All right, well.
Good morning, everyone. We're going to begin the Human Services public hearing for Thursday, March 6th. Hope everyone is well. We'll begin with opening remarks. Any comments from my good co-chair?
We have so many people signed to testify today. I would not want to take any time away from them. So let's go listen to the great people of the state of Connecticut and get going.
Wonderful. And with that, we'll invite up the Commissioner of the Department of Social Services, Andrea Barton-Reeves. Good to see you.
Good morning, forgive me. And I was visiting with some of my former parents from Hark, so it was nice to see them this morning. Appreciate that. All right. So good morning, Chairs Lesser and Gilchrist and Ranking Members Perillo and Case, and distinguished members of the Human Services Committee. I am Andrea Barton-Reeves, Commissioner of the Department of Social Services, and I am very grateful to be here today to speak to you on some of the bills on today's agenda. I know I have many, so I may move through some of them quickly, and I apologize. I can certainly go back at any time to address any of the bills that I may have moved through too quickly. The first is House Bill 7101 is an act establishing a commission to study a Husky for All single payer universal healthcare program. This establishes a commission to seek the advice and direction on the establishment of a Husky for All single payer universal healthcare system. We welcome this commission and we do appreciate the opportunity to explore and research this issue. We look forward to collaborating with those that are on the commission to come to a solution and to actually explore how this might be possible and where the possibilities might lie for improvements in the healthcare payment system in the state of Connecticut. The next is House Bill 7102, an act concerning maternal and infant healthcare. Now, so as we know, this bill requires the Office of Healthcare Strategy in consultation with DSS and DPH to create a strategy to increase the number of birth centers and birthing hospitals particularly in underserved regions of our state that have a high percentage of Medicaid recipients. What we wanted to bring to the committee's attention is that DSS did launch its maternity payment bundle in the beginning of this year, and that coverage also included dollars for doulas within the bundle payment that we provide to providers. And additionally, in January of this year, we did add at the urging of our providers, standalone doula services for members who are not already receiving those services under the maternity bundle amount. The bill, however, to increase the number of doulas and to increase a rate increase and to provide a rate increase is not included in the governor's budget, which would make it infeasible for us to do that in this current biennial and fiscal year as determined by the governor's budget. The next is House Bill 7103, an act concerning the Katie Beckett Working Group recommendations. And for this, I am going to ask one of my team to join me, and that would be Christine Weston, who is the director of the programs. Christine, if you don't mind coming up. And while she makes her way up, this bill does have a number of recommendations regarding those that came out of the Katie Becker Waiver Working Group, which I'm going to ask Christine to speak for more specifically. But the first section increases the maximum age for participants to the waiver to 18. And we actually do support this recommendation, but we just do suggest some clarifying language that's under 18, because once a person turns 18, they do have access to other Husky C coverage and would no longer need to benefit under the waiver, and that would require a waiver amendment under CMS. And so Christine, I'm going to ask you to speak to section 2, if you don't mind.
Of course. Good morning. My name is Christine Weston. I'm the Director of Community Options at the Department of Social Services, which oversees the Katie Beckett waiver. I had the pleasure of being part of the Katie Beckett Working Group the past few months, where we were trying to think of creative ways to better serve the individuals that are waiting for services on the Katie Beckett waiver. They did bring up the concern of having access to resources for people that are waiting for services or not yet met on the program's wait list. So we agree that we could probably build out our website a little better. We do have significant information on eligibility, enrollment. We have a website linked to My Place CT, which is a no wrong door for all LTSS, regardless of payer. So that addresses kind of the request for the private pay. However, the website could be a little bit more robust, and we are committed to evaluating the content on our DSS site. But as for asking for a login and portal for members to check status, that would be a significant lift. But we do plan on building a dashboard with general information on wait lists, application dates, and where people stand. That's been part of the commitment of our transparency and HCBS under the Medicaid Director, Bill Halsey, and myself.
No, don't go anywhere. Okay, thank you, because we have a few more that we're going to walk through and make sure that you're available. So section 3 proposes several recommendations, and those include the creation and dissemination of an informational program brochure. What we're asking here is that it's fine. We're happy to create the brochure. That's not the problem, but that the mandatory dissemination language, we'd like to have that removed and replaced with the requirement to place the brochure on the website. And here's why. We find that when we disseminate information to, let's say, the hundreds of thousands of people that we have who are currently our Medicaid and SNAP recipients, they often go to the website instead of actually using the printed materials that we provide. So in order to make it more available to them, what we find is that it is more efficient and effective for a number of people that we support to let them know that it's available through social media and through the other platforms that we have, and then they visit our site and they know that it's available. So that's the recommendation respectfully that we'd like to make to Section 3 if we can. Section 4 has to do with the wait list to establish, a plan to eliminate the 5-year, I'm not saying it the right way, the 5-year plan to eliminate the wait list for the Katie Beckett waiver. And again, I'm going to ask Christine to speak to this more directly. Well, we certainly are very much open to a plan with actionable steps. We're not sure that there's a need to have it designated with a 5-year timeframe. And in fact, the waiver would need to be amended and approved by CMS in order for us to address any changes, particularly what's proposed in Section 1. But with all waiver amendments, as we know, it'll have to be approved by the Human Services and Appropriations Committees before we send it anywhere. Christine, would you like to add a little bit more about that section, please?
Yeah, so that is all accurate. And I do think, we understand that the wait list is problematic. There's, 300 children that are waiting for services. With Section 1, if we do get to implement that and that moves forward, that will free up a number of slots because we'll be automatically shifting individuals that are taking up a spot they are not mandatorily told to switch to another Medicaid coverage. And this would actually make that move for them under legislation, but we'll have to go through CMS and the amendment process. So that is one way to address it. And again, for the 5-year plan, really, the way we clear wait lists on waivers is greater appropriations, and we are afforded a certain amount of dollars to serve a certain amount of individuals. So we have to work within that appropriation, and we only put new people on through attrition. So that would solve some additional slots with the Section 1 changes. But other than that, we would need appropriations to really clear a wait list.
Thank you. Thank you. Regarding House Bill 7104, an act concerning programs to mitigate the benefit cliffs, our written testimony, which we have in front of you, is quite lengthy, so I'm just going to highlight a few of the sections. We support Section 1 of this bill, which would disregard financial assistance to individuals who are in direct transfer pilot programs, and as well as folks that get stipends as an individual receives as part of their participation in certain job training programs. The reason why we support this so strongly is that there should be, and we believe, many incentives for individuals to gain greater employment and employment skills. But if they are penalized by gaining those skills and receiving even a modest stipend that moves them out of eligibility for Medicaid and SNAP, then it sort of leaves them in a cycle of remaining on Medicaid and SNAP, when really the purpose is for them to become more financially self-sufficient. And this is very much what many of the people want who are participating in these direct pilot transfer programs and in the job training programs. So in order to have a disregard of those payments that they get through those programs, they can remain on benefit and SNAP for a limited period of time while they're in the program, and then move toward more self-sustainability and financial sustainability in their lives. There are a number of studies that have proven that particularly the direct transfer pilot program is quite successful across the country. And these programs are funded through philanthropic dollars and not through state dollars. Where they've been most successful in most states is where states have passed language that looks very similar to what we have here, where they engage in a financial disregard of any monies that they receive through that program in order for it to create a bridge for people to move to greater financial sustainability. The second part of Section 1 seeks to disregard income that an individual would receive for participation in specific job training programs, meaning that we at DSS would not count such stipends as income, which would determine eligibility for SNAP or TFA. And as I mentioned earlier, if an individual is receiving it and then they receive a new source of income, that does reduce the amount of their benefit and could actually potentially cause their benefit to stop altogether. We don't anticipate that this will have any impact fiscally, as there's no new money being asked for this. We just simply would like to have the disregard in place to give those that are engaging in job training and in direct transfer pilot programs an opportunity to really, I think, experience the full benefit of both of those programs without worrying about having to have their benefits cut off or reduced. For House Bill 7105, an act concerning forensic audits conducted by the Department of Social Services. This is a bill that we had introduced last year, and the committee had some questions about it, and we believe and we hope that the manner in which that we've amended it this year answers some of those questions. Essentially, as we know, there is a need to monitor the long-term financial sustainability and viability of a number of long-term care facilities. In our current statute, our ability to do that is quite limited, and it does not include the ability under statute to conduct a forensic audit. So the general intent of these amendments is twofold. One is to prevent or identify serious financial mismanagement at facilities and to promote financial transparency. So that's the second one. And to ensure that the state is made aware very early on, right, as opposed to waiting until an organization has failed financially, that there is a problem in a particular agent, a particular nursing home or a long-term care facility. So under this proposal, ultimately, what we're looking for is that we can be sure that Medicaid funding is being properly managed and it provides for a better safeguard for our residents in the facilities, because they are the ones that experience the worst when there is financial distress that's happening in a long-term care facility. We have seen that a number of long-term care facilities have closed over the last few months, and that is primarily because of fiscal concerns and fiscal unsustainability. Being able to conduct these forensic audits would allow us to act more quickly at earlier signs when we see that there might be some concerns about the financial sustainability of an organization and be able to step in sooner under statutory authority. House Bill number 7106, an act concerning recommendations of an advisory council on wheelchair repair. I may ask one of my staff to join me on this. So who would come on wheelchair repair? Okay, no one? Fatmata is coming. Here we go. So as we know, this bill makes several recommendations regarding Medicaid coverage payments for wheelchairs, and based on the recommendations of the advisory council. We continue to have engagement with various stakeholders, including our own participation on the advisory council, to make improvements in our procedures. The first thing that the bill does is it proposes to add mobility scooters as an additional category to the bills. And it would include but not be limited to prescription and prior authorization requirements, coverage, and reimbursement changes. We understand the addition of mobility scooters to portions of the bill would actually create greater mobility to Medicaid members, but we do have some concerns about the fiscal note because these costs are not included in the governor's budget. Fatmata, would you like to add more with respect to that? Okay, thank you. All right. Secondly, the bill defines emergency repair, and there is a definition with repairs. We do currently provide reimbursement for repairs of medically necessary customized wheelchair and motor scooters when those repairs are performed in person by a repair technician. We would need to conduct some further research to determine the need for different reimbursement mechanisms and rates, so that we can better understand the difference between in-person, hands-on, and remote repair. And reimbursement for remote repairs also carries a fiscal note with it that is not necessarily covered in the governor's budget. So we would have to determine what the costs of that would be as part of our continued research in this area. Additionally, the current Medicaid regulations specify that the delivery and the shipping costs of mobility scooters are not separately billable. So I've skipped over a piece. So let me go back a bit to talk about the mobility scooters. So the proposal to provide transportation, let me go back even a bit further, to an authorized wheelchair or mobility scooter dealer to repair these wheelchairs and mobility scooters by a non-emergency medical transportation contracted broker could have several impacts, but I'd like to say it this way. Our testimony says it one way, but I'd like to say it another. We're not suggesting that those that are drivers for NEMT are not capable of learning how to properly and safely transport someone who uses a wheelchair for mobility. Their wheelchair is broken and then has to be brought to a repair facility in order for that repair to occur. What we're saying is that it's a specialized skill. And so those drivers would have to be trained, because there is a way in which a person whose wheelchair is inoperable needs to be safely secured in a vehicle. And then the wheelchair itself, whether it's operable or inoperable, also needs to be secured in the vehicle. Most of our NEMT drivers are they are transporting individuals, some of whom have disabilities, some of whom do not, but not all of them are necessarily trained with this specific tie down. So what I would recommend and what we would recommend as an agency is that were this to become part of the law, that there be recommendations that that specific training be provided. I'm not sure if we would ask our NEMT provider to do that, or if we could partner with our agency at DDS. But my primary concern, having come from this world, is to make sure that the safety of the person being transported is primary. And so that's really what our testimony should have said. I wanted to come up and say it in a very different way, but that's what we mean. We want the transportation to be as safe as possible. So other provisions of the bill would require coverage for annual preventative maintenance. We don't currently reimburse for this, and the inclusion of this would be an expansion of Medicaid coverage. So we would continue to have to determine what the fiscal impact of this would be if it were included in the bill. Because at this moment, we are providing services under our available appropriations, which have not included this particular coverage. In addition, and now I'll go back to where I was before, current Medicaid regulations specify that delivery and shipping costs are included in the price for the items listed on the fee schedule, and they are not separately billable. So there are some additional concerns that we have about reimbursement for domestic and international shipping, which are listed in our testimony, but we are certainly glad to go back and revisit those very specifically so that we can provide the committee with more detail. We do anticipate, as you've heard me refer over and over again, and I do apologize for that, that the addition of annual preventive maintenance for wheelchairs and mobility scooters will add about $6 million. So that's about $3 million state share. And I do have to emphasize that is our current 50-50 match under Medicaid, understanding that we know very clearly that Medicaid is quite in flux at the federal level. So that means it's a $3 million state share right now under our current share with the federal government. Since we don't cover mobility scooters, this estimate is actually based on the utilization of wheelchairs. So that number may be higher or it may be lower. We're not necessarily sure. And again, there are no appropriations at the moment for the payment of overnight or domestic or express delivery for wheelchairs or mobility scooters at this point in our budget. And lastly, the bill proposes for DSS to inform our Medicaid members using wheelchairs or mobility scooters as of their rights. We are supportive of this, and we can do so even in the absence of legislation. If it's included in the statute, we welcome that. That is not an issue, but we are completely supportive of that. And we continue to try to find ways that we can be supportive to include and improve access and wheelchair access and motor scooter access for our citizens and our Medicaid members. Thank you, Fatmata. I don't know if you'd like to stay. You're welcome to, but I think we're good. Okay, thank you. An act concerning, the next is House Bill 7108, an act concerning autism and intellectual disability. So as we read this bill, it would require extensive planning and reporting on the strategies for altering the eligibility criteria and the delivery of autism services in the state of Connecticut. So as the single Medicaid agency, we understand that our role in this process is quite critical, and we do not take that lightly. What we'd like to do, however, is to work on this definition with our partners at the Department of Developmental Services and believe that decisions that are made with respect to any changes in how intellectual disability and autism are defined and how those services are delivered should be done in partnership with our sister agencies. So that is why we support further evaluation, I'll put it that way, to determine the feasibility of the outcomes of the studies. And we welcome continued guidance and direction from this committee, knowing that program expansion, however, is not in the governor's budget, but we don't believe that that will stop us from continuing to engage in productive conversations with our partner at the Department of Developmental Services. House Bill 7109, which is an act concerning Medicaid coverage for applied behavioral analysis services and implementing certain recommendations of the Transforming Children's Behavioral Health Policy and Planning Committee, which we call the TCB. We do know that Section A requires DDS to increase its rates within available appropriations. What I'd like to note here, and we do have some others that may join me if necessary, that last year, in July of 2024, we did leverage the $7 million of state share of the $14 million that we had to provide rate increases in a comprehensive set of behavioral health codes that were directed towards children's behavioral health needs. And those also included codes that were on the autism spectrum disorder fee schedule, and that those received a bit of a higher increase than the rest of the codes. But at this time, the governor's budget does not contain any additional funding for us to increase those rates, so we don't have the ability to support that part of the bill at this time. The same is true for Section 1A2 of the bill, which would extend coverage for applied behavioral analysis, which I know is ABA services under Husky V, which is the Children's Health Program, which is also known as CHIP. That would expand coverage, as we know, but it also has a cost associated with it of $1.3 million for state share that is not currently in the governor's budget. As for Section 1A3 of the bill, which would provide Medicaid coverage for caregiving training for applied behavioral analysis, I know that this has been a part of discussions with our ABA and our autism provider community for quite some time. If the language does propose that it would provide additional services beyond what is additionally covered, again, this is considered an expansion. And within the governor's currently proposed budget, there are no resources for the expansion. If there is another way in which the caregivers could be covered under our given appropriations right now, we're more than happy to have that discussion. Moving on to Senate Bill 1416, an act expanding long-term options for Medicaid benefits, for Medicaid beneficiaries. We do appreciate the committee's interest and support in rebalancing long-term services and supports in Medicaid. And as you know, it's been a focus of ours for close to 10 years. And with the last rate study and Medicaid analysis that was done, the rebalancing and actually the improvement of the delivery of long-term services and supports was raised up as an area of improvement for the department. So we continue to work on that. And we do know that in the governor's budget, there is a $1 million appropriation that is proposed to allow us to continue that work so that we can improve the delivery of services for long-term services and supports. Currently, I did want to raise to the committee's attention that we do have contracts with 10 not-for-profit agencies that have over 100 contracted staff within the community that serve out this mission. And that we also have collaborative relationships with the Department of Developmental Services, the Department of Mental Health and Addiction Services, and Yukon Health. So we do find, in one key finding of the report that I spoke of, that 70% of our Medicaid members receiving LTSS are doing so at home and in their community, and use only 54% of our budget. So we understand the intent behind this act, and we support continuing to work toward improving long-term services and supports. But where there are additional costs associated with that, we would only be able to do that within our current appropriations. I will move on to Senate Bill 1417. Just excuse me for a moment. Allergies are giving me a tough time this morning. The bill would establish a nursing home workforce standards board to develop recommendations for improvement for nursing home employment and for training and minimum compensation standards necessary to ensure the safety and well-being of nursing home residents and workers. We do support the intent of this bill. We do believe that the nursing homes, as we know, and I just testified earlier, they are the backbone of taking care of our most vulnerable residents, particularly those that are in long-term care facilities for very long periods of time, not just for rehabilitation. So we absolutely support ways in which direct care staff can be better supported in their work environments, particularly in the work that they do, which we know is really critical and important. The bill, however, would also require us to establish the standards board that would make recommendations on employee wages. Notably, we do understand that Medicaid is the largest payer for our nursing homes, and any increases to wages, as we know, would have a direct impact on our budget, resulting in increased costs. While we appreciate the language that's in this section of the bill, we understand that no wage recommendations can be adopted unless there is a concomitant fiscal note associated with it and enough resources to be able to do that. And those are not currently in the governor's budget. For Senate Bill 1415, an act concerning Medicaid and Medicaid funded programs, this would establish an increase in the minimum wage for nursing home staff from of $22.50 effective January 1 of 2026 and increasing to $25 in January 1 of 2027. Our only concern with this shift is the fiscal impact of it that is not included in the governor's budget. So by creating a minimum wage, we do know that this legislation would set a floor for nursing home staff, which is currently unfunded at this time. This is not to say in any way, shape, or form that we undervalue or have no appreciation or do not appreciate the work that nursing home staff do. It's critical, it's important. And we do believe that a fair wage is critical. But in this budget, there, as it currently stands, there is no appropriation in order for us to raise those wages and to set a floor. So at this point, for fiscal reasons, we cannot support the bill. I will now move to Senate Bill 1418, an act reducing barriers to food security. As we know, this bill requires DSS to submit an 1115 waiver to provide Medicaid coverage for food as medicine. We've always supported the idea of food being a critical part of overall health and wellness for our Medicaid members and for Connecticut residents in general. So there are a few reasons why we would ask the committee to reconsider this legislation. First, it means that it would require two sources of funding, the administrative expense to plan and apply for the waiver. And then second, of course, are the actual costs of providing the services under the waivers itself were it to be approved. The last reason, which is not in our testimony, because this just happened this morning or late last evening, depending on when you read the news, and that is that the federal government, under our current HHS secretary, has now said that it will not approve any further health-related social needs waivers, which is really unfortunate news from the federal government at this point. So even if we were to move forward with this, it's very unlikely that the waiver would be approved because they've been very clear with respect to their direction on these waivers. And I'm sorry to be the one to have to bring you that news for those that have not heard it already. Moving to Senate Bill 1419, which is an act that would prohibit Medicaid reimbursement for healthcare providers who include training, repayment, agreement provisions, and contracts with employers. This bill would prohibit Medicaid from providing any reimbursement to healthcare providers who include training, repayment, agreement provisions in their contracts with their employees. So the challenge that we have with this particular Senate bill, respectfully, is that these relationships are between the private employers and the people that they hire. What is given to us in terms of the cost reports that we receive and other ways in which Medicaid dollars are used is for direct patient care. So we really don't have any control over how any not-for-profit or any private entity would use other dollars to pay for training or any other type of support or any other type of training that they would provide to anyone else who is within their employment. So if those are paid for, then they would be paid for, we would believe, with the dollars that the agency has or the private entity has as a whole. And currently, statutorily and regulatorily, we don't have the authority to intervene in those relationships, which are contractual. So at this point, it would be difficult for us to actually adhere to the bill were it to be passed. So now I'm almost done. I'm going to move to Senate Bill 1421, an act concerning Medicaid coverage for obesity treatment. This bill references the coverage of generic forms of GLP-1s, as we know, and there are two generic forms of GLP-1s approved by the FDA to treat type 2 diabetes, and we already cover both of those. There actually are no generic GLP-1s at this time that are FDA approved to treat obesity at this time. So at this point, I'd like to ask the committee if we could place greater emphasis on actually section 2 of this bill, which establishes an advisory committee to study ways in which we can maximize access to cost-effective prescription drugs by the FDA to treat obesity and to make recommendations, not just to the commissioner, but I think generally to our healthcare community. So while the advisory committee or the bill itself doesn't speak to prescription drugs or treat diabetes or reference generics, We really believe that having a wider voice in an advisory committee in this process makes a lot of sense. We would like to learn from other states. We've done some of our own research as an agency with other states, but we also believe, and we've also been in a number of conversations with the Office of the State Comptroller, which manages the state employee health plan, so we can understand how they are also covering different types of drugs for obesity. But there's a lot to be learned from other experts in other states and other providers. So we really would welcome the opportunity to create and develop an advisory committee and then come back with an informed way in which we could provide coverage for GLP-1s that I think would satisfy the need that we have in this state for the coverage for these drugs. Finally, under House Bill 7022, an act promoting equity in Medicaid coverage for fertility healthcare, this bill would require the department to amend the Medicaid state plan to provide Medicaid reimbursement for fertility treatments. Our primary concern here, again, is one that is fiscal. So under our current guidelines, under federal guidance, infertility services or fertility preservation services, they are included within our family planning services. We estimate, however, that with an assumed match of 90%, which can no longer be assumed based on current federal guidelines, and a 50% match, this would result in a $300,000 increase in state fiscal year 2026, an $11.5 million increase in state fiscal year 2027, and a $27.1 million increase in 2028. If there is no match for fertility services, then we estimate those numbers to be quite considerably higher. In fact, we believe they would go up to 2.1 million in state fiscal year 2026, 28.7 million in 2027, and 46.3 million in 2028. In either instance, the numbers are quite significant and the costs would continue to grow as the years go on. So while we anticipate that adding fertility treatment coverage would result in a significant cost of Medicaid expenditures, we're also continue to be concerned with the changes that are happening in Washington. And for that reason, we're really unable to support this particular bill because of the fiscal impact that it may have. So that ends the testimony that I have on the bills that I believe are before the committee today. I do have our senior team with us and many of our subject matter experts to answer any questions that I cannot. So I welcome any questions the committee might have. Thank you for your time.
Thank you, Commissioner. And that certainly was a lot of bills. So thank you
was.
so much for speaking on them.
Sure.
My first question I'll start from the beginning, has to do with the, I forget the title, an act concerning maternal and infant health care.
Yes.
When it comes to the doula care that is covered in the department's maternity bundle,
Yes.
how much money is the reimbursement to the doulas in the maternity bundle?
Yeah. So I am now going to ask Fatmata Williams to come and join me again. We have I think it's about a $2 million budget for our bundle for doulas, but she'll be able to speak more specifically about the rates and where we are right now. Okay.
Thank you, Commissioner. Good morning.
Good morning.
Representatives. I'm Fatmata Williams, Deputy Medicaid Director. So Representative Gilchrist, to your question, the Commissioner is right. We did have $2 million in general, but doulas can get reimbursed up to $1,200 for the entire episode, from the pregnancy all the way to the postpartum period, whether they are participating within the bundle or as independent providers. We allocated $1,200 for now because based on appropriations.
Okay, thank you.
You're welcome.
And you said that's the entire episode is, what is it from?
From the prenatal to the postpartum period, the bundle triggers during the second trimester. So anywhere around there, providers could work with doulas or doulas could independently engage with members if they're enrolled in our medical assistance program network.
Okay, wonderful. Thank you.
You're welcome.
Okay, shifting to another bill, so thank you.
Mhm.
With regards to an act concerning the Katie Beckett Working Group, and want to thank your department for participating. A few folks from DSS participated, and we really appreciate the conversations. I understand the potential issues with a portal, cost wise. Even though I'm not an IT person, but I work for enough nonprofits, I get it that
Yeah.
somehow logging into something costs a lot more than
Yes, it
just
does.
visiting it.
It does.
What I want to flag and hope we can continue the conversation is that the website is one piece of the recommendations that came out. We heard from folks that it's really not clear how you even are eligible. What would be barriers in terms of kind of your income and assets to accessing the program. It would be great for the website to include such things as, other resources for families. So, would love to continue those conversations. But the additional piece that we heard time and again was that, and I know your staff understands this, and so really want to work with you on this. Once folks are on that waiting list, there's just radio silence. And so I really do want to work with the department on some type of system for families to be updated on their status, just a check-in every 6 months,
Mhm.
because families just don't know what's going on.
Right.
And I actually think it will be helpful because some families don't need the services anymore. And so it would be a way to also update that list.
Thank you.
Also with this bill, how long is the amendment process for us to do the under 18?
Well, I'm hesitating because
True.
I knew what it was before
Yeah.
and it's different now. I'll just say that. So generally, we would draft the waiver. We often need a little bit of help to do that because it's a very, very complicated process. So it can take us a few months to draft a waiver, right? It can take 3 months. I'll just use that as sort of the short end. And then we would then bring it, once we have that done, we bring it here. And then once it's approved and the waiver is fine, then we would send it off. A waiver can take 6 months to be approved. It can take up to a year. We are still waiting approval, for example, for our justice involved waiver, which we came before you many, many months ago. Granted, maybe that is a different circumstance because there was obviously an imminent change in administration one way or the other. And we still are awaiting word on that particular waiver. And so there isn't a particular time period. The short end is 6 months, the long end can be a year. It's not a fast process.
Okay.
Yeah.
All right. Thank you. That's helpful to know. And that looks like that's it for me. I'm going to turn it over to the senator. Thank you.
Thank you, Madam Chair, and you caught me a little bit off guard. I thought you had more questions than that. First, just a question about the fertility bill, and I apologize if you asked this question before. Your testimony was, I was a little having trouble following the fertility bill testimony about whether there was, my understanding had been that that family planning carried a 90% reimbursement threshold under current law. I understood from your testimony, though, that either a 50% match or a 0% match was what you were anticipating. And I was surprised to hear that. And I didn't know if you could shed some light about those discrepancies.
Yes. So I'm sorry if I was unclear. There were a lot of numbers that I was reading from too, because it all depends on the service that's being covered. So I'll just go back to my testimony because this really outlines it, I think, pretty clearly. So these are estimates that we had drawn up based on what an assumed match would be. So right now we are getting 90%. So based on our current federal guidelines, that's for fertility preservation services, and then a 50% match. Again, this is assumed on our prenatal, our postpartum, and delivery. So those are the numbers. Those are the categories of coverage that actually I was reading from. And so that's where I was saying that if we had those particular categories of coverage based on what we have now, what we know our federal match to be, if we were to add the reproductive health and infertility treatments as being proposed under the bill, that the additional cost, even with the state share, would be the numbers that I read from. That's what I meant to say. So I apologize if I was unclear.
So you've submitted quite a lot of testimony on quite a lot of bills, and I'm trying to follow everything you're saying, and I'm struggling here. So as I understood your testimony on that, Bill, you suggested that in some areas we might not be eligible for any federal reimbursement, and I just wanted to understand where that would be.
Yes, so that actually is just based on what we're hearing from the federal government right now. I think what I'm trying to do is trying to set some expectations around the ever-moving landscape in Washington. That does not mean that as we sit here today, that any of our federal match dollars and any of our federal match percentages have changed. But as things are changing, I could go back to my desk this afternoon, writing, and I could receive something that says that it changes, like last night we heard, and early this morning, that health-related social need waivers aren't being considered anymore by the feds. So that isn't to say that that's the current state of being, Senator. I think that's what I need to say very clearly. It's not the current state. With our current state, the numbers that I cited, that's what they would look like. Also with the caveat that we don't know whether any of this might go away.
I know that for states that have expanded Medicaid, there are some states that didn't trust the feds and they put in, we're not one of them, but there's some states that put in trigger laws saying if the federal reimbursement rate were to drop, this would not apply.
Right.
As we're, the elephant in the room is what's happening in Washington and how that affects the people of Connecticut and
That's right.
your department and the whole state. And since we don't know what's happening, we get some indications, but there's a lot that's happening and there's a lot that's being litigated in the courts. Would you suggest that as a way to move forward, and otherwise we would be sitting in a state of total paralysis until some sort of normality arrives, would something like a trigger law, if the concern is we think we're eligible for 90% reimbursement or whatever the reimbursement rate is, but we don't know, Congress could change the law, the Department of Health and Human Services could decide that the law does not matter, whatever happens, could we put in some sort of protection that ensures that Connecticut taxpayers are not left holding the bag if the federal government reneges on their commitment to us?
So certainly a trigger law would be one of the tools that we could use to provide some degree of protection if the bill were to pass. The other primary concern that we have, Senator, is that there's no appropriation for it in the governor's budget. So if there were any appropriation over time, I don't know, I'm not part of the negotiations. So let's assume that there was, then a trigger law, I think, is an appropriate way in which to protect the taxpayers of this state. But absent that, and we were to pass it, then we would have the obligation to provide the coverage. And as we sit here today, there is no appropriation in the governor's budget to do that. So it'd be both of those caveats.
Thank you. And I appreciate that.
Yeah.
And if OPM is listening, I'm sure they appreciate your reminder that the governor's budget is the law that you are under. And
Yes.
we have to set our own policies, and we
That's correct.
sometimes agree with the governor and we sometimes disagree with the governor.
Understood.
With regard to the health-related social needs, and obviously that's dispiriting news. I
is.
read what they did slightly differently than you did.
Okay.
So the language that I saw was they definitely rescinded the health-related social needs guidance. They had put out guidance that would create a path forward for those types of waivers.
That's right.
But the replacement doesn't say that they won't consider them. It says CMS will consider states' applications to cover these services and supports on a case-by-case basis to
Yes.
determine whether they satisfy federal requirements for approval. So to my reading, it doesn't say no, but maybe I'm a Pollyanna and maybe you're hearing something that's a little more dire than what I'm reading.
I would not say that you're Pollyanna, Senator. I would say that I'm probably beat down and jaded from what has happened over the last few weeks. And so maybe this is all that it all falls on me. And so I will take full responsibility for my pessimism and apologize if I'm spreading it throughout the hearing. The challenge we were having, and I think why I went with a more conservative approach in reading it, is that all of the descriptors that you just provide, case by case basis, whether it meets the criteria, we don't have any idea what those are, right? There's no guidance as to what those are. So we can spend the money and the resources to file a waiver only to be told, because we don't have any guidance, these don't meet our criteria, because we don't know what the criteria are. So I think I am guilty of reading it much more conservatively, understanding that as a state, we have limited resources when we're putting waivers together. And we would much prefer to use our resources to file waivers that we think have some degree of success with rules that we know that we're working under. So that's my reading.
Thank you. Well, I gotta go to another, actually, so one question on that though, what, and I think you answered, I think Representative Gilchrist asked the question, but I was pulled away. There's a vote in another committee that I'm on. What, do we currently have any waivers that are health-related social needs as defined by the now revoked federal guidance? Is there anything that currently pending that we think might be covered by that?
The only waiver we have pending right now is our justice involved waiver.
But that's
which
not
does
health.
have-
That's
It's
different.
not specific to, it has some components of health-related social needs, but it's not the typical type of waiver, and we're still waiting for approval or some word on that.
We are waiting anxiously with bated breath, and hopefully that will be okay,
Yes.
but we will.
Yes.
I have no, I have no insight and other
I don't
than
either.
general concern.
Right.
So this presents some difficulty. I read your op-ed yesterday in the Hartford Courant about the weight loss coverage, and I know that this has been a source of a lot of discussion and interest in the building. We passed a law 2 years ago requiring coverage of weight loss medications by Medicaid, and the process for it has not gone as I think the legislature anticipated. I did hear, there was a little bit of a discrepancy, a minor discrepancy, but a discrepancy in what your written testimony and what you just told us in your oral testimony. And I just want to clear something for the record, because your written testimony seems to suggest that there are no GLP-1 weight loss medications that have been approved to treat obesity. And I heard in your oral testimony, I heard you say that there were no generic.
Correct.
So I just want to make sure that you weren't, it wasn't the department's position that there are no GLP-1s approved by the FDA to treat obesity.
No.
Okay.
No, there are no I'm talking about the bill, this particular bill as it's currently drafted that asks about the generics. There are no FDA approved generics. So that's what our testimony should reflect. And if I misspoke, then I apologize for that. And
No, you didn't misspeak. I
Okay.
mean, I don't think you misspoke.
Okay.
What your testimony said, your oral testimony, what you just told us,
Yeah.
was specific to generics. The
Right.
written testimony, I didn't think was specific to generics. It said sort of,
Oh,
as I understood it, it categorically said that there are no GLP-1 weight loss medications approved to treat obesity. I think that's just wrong, but
Right.
it doesn't sound like that's what you intended to say. So,
No, it's not. So
Okay.
we will make that correction.
Okay,
Thank
great.
you. Yeah.
And then, the written testimony also, one of the questions, when we passed the legislation, it was the clear intent of the legislature to cover GLP-1 drugs. And we had thought we had negotiated that with the administration. We thought that benefit would come to Medicaid patients. We knew that there was going to be some difficulty in paying for it, but we thought we had figured out how to do that and had a plan to do that, or with at least the kernel of the plan to do that. And obviously that has not happened. At least with regard to weight loss treatment. I know that folks have access now on the basis of diabetes and cardiovascular risk, and under federal law, I'm hopeful that the department will soon provide it for sleep apnea, but weight loss treatment remains elusive under that, despite that promise. So understanding that you are nevertheless mandated by the federal government to cover GLP-1s as FDA approved medications for non-weight loss purposes.
Right.
This bill is also trying to, ask the federal government, petition the federal government to come up with innovative solutions to allow us to price those accordingly. And I'd love to, I know you and I have talked offline about this, would love to
Yeah.
have some serious deep conversations internally and with our federal partners about options that are available to us. I saw some testimony from the department, with your name on it, against some of the ideas that we were floating. And I think I would just ask that in the interest of trying to figure out how we can do this, that the department not oppose our efforts to try to identify cost containment, because the plain language of the law currently is that you need to cover this stuff. That's my reading. You may disagree, but but testifying against our cost containment efforts, I thought was disappointing and sort of makes it harder to figure out what we're going to do on the way forward. That was in your written testimony. I didn't hear you say that here today, but that was my concern there.
Understood.
I I don't know, there was a question there, but if
That's-
you would like to respond, you certainly may.
Oh, all right. Thank you, Senator. I appreciate your feedback and your observations. I will go back and speak with our team around our testimony so that I can, obviously, I read it, but I will reread it so that I can have a better understanding of the concerns that you've raised. And again, I know I mentioned this in my testimony today. I really am very, very open and willing to continue to have the establishment of the advisory committee. I think that having a wider breadth and depth of understanding of how other states may have, we're in the minority. There are a minority of states that have been able to do this. Some have and have had to stop it. And that's part of the concern that we had. You and I have spoken, offline with respect to this issue, and that one of my primary concerns was sustainability and cost sustainability. And I'll offer this, this apology publicly, that I think that I personally and our department could have done a better job of communicating what the challenges were that we were facing and try to work together more collaboratively. So I am stating publicly that I would like to have that happen, very much so that we are not just struggling with this on our own, and that we can have some more dialogue with other states who may also be contemplating the same degree of coverage, whether they have a statute or not, and find out ways that we can move forward together. So I thank you for the ability to have that dialogue.
Thank you, Commissioner. The Nursing Home Workplace Standards Board, I appreciate the department's support of the legislation, and I understand
Yeah.
it's a complicated thing to stand up and requires some thought. And I obviously this is an issue that touches on multiple agencies, and I've talked to some of your sister agencies who have thoughts about how to implement it. But it does seem, just because you are the main payer, that DSS has a central role here, just because of the centrality. I know that it's tricky, but I would love to, I want to thank you for your testimony and conceptual support, and recognize that there's some work that has to be done before we can
Yes.
stand that up. With regard to the TRAP law bill about Medicaid funding for institutions that require repayment, I understand that there can't be an agency to solve all issues, but I think the issue that we're trying to get at here is ensuring that the taxpayer funds are not being used to trap employees in exploitative or abusive practices that are, to my mind, already prohibited by the law. And so, the hook that we have obviously is access to Medicaid funds. And so I just don't know if you have thoughts about how to, with that hook available, if there's a way. I don't know if there's a sister agency that should have a role here, but it seems that DSS has some part to play, and I'm just not sure if you have specific thoughts about how to do that.
I understand. And honestly, Senator, when we read this bill, we certainly understood the intent, but we're really struggling with our role as the payer, and sometimes acting in a role of somewhat of oversight with our sister agency, EPA. What role would be appropriate for us to play? So I will say this: I'm happy to take this back, because I understand what it is that we're trying to avoid having to happen, because people should have mobility. They should be able to move to different jobs and not necessarily, as we say, be trapped in a particular employment circumstance. And I think we all appreciate that and would want to have that autonomy for ourselves. So if you don't mind, I'd like to take that back to the agency, and maybe you and I can have further discussion around that.
That would be great. Thank you.
Okay.
And I, now, with respect to the closure of long-term facilities, I certainly support the department's goal of getting more information about troubled nursing home chains and what we can do to, what information we can have. There've been closures across the industry, but there's also been concentrated in a few different chains and in a few different geographical areas. And I know that I've struggled to understand the state's policy with regard to nursing homes, because on the one hand, we just had a bill to lift the moratorium in some respects on new nursing homes. On the other hand, we're still seeking to rebalance and reduce the number of nursing home beds, it feels like. And we're seeing enormous disruption to our residents. I've heard from folks in Waterbury. We lost a home in Middletown that was very disruptive. There's now an issue in Bristol. So this is an issue around the state, Manchester a few years ago. So, it does seem quite disruptive, and I certainly support any effort to get more information about nursing home health. But I'm just curious, how do we sort of figure out what the state's
Yeah.
policy is here? How do we mitigate harms that are concentrated in particular communities? I know there are, and then there's the particular issue when there's a nursing home chain that's failing. We seem to have residents go from one home and then experience the trauma of being rehoused to a second home, and then have this happen again to them. These are folks who are the most vulnerable people in the state of Connecticut, who are now being ping-ponged around the state, like they're being warehoused somewhere. And I just don't, to me, this seems like this is not something, I know that maybe data is the answer, but I feel like we could manage this better. And I don't, even in this purview I have as chair of this committee, I don't have a great sense of what the state's policy is right now.
So thank you for that. I would also say that it's a conversation that we should be having with Commissioner Giuttani as well, because these decisions are ones that we make together as state agencies, because obviously her role with respect to nursing homes is security, safety, and ours as the payer. But that division is really one that I think it's an important one, but it's not strictly administrative. Our primary goal is to make sure that all of the residents in the nursing homes get quality care, and that the dollars that taxpayers pay through, whether it be federally through Medicaid or through state dollars, are used appropriately. So to answer your question about rebalancing, we'll go there. Our prior rebalancing plan assumed that the numbers of nursing homes that we had would have variations in their population, right, based on the number of people that are there and their ages and morbidity and mortality data that we have. That we don't do this. There's another vendor that we work with, that an actuary that does this work for us, that we could determine how many homes we would need in different parts of the state at different times. What has changed this rebalancing is the financial instability and specific changes with one of our largest providers. So that meant that a number of homes closed much more quickly than had been anticipated under what was our previous plan for rebalancing. So what you're observing is twofold, one of which is the rapid closure of those homes because of financial instability. And then the second part of that is the ability for each person through the ombudsman and through Money Follows the Person to make a choice as to where they can go. So we can, through the ombudsman and through Money Follows the Person, we can talk to a specific resident and say to them, you can move to whichever home you choose, right? Home A, B, or C within a 50-mile radius, closer to your family. Those are all personal choices that are left to the resident. But as homes continue to fail, then the challenge we've been having is we move to a home that then appears to be financially viable. That home then has a challenge, because if it's within one particular chain of home, then you may have staff that may have concerns about remaining with the chain. They may move somewhere else. So we're constantly monitoring that. And so as that home proves to not be the safest place for people to go, then a determination is made as to whether or not that can stay open. And the unfortunate product of that is that people do move multiple times. We do everything in our power to try to avoid that. We really do. And these decisions are very difficult and they're very complicated. And I know you're probably very much aware of the latest hearing that was had in Bristol. We heard very clearly the objections raised to closing those homes. But part of what would happen with the forensic audit is that we would be able to get to these issues sooner. There's really no statutory regulatory authority that allows us to audit a private entity just on our own because we have a concern about what might be happening with that entity. We often learn that an entity is in trouble when we hear from their staff. Their staff may say, my health insurance card is being rejected. I filed for workers' compensation and there's a problem. Or a vendor may call. They'll either call the Department of Public Health or they'll call us and say, I haven't been paid in a number of months. And it's under those circumstances, then we learn that there might be a problem. What we're asking for is when we hear of those to have more authority than to just call the particular agency or nursing home or long-term care facility. I just don't want to focus on nursing homes. I just want to say long-term care facilities, to say, we're hearing these concerns. What's going on? Send us what you have. We can only ask them for specific things that we have the authority to ask for under Medicaid. But often we need more information than that to really understand what's going on. How are you paying your vendors? Why is this vendor calling us to tell us that they haven't been paid in whatever number of months there are? That's what the forensic audit would allow us to do, to intervene much more quickly and sooner, so that where stabilization can occur, we can make that happen to avoid the very outcome, Senator, that you outlined. It is a very difficult circumstance for us to manage. I appreciate that. I think if Commissioner Jatani were here, she'd have something to add as well, but that's what I can add today in terms of response to that. That is the plan, is that rebalancing has changed because of the closures in these nursing homes. So we are now trying to manage that as best we can.
So how many, at this point,
Yeah.
given that the rebalancing has been a policy of the state government, how many more nursing homes is the state government hoping will happen? How many more beds are we hoping to reduce, or have we already achieved those rebalancing?
We're pretty close to rebalancing right now, and I know that Nicole Godburn is here, so I may ask Nicole to come. We're pretty close to rebalancing, and we consider rebalancing having enough beds in the aggregate for the number of people who we believe actuarially will need those beds over time. And then drilling down even further, it's how many beds do we need in different geographic areas within a 50-mile radius for people who are living in particular geographic regions. But our fiscal director is here for long-term care, so that's not your title. I never get it right, but here's Nicole Godburn. Yes.
Hi, good afternoon, I believe. Nicole Godburn, Director of Reimbursement and Certificate of Need with Medicaid DSS. So just to also piggyback on what the commissioner was talking about, part of the change in our, because we have had a long-term right sizing rebalancing program here in the state for many, many years. Part of the other thing that happened was COVID. We had a pandemic. So everything that we knew to be true leading up to that point in our right sizing rebalancing plans, all of a sudden was exploded and blown up when the pandemic happened. We now saw sections of our state that were experiencing closures, bed delicenses. We've seen sections of our state where we've had completely new ownership structures coming into the state. So we have nursing homes that we knew the owners and operators for many years, and now there's a new entity running it, and they may be running that organization very differently than the previous owners had. So all the things the commissioner said, plus the pandemic happened, and it's completely shifted our entire industry when it comes to nursing homes. So we're having to relearn that, and we're having to take a relook at our right sizing rebalancing plans. We're having to incorporate and look at new tools that we can have. I talked to the ombudsman just last night. I mean, our sister agencies were constantly speaking with each other on ways that we can address and support the industry. Currently, right now, we have about 3,000 excess beds statewide. The ideal spot to have occupancy is you want to be between that 90% to 96% occupancy ratio. We're currently also working with our actuarial firm to dust off our right sizing rebalancing plan, just to make sure that we still have the right percentages at that 90 to 96%. Statewide occupancy, we're at about 87% right now. So when you look at it topically from that direction, it looks okay. But then when you start to drill down into sections of the state, there's areas of the state where it's getting very compressed and very tight, especially in our rural areas of the state. So that's why we are in our other bill asking for an exception to the moratorium, so we can be nimble and adjust as needed. But we are doing that work, but the ideal statewide percentage would be between that 90 to 96% occupancy.
Thank you. And 90 to 96% is a helpful target to understand, but we are, the demographics of the state are changing pretty dramatically, and the bulk of the baby boom generation is not, they're still quite nimble and spry and not anywhere near nursing homes, and so obviously we can look at longitudinal projections, and it's not hard to see that no matter how much we do to support home and community-based programs, we're going to have folks who are going to need nursing home level of care. So how, if we were to keep the exact number of beds we have right now, I assume that number will go up over the next few years in terms of the percentage will go up. I mean, the percentage of occupancy will go up because just the sheer number of folks needing supports. Well, am I wrong, or do you think we can support that in the community?
No, you're not wrong, Senator. And that's one of the reasons why we asked for the moratorium to be lifted, because we can see that trend coming. And so that's what we're working on right now. As Nicole had said, we do have actuaries that do this work for us, who determine, just like you said, based on the number of people, some are healthy and spry and it'll be fine. My grandfather's still taking 3 mile walks when he was 96 years old with a 1-year nursing home. But that's not true for a number of people. So the actuarial analysis will allow us to determine what those numbers should be. But as we know, just as we said, we have 3,000 beds, as Nicole had said, across the state, but it's much tighter in some of our geographic regions. We need to have that moratorium lifted so that we can create more bed capacity, because we know that this trend is coming.
Well, we already voted to do that, so we're,
Okay,
we
thank
are, whether the full legislature agrees with us, TBD, but this committee has already agreed with you on that. I just, still, I'm hearing from staff and from families of patients for homes that are currently threatened with closure. I just heard from one today. And it wasn't clear to me what it was we were trying to do. Like, we were trying to go down on the numbers, or are we concerned about a rapidly aging population? We need to go up. Like, and so because we seem to be going in different directions, I am hardly an expert on this, and you are, and that's great. I was just hoping to communicate to them what it is the state's policy is here. Are we trying to keep capacity? I know we have that 90 to 96% goal, but that's a moving target depending on the numbers each year. And so
yes, Senator, we are trying to keep capacity. The rapid closure of these homes was not expected. And so that really has changed the direction and the manner in which we've been working with the right sizing and rebalancing. And as Nicole said, in addition to COVID, that really has changed the landscape completely. So in some of these instances where, let's say, there are a number of homes that are owned by a single operator, we really tried our best to keep some of those homes open, maybe by assumption of ownership, assumption of management, and that closure really, and this is very true, it's really the last resort. And that there are a number of steps that occur before the closure of a nursing home is determined to be the only viable option. But I'm happy, Senator, to have this discussion with you offline. Maybe we can have Nicole and the DPH commissioner. We can speak more about the concerns that you're hearing from your constituents about right sizing and rebalancing, speak in more detail about how we actually engage in that analysis, and perhaps provide you more support as you're talking with your constituents.
one last question, and I hear
Certainly.
relief from my fellow committee members and
Okay,
perhaps from you. But on regard with no, this is for still, no,
Okay.
you're still on.
All right.
Okay, cool. Sorry.
sorry.
So with that issue where a nursing home chain is in trouble, and we know that they're in trouble, we can hear from their employees that they're not getting health care or whatever else, but they're not paying their taxes. The air is, there's a whiff of trouble in the air. I heard what you said, and I see the ombuds here as well, and I certainly know her perspective. I know that the residents have the right to go to not be kept within that one troubled chain. They can go anywhere, but we don't have state minders there with the residents 24/7. And I know, and and I think the folks out there know, that they may have that right, and we may be, the ombuds office may be advising them of that right, but somehow, through some mechanism that is not clear to me, they always seem to wind up, or a lot of them seem to wind up at the same chain. And so if the chain is troubled and they're in one home and then they stay within the same chain, that may be great for propping up that nursing home's chain's finances. But it seems to me that we've just doubled down on the risk to the patient, because the client is more likely, if they're in a troubled chain, to be affected by multiple nursing home closures, which to me seems like the coolest possible thing we could do to someone in that, and if they're more than just a source of revenue for the chain, if they're a real person who has needs and healthcare needs, should we consider preventing them from staying within the chain? Should we consider where the state is helping them find a safer location, or give them advice about what's the best option for them? Obviously, I want to make sure that they have agency and they're able with their family to make the best decision for them. But right now, it feels like they're being exploited for the health of troubled chains.
I understand the concerns, Senator. I don't think I'm really the best person to speak to that. I don't know if you mind inviting the ombudsman to come and speak to that at some point. but I can't.
She's got her own time. We'll
Okay,
get
that's
to her in a
fine.
minute.
I would say, Senator, in response, you're right. We can't be there all the time to monitor or be in the places where conversations might be had with residents. But there are times when residents are fully informed about the state of affairs in a particular home that they're in or a chain of homes that they're in. And they make the decision to stay because they know the staff. They know that particular chain. They may know the owner or the management of the chain. And even though they understand the risk that's associated with it, and sometimes they understand it very clearly, they choose to make that decision. And so I don't know what other kinds of influences they may have or the conversations that they may be having. I'm not suggesting that what you're saying might not be occurring, but I don't know whether or not it is or not. So all I can do, and I will not speak for the ombudsman because I'm sure she and her team do the best that they can to make sure that everyone is given all of the information that they need to make an informed decision. But now that she's hearing the concern today, I'm sure that she and I will be talking further about what we can do to make sure that there's even more transparency, even greater transparency when those discussions are had with people who need to move from their home to another.
Great. Thank you very much.
You're
And,
welcome.
I'll just in closing just say, I'm not gonna ask questions about it, but look forward to working with you on maternity bill, the
Yep.
Katie Beckett bill, and of course, we've got a lot of folks here who are really interested in seeing better care for folks with wheelchairs.
Yes.
So thank you very
so
much.
Appreciate that.
Oh, okay. Sorry about that. Oh, yep. Representative D'Amico does have some questions.
Thank you, Madam Chair. So thank you, Commissioner, for coming.
Wait, I think I turned yours off. I'm so sorry.
Thank you, Madam Chair. Thank you, Commissioner. Appreciate all of your good testimony. So I want to turn your attention to House Bill 7106, I believe it is. Yeah, House Bill 7106, an act concerning recommendations of an advisory council on wheelchair repair. So I appreciate your thoughtful testimony, written testimony on this. But it struck me at the very end of the section in your testimony where you, on this particular bill, you said that DSS continues to support ways to improve access to wheelchair repairs for Medicaid recipients. Which is great, which is a great sentiment, but almost every section of your testimony talks about the financial burden that these recommendations or these proposals would have. So I guess my question is DSS really committed to improving wheelchair repairs and wheelchair access for people with disabilities, or aren't you? Because well, anyhow, I'll just leave it at that.
So thank you for your question. And I understand from the testimony that you have in front of you, it appears that we're not, but we are. And my challenge really is, I'm being very transparent about this as it is in our testimony, our challenge really is fiscal. So what, if there are additional resources in the budget and the governor's budget and the Medicaid budget for us to address some of the needs of those who are in wheelchairs and motor scooters, we are happy to do that. So I would say, yes, of course, we're supportive, but we do have significant fiscal constraints. Happy to continue to work on ways that we can meet those needs that are within our available appropriations, but I don't have any additional resources at the moment, but I can certainly revisit what we can do.
I would appreciate if you could
Sure.
revisit. Yes, thank you.
Yes,
Appreciate
okay.
you saying that.
Yes.
Thank you. Thank you, Madam Chair. Thank you, Commissioner.
Thank you, Representative. Yes, Representative Fortier.
Thank you, Madam Chair, and thank you to the Commissioner, as always, for coming and giving us such lengthy and definitely thoughtful testimony on each of our bills. As you know, I'm representing part of Bristol, and we're in the process, that CON process, 2 nursing homes closing, part of that chain that has been referred to, I think, prior by the Senator. I'm gonna try not to, express all the anger and frustration I have, not directed to you at all, but to this situation. Um, is the bill before us today about forensic audits really going to be able to help stop this in the future? I know that's a big question and it's
It is.
open-ended, but I just don't want other communities of folks in nursing homes to have to go through this again. And I understand, you know, last night's rain could have flooded a facility and folks are gonna have to move on an emergency basis. But this, what's happening in Bristol, this chain is preventable in the sense that, you talk about financial concerns or financial issues. I mean, I'm gonna call it mismanagement. These companies, this particular company is, just not doing what they're supposed to with the public trust of taking taxpayer dollars and providing care for people. They're just not doing it, and it's just beyond appalling.
So I think your question was whether it would stop it from happening, right? And my answer to that is it at least gives us more of a fighting chance than we have right now. So I couldn't sit here and I would never, in all honesty, sit here and tell you it's going to guarantee that it will never happen again. But it allows us to ask them and to demand by statute, greater transparency and more access to fiscal and financial records than we have right now, which are just limited to Medicaid. So we can only ask for the dollars, we can only ask for records that are related to Medicaid. But as we know, there are also folks that are in nursing homes that are paying for this privately. There are other kinds of commercial payers that covers. There are long-term insurance coverage that people have. And so this would allow us really to be able to get more of a totality of the circumstances earlier on. And that's just not a power that we have that we currently have. If we had, if we had it earlier, then even if we saw it in one home that's in a chain, let's just use that as an example, then it would raise concerns about what's happening in other parts of that chain. We would then have the ability to ask for all of those other records too, not just in the one home that let's say that the employees are complaining about. It would give us the ability to look across the board and say, give us everything so we can see what's going on. And if there's a pattern that's associated with that, then we'd be able to intervene sooner. That's really what this bill would allow us to do. And so from that earlier intervention, then that outcome might very well be that some homes don't have to close, or we can find another owner, or we can find another manager sooner and not be behind the process and more ahead of it.
Because again, would you say that one of the issues right now with the Bristol situation is that the financial situation is so bad that owners are not interested in purchasing these facilities?
So it's challenging for me to have to know all of the circumstances behind that, but I would say that given the current financial situation, that it may be less attractive to some buyers who may have different criteria for the circumstances under which they would want to assume the ownership of a home. Some have, let's be honest about it. Some have said, even under the circumstances, we are interested in assuming ownership or management of particular homes, and we welcome them because they are good providers. We know their reputation, and that made sense for us to do that. And it also depends on the quality of the putative owner or manager that steps forward too, because we are, and again, I wish the DPH commissioner were here. She would say that our primary concern is that whoever may assume that ownership and management has the capability to take care of the residents and to maintain the home in good order. It doesn't make sense to have someone who may have the fiscal ability to keep it going, let's say pay the staff and pay the vendors, but not deliver good care. So we're looking for the entirety of that. So those that have assumed ownership of, we know them, they've been in the news, or they've assumed ownership of some of these homes, they meet that criteria of being able to manage them well, have a reputation for doing that, and have the fiscal security to make sure that they can do that in the long run. Some that may approach us may not always meet that criteria. So that's not always the case in every circumstance.
Okay. And just one follow-up question on the bed moratorium
Yes.
issue, which I know that bill isn't before us today, but I wasn't able to ask you questions when it
Sure.
was.
Okay.
Again, just as an example, if the two facilities in Bristol were to close, completely close with no new owner coming forward, would the moratorium bill, if it succeeds, allow the possibility of an owner taking over that physical building that exists, that's sitting there empty, and open a new nursing home there, if in your and public health's judgment,
Mhm.
that would be a good thing at
Yeah.
some time in the future?
I'm gonna ask Nicole to join me again because they're actually two
Thank you.
different things and she's always really good at correcting me. So I just, I live in a wonderful feedback loop with Nicole, so it's great. But they're really two different things. So the ability to take over a home that has been closed requires a certificate of need and it requires, sent by a new owner, an entirely new approval process, right?
No,
They have to
and
come to
I'm-
us from the beginning.
I would understand that. I
Right.
guess I'm just talking about the idea that beds are beds and, those are, again,
Yeah.
in a presumption that they both close this
Yeah.
year. We've got an empty building sitting there and I'm just looking, for that possibility in the future,
Right.
because I'm looking at my Bristol community, which
Yes.
has such a high percentage of folks over 65
Mhm.
and that population growing, as stated earlier. To have, we're a community of 60,000 people and we literally do have a higher percentage than the state of people over 65.
Right.
And the loss of beds there in our community, I see as a problem going forward, not just the current problem of the residents that are there and all the nightmare and trauma that that's causing.
So once the nursing home closes, those beds are delicensed.
That's what I'm
That's
talking
what I'm
about.
saying. So if an owner came in and then said, well, I'm interested in reopening these homes, then those beds are basically taken out of circulation. So we would need to lift the moratorium in order for those beds to be filled
Correct.
again, right? So we'd have to do that. And this would allow us to do that. So go ahead, Nicole, sorry.
The commissioner is completely correct. Once the delicensure on the Department of Public Health end happens, and then through the exception to the moratorium statute, if another operator came in and said, I'm interested in purchasing the Bristol property, turning it back into a nursing home, they would have to then go through the process of, we would do a review of the moratorium, the exception to the moratorium statute, look at area population, look at percentage. Department of Public Health has a very strong role in the process of the new operator coming in, making sure that they would be a good operator, that they would meet
Right.
all of that criteria. Our agencies work very closely. We would strategize and then lean into, if all the boxes were checked, then reopening the property.
Mhm.
But right now, unfortunately, to the commissioner's point, because we have the moratorium in place, all of that conversation would not be allowed to even happen.
No,
But
and I understand that. I'm just
Yeah.
looking to the future. If no buyer comes forward in the next few months, I'm looking at what is that next step and that possibility. I mean, I'm in strong support for lifting that moratorium for this reason. Besides the general problem statewide. So thank you both.
Thank you. So, Reporter, I think the last thing I will add regarding potential or putative owners, not just in your district, but in others, there have been circumstances under which your fellow legislators have identified possible owners. We always have conversations with those owners to assess their interests in the property. We're very transparent with them regarding the circumstances under which the home is closing and give them an opportunity to fully assess whether or not they'd like to take the opportunity to assume ownership of the home. So and I say this to say, if that is the situation in Bristol, those conversations have been had before, but to my knowledge, we've not had any owners that have stepped forward or been identified as
Yeah,
possibly
and I certainly
interested.
don't have any.
Okay,
I'm
I understand.
praying, but
Yes.
it's not happening yet. Thank you. Thank you, Richard.
Thank you. I know we're going long. I do have two more questions. To the wheelchair recommendations, Bill.
Yes.
It was my understanding, so the senator and I do not serve on that council.
Mhm.
And it was my understanding that the scooters were already covered, and now I'm confused by the testimony. Are
Okay.
scooters, mobility scooters not covered by Medicaid?
They are, let me get some help.
Okay.
Okay. Who can help me answer this question? Because I don't want to answer it incorrectly. That's why. I
I
do know the answer,
appreciate
but I
that.
don't want to answer it incorrectly. Thank you.
Hi,
Hello.
I'm Fatmata Williams again. They're covered by Medicaid.
Okay.
It's all based on medical necessity.
Okay, wonderful. Just to get that cleared up, thank you.
Mm-hmm.
And then next and final, hopefully, questions are about the fertility bill.
Yes.
Did you say earlier that preservation is already covered by Medicaid?
It is based on medical
Necessity.
necessity.
That's
Okay.
right. That's what I thought.
Thank you. And then last year, when we heard this bill, it was a different version. It was more expansive.
Mhm.
But the fiscal note you all had come up with included the cost of pregnancy-related care and the potential child that resulted from the pregnancy in, as they continued to grow. Does this fiscal note include those two pieces? And if so, can you break it out for us and send me a follow-up?
Yes, I can do that.
Okay, that'd be
Yes.
fantastic.
Yes.
Thank you. Okay, I don't see any other questions. Thank you so much for your testimony and your time.
Thank you. Thank you to the committee.
All right, we are going to go to number one on our speaker order. We will hear from other public officials in a bit, but we have some folks with accommodations. And so we're going to hear from Maureen Amiralt.
Thank you, Representative Gilchrist and members of the committee. My name is Maureen Amiro, and I am a customer of New Motion. I have been serving as co-chair to the Wheelchair Repair Advisory Council, but today I am speaking to you as a wheelchair user and advocate. As an advocate, I would say two noticeable deficiencies within the current law is that people don't know about the law and they don't know to whom to go to when they have a complaint, and also that there's no enforcement with the law. As far as a consumer, I would just say that I have seen very little difference with repairs. I had a repair issue in August, and it was clear to me that there was no intention of meeting the 10-day requirement. They did not offer me the option to go and shop. I mean, at home, they wanted me to go and shop. I had to insist on them coming to my home. And it took 4 business days for them to come to my home, and then another 4 business days just to call my doctor for the prescription. The repair eventually got tied up with insurance, which makes it difficult to track, but that's okay because I had another repair issue that came up in September in which my wheelchair was continually shutting down. It wasn't a big deal at first because I would just turn it back on. It was fine. But by October, the chair was shutting down several times a day, and sometimes I could not get it restarted. I was stranded so many times, both in and out of my home. I was relying on friends and family and sometimes strangers to assist me to get my chair back home and back into my house. And for whatever reason, it wasn't explained to me. New Motion did not want to process this as a separate repair. And so they wanted to use a remote tech to talk to my friends or family members and walk them through the process of pulling off the back panel and locating and securing the wire that was loose. This process took over 2 hours every time we did it. And it just a couple of days I was completely bedbound because the chair wouldn't work. It took to for my 80-year-old uncle was crawling on the floor of a restaurant to try to get my chair up and running when New Motion finally agreed to send a tech to my home, and the tech came out and same day was able to assess and fix the chair. So this whole process for a month that went on for a month was so unnecessary. I worry about what's going on with other people. The recurring sentiment at the June bill signing was that we're not done, and I thank you for recognizing this by bringing forth HB 7601, 7106. Anyway, 7106. And I'm just worried about the compliance levels that are being reported by New Motion and NSM, especially New Motion. I'm concerned with the staffing levels that they are reporting, and I'm concerned by the fact that neither company will communicate to their customers what rights that they have under Connecticut state law. We need a stronger and more comprehensive law to hold them to account, and I support HB 7106 in its entirety, and I hope that you will as well. Thank you.
Thank you. Thank you so much, Maureen. Thank you for being here and for your work. Anyone have questions? Yes, Representative.
Thank you, Madam Chair. Thank you for not cutting off my microphone this time. Thank you. So I wanted to thank, I wanted to start by thanking the chairs of this committee and the leadership of this committee for bringing forward the legislation that was proposed last year that resulted in the Wheelchair Repair Advisory Council, which you, Maureen, so ably have contributed to. So I want to thank the chairs, but I did have a question for you, Maureen. Well, a couple of things. First of all, I noticed in the testimony that was submitted today that there were several pieces of testimony from persons who use wheelchairs attesting to the long delays in getting repairs to their wheelchairs. So I think that substantiates what you had said just now in your testimony. So I'm a little bit confused as I read the bill, Section 5. Starting at line 158, it having to do with timely repair and this 10-day period for repairs. So could you explain to me what the advisory council discussed, and then what the advisory council recommended, and if that recommendation is reflected in the bill that's in front of us today?
Yes, and I also would like to thank this committee for their work on this bill, the law, and to get the advisory council started. As far as the 10-day requirement, there was some question about what the requirement was, but in order to have a working advisory council, we agreed on the definition that the 10-day requirement starts with the initial call for a request for repair. And the time clock stops for getting prior authorization from insurance companies, and that is for mostly Medicare. Medicaid does not require prior authorization anymore. And also when receiving parts, not ordering, but the time that it takes to receive parts, the clock is also stopped, because these things are out of the control of the wheelchair companies. So we don't want to penalize them for something that's out of their control. But it's 10 business days from the initial call to the actual repair.
So this legislation in front of us, in simple terms, says that the 10-day period does not include time that's spent waiting for authorization as well as waiting for parts to arrive.
Correct.
Okay.
And it goes without saying that if there's difficulty scheduling any appointments because of the wheelchair user, that's obviously would not reflect against the 10 days.
So would you be able to offer to the committee an explanation as to why we are seeing, we still a year later, after all this discussion and, you know, everyone around the table talking, you know, with the cooperation of the industry and advocates and wheelchair users, why are we still hearing about, really egregiously long wait times for people to get, their wheelchairs repaired?
I think this came up in the task force last year, which I was not part of, but I watched every single meeting, and it came up back then. It's coming up still today in the advisory council. And I think it boils down to staffing levels. The companies just don't have the staff to support our needs as wheelchair users and to support repairs. There are about 5,000 wheelchair users in Connecticut, and I don't think they have the staff to support that. The most recent numbers we received, NSM National Seating and Mobility has about 17 techs, and New Motion is reporting 7. So and they are trying to hire 2 more. So they're just deficient in staffing. And I would also say staffing in their office, their support staff in the office to help move the repair along.
So just to conclude, you are recommending that this committee approve House Bill 7106?
Yes,
And the
please.
recommendations that are what is proposed will hopefully improve, make an improvement
Yes,
for your community.
yes.
Yeah. Okay. Thank you very much. I appreciate it.
Thank you very much.
Thank you. Thank you, Madam Chair.
All right, thank you so much. I don't see any other hands. Thank you so much for being here. Next, we will hear from Mary Ann Langdon. There she is. Hello. That's totally fine. You just have to push the button and it'll turn on red. Thank you.
Good afternoon. Patty will read my testimony.
Marianne says, "Good afternoon, Patty." Hello, I'm Patty. Press it off again.
Okay.
I'm new. Thank you. Hello, Senator Lesser, Representative Gilchrist, distinguished members of the committee. My name is Marianne Langton, and I live in West Hartford. My personal assistant, Patty Ellis from Windsor, will be reading my testimony. I am in support of Bill number 7106, an act concerning recommendations of the Advisory Council on Wheelchair Repairs. I am pleased to learn that motorized scooters were incorporated into the bill. Also, I am delighted that emergency repairs were written into this bill.
Yeah.
Power wheelchairs and motorized scooters are an essential independent living adaptation. And they support people with disabilities, including myself, to have independence and control over our own lives. I think of my wheelchair as being an extension of my body because it has enabled me to lead an active life within my town, state, and even nationally. I would recommend stronger language regarding repairs because of the following example. In mid-July, my personal assistant drove me for an in-shop appointment at New Motion since my recharger adapter did not work. 2 weeks went by without any communication whatsoever from New Motion. So I called them and was told that my doctor did not send his approval for the repair. I called the doctor and was told that they sent it. After I followed up with New Motion, they began telling me that my insurance was never approved either. Who do I believe? I went to New Motion in early August when my parts came in to learn that the incorrect size was ordered by them. This meant that I had to begin the process over again with prior authorizations from my doctor and insurance. I expressed my frustration to the technician, and he said that he has grown numb to hearing complaints from the people with disabilities, which told me he was tired of dealing with us. My part finally came in at the end of August. The impact of waiting for the device meant that I could not independently charge my chair every night. I would be remiss if I did not tell you how New Motion is treating their customers. Here's yet another situation. I was notified in November of 2024 that I was eligible to get a new power chair. I was evaluated in December by New Motion, and I tried a power chair in January that would enable me to stand up. My doctor sent the prescription to New Motion. I was told by New Motion that my new chair would be ordered and I should get the chair by April 2025. I received an email on March 4th, 2025, telling me I need a face-to-face interview with my doctor for insurance's approval. Now my chair is on hold indefinitely. This is inexcusable because the salesperson should have told me how to complete this process back in December so that I could have been assured all steps were completed in time. I am frightened about the present political climate and what implications it will have for me receiving a new chair. In conclusion, vote yes to proposed Bill 7106. Thank you.
Thank you. Thank you so much for your continued advocacy. And I think you did a great job. Thank you.
Thank you.
Next, we'll hear from Suzanne Garafa.
Okay, this is Suzanne Garafa, and I am going to read her testimony. Senator Lesser, Representative Gilchrist, members of the Human Services Committee. I am testifying in favor of HB 7106 because as happy as I was with last year's passage of Public Act 2458, an act concerning wheelchair repair requirements, I have had experiences over the past year that show it needs some revisions. In April of 2024, I initially had a repair for an actuator on my wheelchair, but National Seating and Mobility determined that the actuator was not the problem, and I had to start the repair process all over again. I had a new assessment on June 12, and they determined it was a tilt frame assembly. Prior authorization came through on July 3, and the needed parts were not ordered until July 10. The earliest date they offered me was July 23rd for the repair, but I had to cancel it because I was having issues with my eyes and I had to schedule around my aide. They eventually scheduled me for August, but offered me an earlier date if I came into the shop, something that I'm not able to do. There's considerable pressure for me to come into the shop, and the whole experience was in violation of Public Act 2458, which requires at-home repairs within 10 business days if that is what the customer needs. Since they made the mistaken assessment in the first place, I had hoped that NSM would make the new repair a priority, but this was obviously not the case. When my wheelchair is not working properly, I have nothing, and it hurts me physically. When the tilt function on my chair doesn't work, my back hurts and I cannot change my position. I struggle with the tasks of daily living. The only backup I have is a manual chair, and I cannot transfer in and out of it. It's also very uncomfortable and puts me at risk for sores. Otherwise, I'm completely bedbound when I have a non-working chair. When I first moved to Connecticut, I had access to 24-hour wheelchair service, but the company has since been bought out. My point is that it is possible for a company to have emergency services available. Often, if I call NSM after hours, it can take up to 2 weeks for them to return the call. I usually end up having to call back for follow-up. The availability of emergency services would give me the peace of mind that my repair will not be unnecessarily delayed or slip through the cracks. Because it has enforcement provisions and new wording about emergency services, HB 7106 would go a long way towards fixing this problem. Please support it. Thank you.
Thank you. Thank you so much for being here and for sharing your experience.
Can I say something?
Yes,
Wait,
but we just need you to
into the
speak
mic.
into the microphone for the public record.
Have a mic. Sorry. Hey, thank you. I don't.
There we go.
I don't need to repeat myself, but I'm gonna repeat myself anyway. Okay.
Thank
I
you.
told Mike this the other day, and I told you guys this the other day when I was here. We cannot wait forever. This needs to be done now. People are sick, they're in bed, they get sores, they end up in the hospital and they die. I do not want to be one of those, and neither do they. So pass this bill. Thank you.
Thank you. Senator Lesser.
Thank you for your testimony. We are not losing any sleep. We are going to do what we can to make sure that we're improving services and support for people with wheelchairs in Connecticut. That has been a priority of this committee since last year. We have not stopped working on it. Representative D'Amico is following us very closely to ensure that we keep our commitments to the community, and we are here to ask some questions of the industry and figure out what we can do to make sure things are better.
Yeah, he's good. You know you're doing it, but we just trying to ask you to do it real quick. Thank you.
Yes, ma'am.
Please speed it up, Mr. Chair, please.
Pleasure. Thank you very much. Next, we'll hear from Farah Garland, who is on Zoom.
Good morning. My name is Farah. I am a disability and queer rights activist. I am the chair of the Wheelchair Reform Coalition, a board member of the Silk, and a member of the Wheelchair Repair Advisory Council. I am disabled, an ambulatory wheelchair user, and an NSM customer. And I really appreciate the time to speak with you all this morning. So thank you. I'm here today to ask you to support HB 7106. It is desperately important. While Public Act 2458, the wheelchair repair bill, which was passed last year, was an incredible first step in filling the glaring disability rights gaps regarding timely repair for wheelchairs and scooters, we are far from having arrived. People are still experiencing delays in repairs beyond the 10 days provided in the law, myself included, one which led to significant pain and potential nerve damage. But we don't have time for that right now. Believe it or not, I have more important things I need to talk to you about. One of the most glaring issues is that over 90% of the wheelchair industry here in Connecticut is owned by only 2 private equity companies, National Seating and Mobility, NSM, and New Motion. There has been significant national coverage about how private equity's involvement in healthcare fields leads to significant deterioration in patient care, loss of vital services, and potentially loss of life. We have seen most, if not all of these, as private equity has come into the wheelchair industry. We see a disparity between these two companies as they've been providing compliance reports to the Advisory Council. With NSM, we have seen an improvement up to about 87%. There's always room for improvement, but that is not bad. But with New Motion, however, they are reporting a compliance rate of 37%. Their average number of days to complete a repair by their own report is 46 days, which is nearly twice the national average. And that is 4 times what is required by law. This is not only mind-blowingly inhumane, but is violating the law over 3/4 of the time. And when asked about their own reported numbers, their vice president dismisses them with a gut feeling that they're probably actually doing better despite their own hard data. Wheelchair repairs are not a convenience. They can be a difference between someone having independence or being bed or homebound for, what was it, 46 to 124 days or more. But beyond that, delays can lead to severe health issues and even death. In 2021, Ingracia Figueroa, a woman from California, died from complications from pressure sores after an airline broke her wheelchair and a new chair or adequate repairs were not provided in time. And while horrific, her story is not unique. This is healthcare. This is serious. I understand that this is their business, and as a private equity company, their bottom line is often their first priority. But that prioritization is just unacceptable when it comes to healthcare, to people's literal lives. And that is why I'm asking you to support this bill, a way to hold these companies accountable when they do not adhere to the law and harm us in the process. We need teeth to the law, like the recommended CUPTA violation laid out in this proposal, requirements to allow for emergency repairs and to ensure parts that are expedited when necessary. And as the Advisory Council, requiring monthly reporting of their data for all payers, as well as their staffing levels, and a clear, definitive definition of what a technician is, so that everybody tasked with monitoring this bill, as laid out in PA 2458, can have a clear understanding of what's going on and how to best support not only disabled folk, but also the companies providing for us. This doesn't feel like a very big ask. I thank you so much for your time today and for supporting this bill. Thank you.
Thank you. Thank you so much, Farah. Good to see you, and thanks for your testimony and your advocacy.
Thank you so much. I appreciate it.
Next, we'll hear from Joseph Short, followed by Ruth Grobe.
Hello. Good morning, members of the Human Services Committee. My name is Joseph Short. I'm a Southbury resident, and I'm here to testify about timely repairs on custom wheelchairs and mobility scooters. I was one of the many consumer advocates that were part of the newly created Wheelchair Advisory Council that was responsible for making recommendations to improve the current law for timely repairs and overlook the industry's monthly data to ensure that they complied with this law. The majority of the Wheelchair Council's recommendations are included in House Bill 7106, and they will make a tremendous impact on the quality of life for every wheelchair and scooter user throughout Connecticut. Therefore, I strongly urge for your unanimous support on this important bill. Why should a wheelchair repair take our independence and mobility away for any longer than it absolutely has to, simply because of 2 private equity companies trying to save $1? The current law has no enforcement of any kind in statute and allows these companies to remain grossly understaffed and inadequate for providing timely repairs. National Seating and Mobility has come a long way to comply with the new law, but New Motion continues with their poor service record and is only at 37% compliance, making repairs on average within 46 calendar days. I've personally been waiting on parts for a repair order that I requested on February 5th and still haven't gotten a date as when the parts will arrive, when I'll be put on New Motion's schedule for repairs, which usually takes another few weeks. If it wasn't for having used parts that I could take off old wheelchairs, I wouldn't have been here today. I'd probably be stuck at home in bed for an undetermined amount of time. New Motion and National Seating and Mobility each serve nearly the same amount of people, yet New Motion has less than half the number of technicians that are providing repairs, 7.1 service technicians to be precise, compared to NSM 16. The current law needs to be strengthened in order to pressure these companies to hire more technicians so they actually comply with the law rather than putting the cost of an additional technician above the quality of life, health, safety of thousands of wheelchair users, such as myself here in Connecticut. House Bill 7106 requires monthly reporting of all repair compliance data and staffing levels. Additionally, this bill will provide coverage for annual preventive maintenance on custom wheelchairs and scooters because, let's face it, it's cheaper to do preventive maintenance than it is to wait for extensive damage to occur, which will cost the state more and leave many wheelchair users stranded. These changes, along with the requirement that wheelchair users are notified of their rights and provided accurate documentation of their repair orders, has me hopeful that repairs will be fulfilled as soon as possible with minimal delays, and if there are any issues, people will now know where to file a complaint. Thank you for your time to recognize this longstanding problem that myself and so many other wheelchair users across the state have been dealing with to get our equipment fixed within a reasonable time frame to prevent additional injuries or rob us of our independence. Last year's bill was a step in the right direction, but to actually hold industries accountable for the extensive delays and to improve the quality of life for wheelchair users, we need your support. Thank you.
Thank you. Thank you so much, Joseph. Thanks for your testimony and for being here. Next, we'll hear from Ruth Groby, who is joining us on Zoom. Ruth, are you with us? There you go.
Yes. I'm very sorry. I thought you had to do that. I didn't realize I had to do it. Oh, wait, what happened to the camera? Oh, yeah.
We've all been there.
There you go.
No, can you see us?
We did, and then it went back off again.
Lordy. No, I can't get, oh, no. Okay. Okay, oh, I'm very sorry, and I really want you to be able to see us, because I've got 4 people who use wheelchairs here with me. Could you go ahead to one other? I've got to go perhaps and get some help from the
Yes,
person.
Yes. So if you don't mind just muting, and then you go get some assistance and we'll move to the next person.
Okay, thank you.
Thank you. Yeah. Brianne, who would be next since, oh, is it number 12?
Yes, number 12. One
Okay, thank
moment,
you.
I have to promote.
Is she accepting the promotion? All these new terms we've all learned. Okay. All right, Mary, it's your turn.
Well, good afternoon.
Yeah.
I thank you for hearing us today on this HB 7106. We appreciate this opportunity to further address our concerns on wheelchair repairs. Doubtless many of you have had superfood breakfast to sustain your receptivity and your endurance through all these hearings, oh my goodness, over and over again. In one form or another, we have commuted here regarding our concerns. Beyond daily preparation of morning routines, breakfast, dressing, and transportation, some of us have had additional challenges, whether by an individual effort or dependent on others. The disabled among us have greater challenges to achieving our presence here. Some, like me, rely on Zoom platform as it is too difficult to get to the Capitol. In regards to getting to the wheelchair repair shops, I have another sub-concern that's good for you to hear about. One non-medical wheelchair transportation option to the repair shop, which would save the state from having to consider transportation through the other venues. That option is called Encompass. It works through M7, Metro 7 taxi service, which relies on federal grants to accommodate affordable rides within a limited area. It is available to people in the New Haven area and the Hartford area. It is at risk of ending June 2025 as federal funding runs out. How do you like them apples? I am an Encompass rider from Wallingford. So I ask you as representatives of our legislature to please support funding for the Encompass Transportation Program in the Department of Transportation's budget. This service is my lifeline for last-minute medical rides, getting to appointments, and could provide rides to wheelchair shop repairs. Without Encompass, I would lose my independence to travel when and where I need to go. Please help keep this vital service running. For instance, when I have a last-minute appointment to my doctor from Wallingford to Meriden, it can cost me about $40 round trip. It's crazy. When I have gone to appointments in Plainville, it has cost me $180. So I depend on my caregivers to bathe, dress, help me with range of motion exercise, get positioned. They get me up by a Hoyer lift hoist from the bed to the motorized wheelchair. And during the day, I can access my own quarters and I can work remotely. I have things set up so that I can support my daily needs without caregivers, but that depends on having my chair working. I don't have help until the evening. I rely on this wheelchair to access everything, and I rely on it to work properly. When parts malfunction, like the footrests don't elevate, it is not merely an inconvenience. My feet get swollen, and I am apt to have circulatory issues. And ultimately, it could kill me or give me a stroke. I waited several days to get a remote camera diagnostic avail to address this concern. And the crazy thing is, the footrests are an easy fix. If they cannot come because they have this shortage of help, even the remote Zoom type camera views are sometimes delayed. So they had farmed out my evaluation to a technician in Texas. That's crazy. If the chair doesn't roll, I can't get to my medications, to food, or to escape dangers. Having the reclining tilt features work literally saves my skin. I cannot perform butt lifts to relieve pressure to my bottom. So, as you are well aware, our wheelchair is in effect our legs. Imagine if you weren't walking. It impacts everything. When your car breaks down, you expect service at the repair shop. You expect to have them diagnose the problem and order the appropriate parts. Part of this legislation states require wheelchair suppliers, when needed, to arrange for overnight or expedited delivery of parts, Section 6B. Getting those parts in a timely fashion is not an optional operation, not one that the repair shop should defer responsibility for. The importance of covering both wheelchair and scooter repairs in a timely fashion should not be underestimated. It doesn't matter which conveyance is used for mobility. These are not for convenience sake. These are essential for functions. Having the adequate staff can help address the need for timely repairs. Many of us, including myself, have issues with delays from reporting to having them come out or even call back to address the repair needs. It is important to strengthen, to pressure the companies to hire more staff, which can solve this wheelchair repair crisis. And having the repair shops post the 10-day limit should be implemented and reinforced.
Excuse me, your time is complete. Please summarize.
Okay. Please understand that time limit should not be dismissed. And please help us avoid further snafus by supporting this bill and avoiding damage to our bodies and our lives. Thank you.
Thank you. Thank you so much, Mary, for your testimony and for being here today.
Thank you.
Ruth, we'll go back to you. I see the camera's working.
Thank you. Yes. Senator Lesser and Representative Gilchrist and members of the Human Services Committee. My name is Ruth Groby, and I am the Secretary of the Citizens Coalition for Equal Access, or CC=A, grassroots disability advocacy group that grew out of work with the Farmington Human Relations Commission, which I chaired for more than 10 years. You are hearing from a number of CC=A advocates with severe disabilities today. And they're surrounding me right here in this room. And my role has been to take dictation or give any other kind of service to expedite their giving testimony to you in favor of HB 7106. But first, I'd like to say, as an abled person, I lived the first 50 years of my life with almost no exposure to the lives of people with disabilities, and even received a master's degree in social work without having been educated about the many barriers they face. However, in the most recent 23 years of my life, I have made the acquaintance of a large number of people with physical disabilities, and I now see that their full and equitable participation in the life of our society is impeded by misconceptions, physical and attitudinal barriers, and problems with communication, transportation, housing, healthcare access, and today's subject, wheelchair repair times. Because of these issues, people with disabilities remain largely invisible to their fellow Americans as they struggle to have their voices heard. We deeply appreciate the effort made by this committee to rectify this situation. And now the 2024 session of the General Assembly passed Public Act 2458, which we've been talking about. It was a great start, but only a start. And HB 7106 has important changes that will address additional problems that the next 4 speakers from CC=A have faced, even after the passage of Public Act 2458. In the interest of time, 3 of our 4 speakers have asked me to read the testimony that they gave to me, but they would be happy to answer any questions you might have, as am I. Ray, you're next. Ray, can you come up a little further, please? Should I go ahead with the next person?
Yes, please go right ahead.
Okay, this is Ray forward. This is Ray Howell. from Unionville. He's coming into your picture in a moment, and I want to thank him for being here because Ray had dialysis this morning and is still recovering from it. And so I really appreciate your being here, and
Thanks for being here, Ray.
Can you still, yes, okay. My name is Ray Howell from Unionville, and I am testifying in favor of HB 7106. I have several severe health issues, and I depend on my wheelchair to get to doctors and dialysis appointments. Several years ago, I experienced a 5-month delay in getting my wheelchair repaired, so I was very glad that the General Assembly passed Public Act 2458 last year. My hope has not lasted. At the moment, I am in the middle of a 3-month delay in getting my wheelchair repaired, and I am extremely frustrated. It always seems to be about getting parts. So I want to support the fact that HB 7106 calls for new motion to keep sufficient parts in stock to ensure timely repair, or have an overnight express delivery option for parts needed. I have had many severe health problems since birth, but I have tried to live a full and meaningful life, expressing who I am through my art when my disability keeps me at home. I totally rely on my wheelchair to get out into the community, and it is not right that wheelchair repair companies care more about making money than about what I need. Please vote in favor of HB 7106. Are there any questions?
No questions at this point.
Want to introduce yourself?
I'm Jamie. Will read my test.
This is Jamie Mosier, who lives in Unionville as well. On September 5th of last year, I sent an email to New Motion's coordinator of repairs for the Connecticut area to report a problem with my motorized wheelchair. In July, New Motion had replaced one of the motors on my less than 1-year-old wheelchair, but then the other motor conked out. The coordinator, and that's what I was calling about on September 5th. The coordinator did not get back to me on the next day as her automated email had claimed. So I finally contacted the call center and got an appointment for September 12th. This was already 6 business days from when I had initially contacted the coordinator. The technician ordered the parts after looking at my wheelchair on September 12th. First, the parts were supposed to come in by September 27th, then it changed to October 14th, and finally to November 4th. New Motion did not come to fix my chair until November 13th. Which was definitely more than 10 business days from when I reported the problem, even if you don't count the endless time it took to get the parts. During all this time, I had to use my old chair of 15 years that did not have the same features as my new chair. I experienced a lot of pain in my back because my old chair didn't have a recliner, and New Motion could not provide me with a loaner chair that had proper features. I do up to 19 hours in my chair per day, and there aren't always people around to help reposition me. So I ended up with problems all over my body in the form of sores. The process of getting wheelchair repairs done is ridiculously long and can hurt people with disabilities like me who rely on their chairs. I believe that New Motion needs to get rid of its call center and hire more technicians. PA 2458 needs to be strengthened by the provisions in HB 7106. And now, Ray, can you let Valerie come through? Thank you so much. Are you okay?
Yeah. Just gotta make sure I'm getting into the right spot here.
Yeah, you're perfect.
Okay. Am I on camera?
Yes, you are. Please go right ahead.
Hello, ladies and gentlemen, I'm Senator Lesser, Representative Gilchrist. My name is Valerie Ann Rumpf, and I am speaking in support of House Bills 1706. I do have a very recent issue, with new motion, about a wheelchair repair that I am going to need. I did call them over. I would say, last week to have my chair looked at, because my battery's basically crapped out on me, and I'm having a few other issues with my chair. And I do have an appointment set up for Tuesday, March 11th for them to come out to my house, but they did want me to bring it into the shop, and I told the call rep that there was no way that I could bring the chair into the shop, because first of all, I can't drive due to my vision, and also it's kind of hard to bring a broken chair to the repair shop if you're physically disabled and you're trying to do it yourself. So hopefully I will get lucky and they will actually come out to my place and look at it and do what needs to be done with it. But in all honesty, because I do live in an apartment complex that has a lot of people in it with physical disabilities, I do see a lot of frustration, with getting wheelchairs repaired, and it's just ridiculous that not having a proper working wheelchair actually does affect people with physical disabilities. It can cause them harm. It could also cause them loss of income if they work. It could cause them loss of independence, and a lot of other things too. Thank you for allowing me to testify on this bill, and I hope that this bill passes, because we need better repair services in the state. Thank you.
Thank you. Thank you so much for being here.
Oh, you're welcome. Any questions?
Nope, not right now. Thank you, though.
Yeah. And now I would like, oh, you want to introduce yourself, Chuck? Please do. My name is Chuck Hutchings, and I'm supporting Bill number 7106, asking you to support it. It's okay if I read your testimony? Chuck has cerebral palsy, and I'm going to do it in the first person though. I have cerebral palsy, and I have had to use a wheelchair all my life. But in recent years, I have gotten even more reliant on my wheelchair as I have developed lupus and other serious health issues that require frequent doctor's appointments. I would like to speak in favor of HB 7106. Recently, I was approved for a new motorized wheelchair, But this process unfolded very slowly when Mary Ann Langton, I'm going to interrupt a minute, when Mary Ann Langton was giving her testimony about how at the last minute she was asked to have an in-person meeting with her doctor in order to get the new wheelchair done, even though all the paperwork and the evaluation and everything had been done. Chuck had the same situation when he was waiting for his new wheelchair. While this process was slowly unfolding, my old wheelchair was experiencing problems. I reported them to New Motion, but they could not provide me with a loaner chair, and they did not send out a technician to assess the problem. As a result, my wheelchair stopped working several times when I was out in the community, and also when I was trying to get around my home apartment complex at New Horizons Village. This endangers me and makes it hard to stay in good health. Please support House Bill 7106. Okay, any questions?
Thank you so much. Yes, Representative D'Amico.
So thank you, Madam Chair. Thank you, Ruth, and everyone for your testimony. I don't really have any questions. I just wanted to make a brief comment or two. First of all, Ruth, at the beginning of your testimony, you alluded to the fact that people with disabilities are oftentimes invisible in greater society. And I just want to assure you and assure the folks that you are with this afternoon who gave testimony. I want to assure people who gave testimony prior to you earlier today. I want to assure the whole disability community that due to the efforts of you, Ruth, and your organization and many, many other people, that the disability community certainly is not invisible to the members of the Human Services Committee, the Public Health Committee, and the General Assembly in general. You are not invisible, and that's because you made it a point to not be invisible. So we have public hearings for the purpose of hearing real life stories from members of the public, and you have certainly enlightened us as to many of the problems that exist, that continue to exist for the members of the disability community. And there's a lot of work that needs to be done, but we appreciate the fact, I appreciate the fact, and I know the leadership of this committee, ranking members as well as chairs, appreciate what you are offering to us, and we are committed to really go to work on it and make some improvements. So that was a lot longer than I wanted it to be, Madam Chair, but I felt like it had to be said. So thank you, and thank you, Ruth.
Thank you, Representative, and couldn't have said it better myself, so I appreciate what you had to say. And I just want to thank you, Ruth. I want to thank Ray, Jamie, Valerie, and Chuck for being with us today and sharing your experience so that we can help others. Have a great afternoon. Thank you.
Thanks so much.
Next, we will hear from Jonathan Sigworth.
Here we go. Thank you. Thank you, Madam Chair, and all the other members of the Human Services Committee for listening and hearing our voices today. And I'm especially grateful for all my fellow advocates who have continued to push the effort forward after last year's success. PA 2458 was a huge success in that, Connecticut became the first state in the country to legislate timely wheelchair repairs. But there is more work to be done. And, I just want to say that as largely a public observer of the wheelchair repair councils, it stood out to me that almost for the first several months, for almost the rest of the year, really, there was a debate. It seemed to be a concerted effort in the background to dismantle the law that had been passed even further. There was backroom discussions, denials of that the 10 business day requirement was in fact a 10 business day requirement from the time that a request is made. So one really important thing that should be clear for everyone is that this new law makes it crystal clear what that timeline requirement is, and that it does apply for power chair mobility scooters as well as power chairs and custom manual chairs. So that's point number one. Point number two is, the industry will say that there is improvement, that they are complying, and that they are pushing forward and raising up what is happening in Connecticut as an example. I've been part of discussions as a member of the Connecticut Wheelchair Reform Coalition, as well as the leader of the nonprofit More Than Walking here in Connecticut. We have been in discussions with organizations writing white papers on wheelchair repairs, and in every instance where these national coalitions have funders or members at large that are New Motion and NSM, there is an explicit denial and a refusal to include mandates or requirements for timely wheelchair repair deadlines as part of those discussions. It's very clear from the data that New Motion and NSM submitted that their staffing numbers are inextricably linked to their ability to comply with the law as it is. As it's already been mentioned, New Motion only has the equivalent of 7.1 full-time repair technicians compared to NSM's 16. And from their own data, NSM is able to comply with the law as it currently is 87.5% of the time for in-home repairs. New Motion, a terrible 37% of the time, which is catastrophic for wheelchair users, leading 46 calendar days up on average to 124 calendar days to complete an in-home repair. If New Motion were to invest in doubling their staff, those numbers would go down significantly. And by imposing a requirement that would make it an unfair trade practice to continue to violate the law, this will not push business out of Connecticut, as they may claim, but this will significantly incentivize the companies to invest in the only solution that has up until this point proven to work and proven
Your
to...
time is complete. Please summarize.
Yes. So thank you very much. Please support HB 7106. Thank you.
Thank you, Jonathan. Thank you for all your advocacy and work on this.
Madam Chair.
Yes, Representative D'Amico.
Okay. Yeah, I just wanted to say, Jonathan, I just want to echo the good co-chair's remarks. Thank you for your tireless advocacy on this. I appreciate your coming and testifying today in front of the committee. So I'm still a little bit confused about the 10 days. Could you go into, without belaboring this, Madam Chair, I certainly don't want to belabor anything, but I need to get a better explanation of this 10-day time period, Jonathan, if you could.
Yes. So originally last year, the 10-day requirement is 10 business days from the time that you make a call to the time that someone comes out to your house and finishes the repair. However, the elements of that process that are out of control of the repair technician, such as waiting for paperwork for prior authorization or waiting for parts that have been ordered to be delivered, right? If there's a backlog or a shipping delay or any time that it takes to ship up by ground or whatever, that does not eat into the 10 days. So that was the 10 business day requirement. And the law as it is would be in HB 7106 is the same. It just makes the language crystal clear so that there can be no confusion and no trickery to interpret that 10-day requirement as being from some other point in time. That's last year. It was trying to be argued that the 10 days would not start until the parts had arrived, which would be catastrophic. So does that make sense?
Yeah, no, I appreciate that, Jonathan. So the way the bill is written now, just to be clear, it allows that the time spent waiting for parts as well as the time spent waiting for prior authorization does not count against the 10-day time limit. Is that basically it?
Correct.
Okay, and I appreciate that it clarifies what was written last year, so that what you had just described was a little vague in last year's rendering. So I appreciate that.
Yeah.
I guess my only question would be for you, and I get the fact that this exception is made, or these two exceptions are made for both delivery of parts as well as waiting for prior authorization, doesn't that really render this 10-day time period essentially meaningless or at the very least ineffective?
No, because with the elimination of prior authorization, that amount of time waiting for that should become negligible. And if this bill is passed as is, it will require payers to cover overnight shipping. And so, waiting for the shipping of parts should also become fairly negligible. And I also forgot to mention, because of it is a little complicated, right? Trying to create a system that is fair for both the businesses and the consumers, with, the exceptions for this 10-day requirement. This law, very important provision, would make it so that on the delivery of the final repair, the consumer gets paperwork that has that timeline data clearly written out, along, I believe if it's not there, it should be, along with information on how to report a delay to the Office of the Healthcare Advocate. So there are a lot of things in this bill that really secure that 10-day requirement and make it more understandable and more actionable for consumers when they face severe delays.
So one more question, if I could, Madam Chair. So Jonathan, again, thank you for all of your hard work on all of these issues. I just wanted to give you an opportunity to comment. So earlier, I don't know if you were with us earlier, the Commissioner of the Department of Social Services expressed her support for the intentions that are listed in this legislation, House Bill 7106. But in her written testimony, she noted in several instances that financial constraints would really be a barrier to the enactment of many of the sections of this bill. So just wondering if you wanted to comment on that or you want to leave it alone.
No, I'll definitely comment. I mean, the biggest element of this that I can see that might impose significant financial things are, additional coverage of preventative maintenance and requiring Medicaid to pay for transportation to and from a repair shop. And I would comment in saying that, look, Medicaid already covers transportation for doctor's appointments. For wheelchair users, getting your wheelchair fixed, as Marianne and others have said, these wheelchairs are extensions of our bodies. These are medical appointments. And if they are not legally seen as so at the moment, they surely should be. And failure to get timely wheelchair repairs and transportation to a shop, if that's what we need, then that will result inevitably in further medical complications, which will come with additional medical costs. And the same thing with preventative maintenance of equipment that will significantly assist in preventing catastrophic wheelchair repair needs and ensuing medical expenses that will be billed to Medicaid. So overall, any kind of form of additional cost to the system, I think this really is going to save money in the long run. It's going to improve people's health. And if the department needs additional funds, then go for it. But that should not be an issue that stands in the way of people with disabilities getting what they deserve.
Thank you, sir. Well said. Thank you, Madam Chair.
Thank you, Representative, and thank you again, Jonathan. I don't see any other hands. Thank you for being here today.
Thank you.
Next, we'll hear from Katie Stargartner, followed by Sheldon Tubman.
Good afternoon. My name's Katie Stargarter. I am the Undersecretary for Legislative Affairs at the Office of Policy and Management. And I'm here to talk to you about Senate Bill 1420, an act concerning the Connecticut Partnership for Long-Term Care. You have the Secretary's testimony in front of you, and I sort of want to hit the highlights and answer any questions you might have. We are aware and very sensitive to concerns surrounding long-term care insurance, but we don't believe the revisions in this bill will address rate increases or provide for additional protections. OPM supports the Connecticut Partnership for Long-Term Care along with the Department of Insurance. OPM's role is to provide consumer information, to collect and aggregate quarterly partnership-specific data and to evaluate the program, and to coordinate with the Department of Insurance to pre-certify new policies to ensure they meet federal and state requirements. We play no role in actuarial assessments or the rate review process. Partnership products are standard long-term care products. They're sold by private companies. They cost the same as other long-term care products, and they're regulated by the Department of Insurance. They're pre-certified for certain consumer protection and minimum benefit standards. What makes them special is qualified policyholders earn dollar for dollar Medicaid asset protection. So if they ever need to go into the Medicaid program, DSS will disregard policyholders' assets in an amount equal to what the policy paid out for their care. This is what makes these products special. They are free for consumers and they have no impact on the cost of the policy or on rate increases. OPM does not possess regulatory authority over the long-term care insurance market. We do not have a role in review and approval of initial rate increases or initial rates or rate increases, and we have no authority to enforce statutory or regulatory rules. The report outlined in Section 1B of this proposed bill would require additional staff with expertise to collect, evaluate, and analyze the report. Funding for these additional staff is not included in the governor's budget. For the study and the report in subsection C, OPM would need to hire a consultant with the appropriate insurance and actuarial experience. Again, funding for this consultant is not included in the governor's budget. Also, we want to point out that the study contemplated has already been considered by the National Association for Insurance Commissioners, and their recommendations are currently in place with CID regulations for long-term care policies. In sections 3 and 4, we want to point out again that partnership policies should not be treated different than other long-term care policies. We should not be creating separate rate increase standards for these policies, and doing so would not provide relief from future increases because there's no cap. In summary, OPM does not have the regulatory authority or actuarial or industry expertise to meet the requirements of this bill. Additional staff and a consultant would be needed, funding for which is not in the governor's budget. Partnership products should not be separated out from other long-term care policies. And for these reasons, we oppose this bill.
Great. Thank you, Katie. Representative Vale.
Thank you, Madam Chair. Good afternoon.
Good afternoon.
With the partnership, are insurance companies allowed to sell long-term care insurance in the state of Connecticut that are non-partnership plans?
So OPM's role is only with only with partnership plans. So I couldn't speak to other long-term care policies that are outside of the partnership. Our role is solely within partnership plans. Other plans are regulated by the Department of Insurance.
Okay, but you're not aware if they're allowed to sell non-partnership plans?
I don't know the answer to that.
Okay.
No.
All right, so if someone purchases a long-term care policy, it's more of a per diem or it's like a bag of money as opposed to like a benefit, right? Like it's not like you, like as time changes and medical expenses change, you know, your insurance changes with it. To me, a long-term care policy, you buy a specific benefit amount that may increase if you add that to it, correct?
I'm sorry, I don't
Okay.
know the answer.
right.
We simply stay within the extra benefits that partnership policies provide to consumers.
Maybe, so if they have a $100,000 policy, that's their total benefit. They go into a nursing home, they use that, $100,000, they have $100,000 of asset protection, correct?
That's correct.
So if they have a $500,000 policy and it was exhausted in a nursing home, and then they went off and they stayed in a nursing home long past when their policy expired, that's when the asset protection would kick in. Is that correct?
The asset protection kicks in when Medicaid would kick in.
Yes, exactly. So they no longer have anything. They went through their policy thing. Okay. And then there is there's a 3-year look back or a 5-year look back where people sign over their assets to their children or something like that.
I'm sorry, I don't know
Okay.
the answer.
All right.
Our subject matter expert
Okay.
had an emergency, so
It's okay.
they sent me alone.
All right. It's all good. Thank you.
Of course.
Love your honesty. Thank you. We do have a question from Rep. Dathan. Who's on Zoom.
Thank you so much. And Katie, thanks for coming in and jumping in. And we'd love to talk to your subject matter expert at some stage. I hear repeatedly and it's not really the cognizance of this necessarily bill, but really the cost of increasing premiums for long-term care and the sort of plans and then draining of these assets that are happening. And then these folks end up on Medicaid because they can't support themselves. Or alternatively, contribute to plans for decades and then don't get to use the product at all. Is there any sort of benchmarking process that happens in the state to make sure that any sort of long-term care plan has reasonable cost increases and sort of adjustments needed? And is there any sort of cap that if a person's, let's say, paid in for 40 years or 50 years, that they can stop paying in and still receive their benefits? Are you aware of anything like that in regards to these sort of partnership plans?
So these plans operate just like other long-term care market plans. And to answer that question, I'd have to refer you to the insurance department.
Okay, I'll have a look. And I was just looking for the OPM testimony on this on the website. And apologies if I missed it, but I can't seem to see it. Do you know who may have submitted the
Should be
testimony?
under Secretary Jeffrey Beckham.
Okay, I will have a look again, and apologies that I probably missed it myself. Thank you for testifying today. And I know this is a topic that's being covered in a variety of committees, and I know we're talking about it in my government oversight committee as well. So appreciate the work that you all do. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thanks for being here today.
Anytime. Thank you.
Good to see you. Next, we'll hear from Sheldon Taubman, followed by Walter Glom.
Good afternoon, Representative Gilchrist, other members of the committee. My name is Sheldon Taubman. I'm litigation attorney at Disability Rights Connecticut. We serve folks with a full range of disabilities throughout the state. Here on mostly on the wheelchair repair bill. I do have written testimony on 1416 long-term care rebalancing, and I just wanted to mention on 1421, when the commissioner says they're working towards compliance with the law that was passed, the law required the state to cover all FDA-approved weight loss drugs on July 1st, 23. So they are grossly out of compliance, and I want to put that to rest. With regard to the wheelchair repair bill, we really appreciate what was passed last year. The bill rate being raised 7106 is designed to improve things, as was suggested would happen last year. I have looked at the opposition. I should say I'm also on the Wheelchair Advisory Council. I looked at the written testimony from Wayne Grau, who's the chief lobbyist for the industry. And overall, their position is that no new mandate should be imposed on them, only on everybody else. All the payers should be imposed, Medicaid, OHA, but not them. But the key thing of his testimony is that the bill as passed is working, and quote, repair wait times have dropped considerably. That is half true for NSM. For New Motion, it's absolutely not true. As you heard, the compliance rate by their own data was either 37, or if you want to inflate it, they said really inflated, it's 60% compliance with the 10-day requirement. NSM, on the other hand, is 87.5. The average wait time is 46 days for New Motion, 15 days for NSM. And by the way, those wait days are about what it was a year and a half ago before you even passed the law. And the explanation is really quite simple. It's staffing. So they have 7.1 full-time equivalents at New Motion, 16 at NSM. That's why you see the difference. There's testimony, or not testimony, but the task force that was created before the bill was passed last year had extensive meetings, and in that discussion, the executive vice president for New Motion made absolutely clear that yes, the problem is lack of staffing, but it would be, and I quote, economically not possible for us to hire that additional staff. Now, New Motion has had profits of over $90 million a year for the last 3 years, as reported in May of 24. So this is their position. They don't want to hire the staff, and that would solve the problem. And therefore, they're opposed to anything to enforce the law, which, as discussed previously, has no enforcement mechanism. They don't even want to have the council meet anymore monthly or data report monthly. They want it to be quarterly. And most importantly, they're opposed to private enforcement of the 10-day requirement, any kind of enforcement. So while they refuse to do anything about actually complying with the law, and they don't want any new requirements imposed on them, they are sending out newsletters to all their members, coercing them to come into the shop by saying that if you come into the shop, it will be at least a week faster to get your repair. That statement is technically true, but it's premised upon a gross violation of law. The only reason it takes an extra week longer is they're grossly out of compliance with the state law. And 6 of us on the council wrote a letter to the CEO of New Motion yesterday about this very point, asking him to please stop doing this. So all of the changes that are in the bill, we don't have time to go through them, but in my written testimony, I do, and they're all going to improve this law. And so people with disabilities will have much greater access to timely repair. At the end of my testimony, I did include a couple of revisions that other people are testifying, minor revisions. Overall, the bill as written, though, will make a tremendous difference and really move the ball forward with regard to the one company that seems to be unwilling to do anything without mandates. Thank you very much. I'm happy to answer any questions.
Thank you, Sheldon, and thank you for your work on the task force and for your continued advocacy. I don't think it will come as a surprise, and I think I've said statements before in this building that I'm not a fan of private equity, and I think they're doing damage across many industries in this state and across the country. And so when it comes to private equity and New Motion, because how many states does New Motion operate in the research you've done? Do you know that?
Both companies are ubiquitous throughout the country, and they are gobbling up the mom and pops like we used to have in Connecticut in the old days. So they're doing that everywhere. And the business model, unfortunately, is not just gobbling them up, but also taking on debt in order to buy them. So therefore, from the revenue they get, I believe New Motion has revenue of about $650 million a year. From the revenue they get, coming off the top of their profits, if you will, is the debt service. They bought these other companies. There's something fundamentally wrong with the model, but I have to say, your law is making a difference with one of them. It's significantly improved as a result of the law that was passed, and I can't explain the difference between the two companies, why they are both private equity, and they're both national, and they're both gobbling up other companies. but for some reason, one of them is being responsive to the law while the other one is not.
Thank you. I see Rep. Dathan has her hand raised. Go right ahead.
Thank you very much, Madam Chair. Just a quick question on the weight loss drugs. I know in speaking to providers, I've heard directly that unless they provide certain codes, even under the current laws, they have to provide the code type 2 DM in order to say that it is, pre-diabetes, insulin resistance, et cetera. Type 2 diabetes, even though the diagnosis might be pre-diabetes, insulin resistance. Is that what you're hearing within your sort of circles regarding these drugs? And do you have any support for how we can ensure that folks get access to their medications without having any sort of gaps due to abrupt cessation of these products?
Well, since you asked Representative Dathan, the law that was passed a year and a half ago could not have been clearer. It's a mandate. It's not a may, as you often say, it's a shall. The commissioner shall provide medical assistance for medical services for Medicaid and Husky B beneficiaries with a body mass index greater than 35. And then and that's one part of the law passed. And then the other definition, there's another definition section that says that medical services means specifically prescription drugs approved by the FDA for the treatment of obesity on an outpatient basis. So there's no ambiguity that the law requires coverage of all FDA-approved weight loss medications, and the person would get it if they have a BMI of 35 or more. Nevertheless, the department's clear position, it's in writing, it's in the the commissioner's op-ed yesterday referred to, it's at an administrative hearing I was in, their position is absolutely, we will not pay for weight loss drugs just for weight loss. And you're correct about the coding, that unless there's a code for one of those things, which is to say heart condition or diabetes, it will not pay. And it is currently not being paid now, a year and how many months is it since the mandate went into effect? I don't know what you do when a state agency, maybe under the direction of OPM, is blatantly violating a state law. I don't know what tools you have. Obviously, lawyers can bring lawsuits. Is that really the best way to deal with things? I don't know, but it seems to me that the commissioner should be, she sat right here and said, and in her op-ed yesterday said, oh, no, we're not out of compliance. We're working towards compliance. No, there's no such thing as working towards compliance when the mandate was July 1st, 23, and it didn't say anything about balancing costs and all this. That's not in the law. So I'm not sure what the answer is politically, but it is really problematic. I can say there's a couple little things that the lawyers at DSS, cute arguments they've come up with that could be addressed. So one of their cute arguments is that the statute passed a year and a half ago says that and you say this all the time, when you pass a mandate at the end, you say that the commissioner may seek a state plan amendment from CMS if necessary to implement, which is totally reasonable and appropriate. And you don't know whether an SPA is needed or not. So that's totally appropriate language. The position now being taken by one of the lawyers at DSS is, well, yeah, but since we never submitted the state plan amendment, that therefore the mandate doesn't apply to us. So that would be, you could clean up that language a little bit. I was also told that the word all does not appear in the mandate. It just says FDA approved weight loss drugs, doesn't say all. So you all know that a couple weeks ago, they submitted a state plan amendment to cover ancient weight loss drugs that are ineffective and apparently dangerous, but they're technically FDA approved weight loss drugs. And then when asked, how come you're not covering all the GLP-1, the current class, the answer was, well, it doesn't say all.
That's helpful. It's hard when so many people rely on these and they're having success, and the benefits of, reduced hospitalizations due to heart conditions and other things that are being achieved with these much lower cost medication compared to the hospitalization and treatment of some of these large conditions that you get from could get from obesity and how it affects people's lives. I do think it's important, and it's also concerning to see that I have heard from Medicaid patients that they're not able to receive these. And again, the governor has cut this out of the budget for the next biennium, and trying to see exactly how much we've actually spent on them, because it doesn't seem like, from what I'm hearing, that this is a big problem. People are not getting these medications. So I appreciate it. I also appreciate all your advocacy for the disabilities community and the wheelchair task force that you're on. But thank you so much. Thank you, Madam Chair.
Thank you, Representative. All right, I don't see any other hands. Thank you so much for being here.
Thank you.
Next, we'll hear from Walter Glum, followed by Paula Greenberg.
Good afternoon, Madam Chair, members of the committee. My name is Walter Glum. I am a parent of a man who has developmental disabilities and receives services from the state. And I am also the executive director of the Connecticut Council on Developmental Disabilities. I am here to speak in support of House Bill 7108. You have my written testimony, which has a fair amount of data and detail in it. I'm going to summarize today on the salient points of this bill. Okay, the issue is starkly simple. There are many individuals in the state of Connecticut who have an IQ over 69. They do not have autism, and yet they have high levels of need, the highest levels of need for the types of services and supports that are currently offered by the Department of Developmental Services and under the autism waiver. These residents are now categorically blocked from receiving any of these services because of an archaic policy of the state to base eligibility on IQ and autism diagnosis. You'll see in my testimony, most states don't do this. In fact, as far as I know, only 3 other states use IQ exclusively the way we do. Now, and let's be clear, these individuals have levels of need that are greater than most of the people who are currently receiving services. Because as you know, certainly in the DDS system, we have a large population of about 13,000, 13 to 17, depending upon how you count who's getting services, who've been evaluated with levels of need, and some have high, some have low. There are many folks currently receiving services with levels of need significantly lower than people who we categorically bar from receiving these services because their IQ is too high. There are other tools. Now, of course, a study was done, and what 7108 would do was have the state take the next couple steps, not all the steps, but the next steps towards throwing a lifeline to these families who currently are excluded from getting any kind of services. Now, clearly, there are implications for budgets and resources if we do this. And we're going to have to address those, just as we address them now for the current pool of eligible people. But it's just wrong to continue with a categorical exclusion for these people. I'm asking you to support this bill and to at least take the next steps and give these families some hope that in the future, the state's going to stop ignoring them, okay? Then in closing, I just want to remark that I personally, and well, professionally, it's my opinion that the cost estimates that have been put out by OPM on continuing this work are terribly high, okay? Frankly, I think they spent too much on the Altarin report, and to take the next couple steps that are proposed in this bill, I think can be done economically, mainly because we already have in Connecticut a level of need tool. We already have a universal assessment tool, both of which were ignored by Altarum in their report. Okay, and I don't understand why. Okay, so we have the foundation for doing this. Okay, I think, and this bill points to that, and just take a look at using, for example, use the level of need tool or use the universal assessment tool to prioritize. We don't do that now. We don't prioritize eligibility based on level of need. We have some arbitrary cutoffs that exclude a lot of people, and it's time to move on and join the rest of the country in doing this in a more reasonable way. Thank you.
Thank you very much, Walter. And I'll be following up because I'd hate to, like, this has been an ongoing conversation. Now a report was done and I don't want it to just go on a shelf as if we solved something when we didn't. That was just the beginning in many ways. And so how do we move this along? And so I really do want to come out of this with some actionable steps we can take to keep moving this process forward here in the
Thank
state.
you.
Representative Dathan has her hand raised. Go right ahead.
Thank you so much. And thank you, Walter, for all your advocacy here. As you know, Representative Case and I worked on the 5001 bill, and this was one of the key things we heard from the community, how many folks out there that have an IQ greater than 70 that weren't able to access services, but because their level of needs high. And I think you greatly pointed out, we do have a tool and process that is the level of need that really assesses folks and determines what is needed. We also have, an opportunity to really do this in a cost-effective way. In some of the things that we've talked about in the recommendations, can you kind of highlight the cost to do the initial sort of things that are contemplated with this bill?
Oh, I'm terribly, I can certainly get back to you on that. I'm not here prepared with a cost estimate on what it would take to implement those first two recommendations. But I'd certainly like to follow up with you.
Yeah, I mean, in my understanding, it's not like all of, our current system, we do have a high waiting list and we do need to make sure that we address those, but also making sure that we are looking at folks based on their level of need is equally important. And I see that some of these first two steps just keeps the conversation going, brings us in line to the rest of the country. As you highlighted, Connecticut's an outlier in how we are dealing with this and assessing folks and ensuring that we are helping those that are the most need to get services. But in my sort of analysis, I don't see a great cost for, implementing these first two recommendations really to get the sort of ball moving, if you will. So just wanted to kind of highlight that. So thank you so much for your testimony, and thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much for your continued advocacy. All right, next we will hear from Paula Greenberg, followed by Christian Duborg. Yes, Paula's on Zoom. You just have to unmute.
Hi, good afternoon. I chairs Lesser and Gilchrist, ranking members Case and Harding, and honorable members of the Human Services Committee. Thank you for the opportunity to provide testimony today on HB 7102, an act concerning maternal and infant health care. My name is Paula Greenberg, and I'm the president and CEO of Women's Health Connecticut. We are a management services company that supports a group of about 300 physicians, collectively called Physicians for Women's Health, serving many of the communities in Connecticut. Collectively, Women's Health Connecticut has had the privilege of standing up the first licensed birth center this year under the new regs in the state of Connecticut, and we appreciate much of your support in allowing birth centers to be a facility to offer to women in the state. We had the benefit of transitioning the only maternity hospital which allowed us to kind of move forward in a somewhat speedy fashion to make this birth center transition. As you consider the health strategy for putting up additional birth centers in areas of underserved markets, I want to provide you with our experience because I think there's some challenges and opportunities that we need to collectively think about in order to make sure that we're providing some thoughtful consideration about what it means to stand up a birth center and how to go about it. Again, starting from scratch, it's not for the faint of heart. From start to finish, it took us about 12 months to secure a facility, to build to the specifications, to complete the policies and procedures, to begin the accreditation process, and to achieve the facility and license requirements. In addition, there are payer credentialing matters and recruitment of the staff midwives. Midwifery recruitment is also a challenge as the model is very different than what midwives are used to in delivering care at a hospital. So it requires us to have seasoned midwives who have worked in birth centers previously and be able to work in a little bit more independently and to be able to recognize and appreciate challenges with the patient and be able to effectuate proper collaboration and maternal transfer. Additionally, we have to expect delays in reimbursement as once the license is issued, you're not automatically able to bill for services. So it takes an additional 30 to 60 day lag between that. Our patient population comes from across the state, New York, Rhode Island, Massachusetts, and our coverage is equally divided among Medicaid patients and our commercial carriers. This is important to ensure the success of a birth center as the operating costs are high. They must be in close proximity to a transferring hospital. While patients self-select a birth center experience, what we have been seeing in the maternity hospital as well as
Complete, please summarize.
And as we transfer about 1/3 of the patients into hospitals for epidurals, et cetera, we really need to consider that as a location. We must have partnerships with referring hospitals so that they can accept the midwifery practice and privilege in their facilities. I believe an assessment should focus on the limited number, maybe regional-based birth centers. And I think it's important for you to be aware that there are equity-backed companies in this birth center space that are emerging, and we need to understand this landscape as an important part of the assessment. Thank you.
Thank you so much. And we'll definitely go back and look at your testimony and learn a lot from you. Thank you. And congrats on opening.
Thank you.
Senator Lesser.
Yes, I share Chair Gilchrist's congratulations. It's great to see you providing those services. Just a question about how best to think about birthing centers. I know that we have a couple of different issues that we're working through as a state. We've got limited access to, well, we've got certainly health equity issues and cultural competency and a lot of bad outcomes in specific communities. I'm particularly worried about communities of color, but we're also seeing like specific regional gaps in access to labor and delivery beds, particularly where hospitals in rural areas have reduced. So as we're thinking about strategically making, supporting this type of facility, do you have thoughts about how we can best tailor our approach to meet the needs out there? And I agree with you on the need to be strategic. So I'm just trying to figure out how best to do that.
I would suggest, again, some regional pockets and with good transferring hospitals and I think patients, it's a unique patient that wants a birth center experience. We have to think about what messaging we are giving in those underserved areas. We don't want to do a disservice to them by standing up a birth center and not having the emergency transport, et cetera. Perhaps providing a mechanism for them to get to a regional center would make sense. I mean, we're strategically looking at where we know there are areas of need as we start to consider if we would take on birth center number 2. And that's kind of the strategy we've been thinking about is, can we create a regional center that gets a pocket of at-risk patients, but also that balance of at-risk and commercial patients in order to keep the operating costs tolerable. You know, just with Medicaid reimbursement alone, we could not keep this center going because of the operating costs. So I think we have to really think about how do we get that balance, and how do we leverage the patients in that in those communities, i.e. maybe New London could do Norwich, Bacchus, and Wyndham area. You know, could we theoretically do something in that community as an example?
You just answered my question. That was gonna be my next question, and you just answered it. So that is super helpful. And obviously we are along with everyone else in the healthcare space in this state and other states looking at changes to federal level, but also changes in business practices. And you mentioned private equity. So private equity firms are currently operating birth centers?
There's one in the New York area, ULA Health, that I'm aware of, and I know that they're partnering with Stamford Hospital. I don't know to what extent, you know, their midwifery services, but it's recent news and that we've been made aware of. There may be others as well, but that one I'm definitely familiar with.
Got it. And you're, I think you said this, but you are part of the DSS maternity bundle right now.
Absolutely. We've been part of the work group, and we have about right now 524 active patients in the bundle. So
thank you very much for your testimony.
Welcome.
Wonderful. Thank you so much. Thanks for being here.
Thanks. Bye-bye.
Next, we will hear from Christian Dubourg, followed by Kimberly Meerman.
Good morning, Senator Lesser, Representative not morning, definitely afternoon now. Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, Senator Marr, Representative Comey, and other distinguished members of the Human Service Committee. The Commission on Women, Children, Seniors, Equity, and Opportunity is pleased to submit written testimony in support of SBs 1416 and 1418, as well as HBs 7102, 7104, and 7109. I will be presenting this verbal testimony further on SB 1418, an act reducing barriers to food security. So my name is Christian Dubourg. I am the Food and Nutrition Policy Analyst at the Commission and the primary author of the Commission's report on the state of food insecurity in Connecticut, many of whose recommendations are reflected in this bill. We are very grateful to the committee for considering these concepts and for the opportunity to offer testimony. I timed myself trying to read through all the testimony, and it was way past 3 minutes. So instead, I figured I would use this time to briefly share about how our report was constructed, the key challenges that identified, and then the criteria we used to identify recommended solutions. So starting with the report's construction, we used 3 main groups of sources, the first being community input, the second being official data, and the third being published research. So over the course of 2024, we had the chance to conduct input gathering meetings with 107 individuals and small groups, as well as collect 163 survey responses from food organizations across the state, and pair that with published research and official data from state and federal government agencies, as well as academic research institutions, major nonprofits, and more. And the bottom line from the report was that food insecurity in Connecticut is unfortunately in a difficult situation and getting worse. Different sources quote numbers between 10.4 and 17% of the state's population experiencing food insecurity, but all agree the number is rising in recent years. The report talks about a lot of different possible underlying causes that are driving food insecurity, but many can be sorted into 2 primary categories. Accessibility, namely that there are parts of the state where unfortunately it is difficult to physically reach sources of food and get that food home. And then secondly, affordability. Unfortunately, many food items are simply too expensive for many households. And the impact of this is wide-reaching. In addition to the risk of hunger, there's also impacts on education and healthcare and housing, even life expectancy. And these impacts can be very expensive for the state. One study, for example, estimated that food insecurity was associated with an extra $1,800 per person per year in extra healthcare costs. And with regard to those challenges, the recommendations in this report reflected in sections 1 through 7 of this bill and the others in the report were based on 5 criteria. For the sake of time, I will focus just on 2 of them, addressing causes and effects, and fully funded with the potential for fiscal sustainability. So with regards to addressing causes and effects, The proposals in this bill were all designed to hopefully increase accessibility, increase affordability, or both. And then with regard to fully funded and fiscally sustainable, we understand that many of these proposals would stand up new initiatives or dramatically expand existing ones, and the commission would recommend that any resources for staffing and further resources be provided to the relevant state agencies to make that implementation possible. Thank you very much for your time.
Thank you for your testimony. That was an awful lot, and I think you got it in 3 minutes. Representative Hughes.
Thank you, Mr. Chair, and thank you so much for all your work that we can bring forward some of these recommendations. What do you perceive as the low-hanging fruit in terms of solutions regarding affordability and accessibility?
That's an excellent question, Representative. And in terms of low-hanging fruit, I will start by caveating that we don't, I'm not a fiscal analyst, so I wouldn't want to speak to the fiscal impacts. One thing that I think could have a very significant impact on food insecurity, hopefully rather quickly, would be establishing a state minimum SNAP benefits. So there are, the USDA conducted a study on the efficacy of SNAP, and it found that SNAP was effective in reducing food insecurity in nearly all subcategories of households, but one of the rare exceptions was households who receive the minimum amounts. Nationally, about 10%, the USDA says, of households receive the minimum amount, which is $23 a month for a household of 1 or 2. And so expanding support to households to be able to buy food, to be able to buy that food would be a way to immediately improve affordability.
Especially with, through you, Mr. Chair, especially with the increasing prices of groceries or, where we can spend those SNAP benefits. Is there part of that proposal around indexing those benefits to prices?
There is not currently.
Finally, you talked about this state and that there are sections of the state. I call it food apartheid. You called it food desert in your report. We talked a little bit in standing up the Office of Food Advocate about mapping where those were and having that like as a living map of how we can address that. I mean, Connecticut still is not a very big state. So it seems like the solutions, yes, they require some resources, but to making sure that we address the accessibility gaps where there isn't, transportation and there isn't grocery stores and there isn't anything but convenience stores or whatever. What do you think the solution to that would be?
That's a great question. Thank you so much. So yes, with regards to the food deserts, or the USDA will sometimes refer to them as low income, low access, or LILA areas. There are, according to the USDA, about 210 census tracts somewhere in Connecticut that have one of those designations. And I believe that it represents roughly 1/4 of all the census tracts in the state. In terms of one thing that we do include in the report in terms of a possible fix would be, one would be the establishment of a food business incubator program. So the report goes into detail on some of the barriers to standing up a food business, particularly a grocery store in general right now. And so having a program that could remove some of those barriers and facilitate these stores getting up and running, being able to accept SNAP and WIC and those sort of things would, if the grocery store is well placed, remove that LILA designation and provide an area, a location in that neighborhood where people could go. And that would follow a precedent that was set in New Jersey, which I believe, I'm going to forget the exact term now, but they have a food desert abatement program to which they allocate a substantial sum every year to provide grants and technical support and other assistance to help grocery stores that are willing to open up in those LILA areas and accept SNAP and WIC and other benefits.
Thank you for that. That sounds like a slightly multi-year phase-in project. And I was wondering if the Office of Food Advocate had any recommendations about the efficacy of your work as a standalone, as its own separate office, because we are talking about possibly 1 in 4 Connecticut residents.
So I would say that we currently don't have any recommendations on that at this time. So my position, I started in this position in January of last year. So we are still in the process of doing everything for the first time. And I don't believe that we would have any recommendations yet.
Okay, just for the record, Mr. Chair, I recommend we keep this office. So that we get more real-time data and analysis and some recommendations about how we, can efficiently and effectively and economically, address the food insecurity in Connecticut.
Noted. Thank you for that. I know that Congress is currently considering a 20% cut to the federal SNAP program, which would be a devastating hit to families relying on it in Connecticut. Do you have any considerations for how we should be planning for potential shortfall in federal food assistance? Other than hope it doesn't happen.
Yes, Representative. So one of the things that we consider in the report, and I know this might be a rather ambitious proposal, would be to create a food and nutrition special fund. And I know that this bill does a version of that, to be able to have state resources that could be committed to plugging any sort of shortfalls. I don't know if I'd be able to speak to any potential federal impacts in the future. What I could say is with regards to things that have happened in the past, since 2022, a lot of COVID era programs have been rolling off the books. So the SNAP emergency allotment payments of at least $95, those rolled off the books, and a study from the University of Pennsylvania School of Medicine showed that was associated with as much of a 21% increase in food insufficiency. So I would expect that reductions in supports, especially if prices were to keep rising, which at the moment the USDA expects prices to rise by another 3.4% in 2025. That would be a significant challenge for promoting food security. And policies like the ones in this bill or others would likely be needed to help plug that gap, be that support for the emergency food system, bolstering federal programs like SNAP with state resources, or some of these infrastructure focused plans to make food structurally more accessible and affordable.
Thank you. Other questions, members of the committee? Seeing none, thank you for your time. Next, we have Kimberly Meerman, followed by Marie Payne.
Yes, thank you. Chairpersons, ranking members, and members of the committee. My name is Kimberly Meerman, and I have 35 years experience in special education. I am also the parent of a young adult with autism spectrum disorder, or otherwise known as ASD. I'm here today in support of House Bill 7109, which addresses the age limit for applied behavior analysis, or ABA. Autism is a lifelong condition, yet ABA is the only therapy that has an arbitrary age limit. Occupational, physical, and speech therapies are covered for life. However, ABA, an evidence-based intervention, can suddenly be discontinued at age 21. This creates fiscal and emotional burdens for families, limits opportunities for our individuals with ASD, and ultimately increases reliance on state-funded services. Ensuring ongoing access would allow individuals to live and work independently while lowering the state's long-term costs. For my daughter, ABA services have made the difference between dependence and independence. 2 years ago, living and working on her own seemed out of reach. Today, thanks to my husband's employer advocating for these services to be covered by their insurance plan, she continues to receive EABA, which is helping her develop the skills she needs. However, not all families have this option. Many must navigate exhausting battles or forgo services altogether. This situation is really not sustainable, and it's certainly not fair. I urge the committee to pass House Bill 7109, amending sections 5 and 6 to replace, quote, under 26 with lifelong coverage. By eliminating arbitrary age limits, Connecticut would ensure that the individuals with ASD receive the necessary support for as long as they need it, promoting independence and alleviating the burden on state-funded programs. Thank you for your time and consideration.
Thank you for your testimony this afternoon. Are there comments or questions from members of the committee? Seeing none, thank you very much. Mary Painter, followed by Sarah Makowicki. And I should know that by now. Should know. I'm getting a dirty look, but I should know that by now. Sorry about it.
Good afternoon, Representative Gilchrist, Senator Lesser, Representative Case, Senator Harding, and distinguished members of the Human Services Committee. I'm Mairead Painter, and I want to thank you for the opportunity to testify before you today on SB 1416, an act expanding the long-term care options for Medicaid beneficiaries. I support Connecticut residents having access to information and choices related to their long-term care options and aligning those choices with their needs, preferences, including where and how they receive their long-term services and supports. Expanding access to home and community-based services allows individuals to remain or return to their communities with the necessary supports. Historically, individuals have often received biased information about the options they have or are presented with limited information, resulting in institutional settings being the primary place where they receive those services and are also influenced by this decision and can profit from it. I'm the co-chair of the Right Size Rebalancing Steering Committee here in Connecticut that works to evaluate regional trends in aging, identify gaps in home and community-based services, assess quality of institutional and community-based care, and assess the adequacy of the current structures in place. Addressing these factors also improves the state's ability to create more person-centered long-term care systems that prioritize choice and autonomy. Expanding home and community-based services also aligns with Connecticut's long-standing efforts to rebalance the long-term care system. Increasing opportunities for individuals to receive care in home or community-based settings allows for the state to improve self-determination and person-centered care. This will achieve long-term cost savings by lengthening the amount of time that a person can pay for their own care, providing less reliance on Medicaid, receiving matched by the federal government for dollars spent, as well as savings for the Medicare system due to reduced hospitalization. Research has consistently demonstrated that when individuals receive care in the least restrictive, most integrated settings, overall healthcare costs decrease and outcomes improve. Proactive steps to increase awareness and access to home and community-based services can also provide cost savings for the state. This can be through targeted outreach to Medicaid beneficiaries who may qualify for Connecticut Home Care Program for elders, as well as other Medicaid waiver programs, or individuals who would otherwise spend down their private funds in a skilled nursing facility to go on Medicaid. Continuing to have the Long-Term Care Planning Committee study and evaluate ways to expand the home and community-based services will identify cost savings versus just relying on skilled nursing facilities. The committee's report provides valuable insight into the financial and systemic benefits of increasing home and community-based availability and will inform further legislation and budgetary decisions. I've witnessed the positive impact that home and community-based services can have on the quality of life for individuals who require long-term care. When individuals have access to choose the supports they receive, many decide to return or remain in the community or the homes or the settings that foster the greatest autonomy and dignity. They report better health outcomes, greater satisfaction, and increased self-determination. These better outcomes create added cost savings because healthy, happy people are less reliant on and have lower financial impact to the system. In contrast, when individuals are only provided with information and choices related to skilled nursing facilities, the loss of autonomy and self-determination can lead to reported declines in health and well-being. On behalf of all of the individuals we serve, I urge the committee to support this legislation in giving individuals the need of information and supports across the state to access a full range of long-term care options. Thank you for your consideration, and I'm available if you have any questions.
Thank you for your testimony. I appreciate your support of this legislation and appreciate it. I know you were in the room for my back and forth a couple hours ago with the Commissioner of Social Services and just wanted to know if you had any thoughts on my questions to her about rebalancing and where we are, and then just also about that's question number one. And then question number two is about the specific issue about, and I know that you and I have talked about in the past about residents being directed in a failing chain from one home to another owned by the same operator?
Okay, rebalancing. So when it comes to rebalancing, I think it's really important that we as a state continue to listen to what individuals want and where they want to receive those long-term services and supports. Nursing homes are a critical component of our long-term care continuum, and we're always going to need them. I do think that we can start to use the expertise in nursing homes and help encourage them to diversify and provide that expertise in settings that aren't just looking like our typical nursing homes. Again, looking at the small home model, looking at the expansion of residential care homes where people can receive up to nursing home level of care under the waivers, and then independent community housing, and really allowing an individual to choose what setting best meets their individualized needs is what we hear from the individuals we serve that they want. They don't want us to decide for them where to receive those services and supports, and that dependent on their financial situation shouldn't dictate where they receive those services and supports. It should really be individualized. So I'm really hoping that through a lot of the bills that you all are moving forward over the past year to 2 years, that we'll be able to increase the footprint of long-term care where that expertise is provided, but honoring the fact that we do have caregivers that know how to do that. We just have to put the settings in place where people can feel proud to live and proud to work.
Okay. And then the second part about the
Yeah.
ping ponging.
So I know that you attended a few hearings related to the closures, one in your district. We've had other districts where there's been hearings. My team has been spending an extreme amount of time in these nursing homes working with these residents. And there's bonds that are built. For many residents, the individuals that give them care are their family. And so thinking about leaving that individual is very difficult. We know that due to the way that longevity works for many of these employees, they stay with the same company because they don't want to lose the benefits that they've received and the pay that they've received because of the amount of time that they've worked for a company. So they sometimes will continue on with the company, which I think encourages the individuals who live there to continue on with that same company as well, because they don't want to lose their caregivers. We did very clearly in each of the public hearings for these closures, ask the company if they had plans to close any of their other nursing homes where the individuals were going. And I believe in Middletown, one of the state officials asked them. And the only response we got was, we don't have any future plans at this time. So I think that for individuals, that was a little undermining to their decision. They probably would have made other decisions. And at the public hearing in Bristol, I think it was last week, there was one individual who commented, this is her 4th nursing home that closed or is closing, has the potential to close. And so for her, and I've literally followed her from every home. And so it is a huge impact.
So that's awful. I thought 2 was bad. I mean, 1 is potentially traumatic, right? These are the most vulnerable people in the state of Connecticut, by definition, or among the most. And yet we're uprooting them, taking them away from their caregivers, from a setting that they feel comfortable in, and we're sending them out. I get it, like the home goes out of business, that happens. But when there's a pattern where they're going from one failing home to another after another, is there anything we should be doing to protect those folks? Obviously, I don't want to be in a position of saying, no, you're not allowed to go to home X, but we have to figure out how to make sure that they're not being it sounds like it's such a traumatic experience. How can we best protect these folks given the extreme vulnerability of this community?
Transfer trauma is absolutely a concern for all of us. And we do discuss that and ensure that they have access to the information. We really sit down with each individual. We ask them about their choices, where they want to be, maybe family members are. We ask them to plan for the nursing home to stay open, because that's ultimately their goal most of the time. But also to plan, if they wanted to, where would they apply? What are the things that are necessary for them? And the bill that was passed last year, allowing them to jump into the nursing home that they'd like to jump that wait list, and be able to go there if there is a closure. I do think that dramatically has helped.
And you have wonderful staff and you're doing the best you can, but you're not in every home all the time. You can't be there 24 hours a day. So I am worried. Are you worried that when you're not there, someone else may be having a different conversation with the resident? And how do we how do we, account for that?
Absolutely, I am, and we know that that does happen. We have seen emails, there were emails that were brought to the hearing demonstrating that, which is always a concern, and so we're kind of always chasing that, right? My team members are there and saying, yes, but we understand that that's what you were told, however, and that can be very confusing for a resident or a representative of a resident who's trying to make the best decision possible during that period of time. For the abandonment legislation that was proposed, there's a bill this year related to nursing home abandonment. And that's one of the components that I had asked to be addressed in there, that abandonment isn't just walking away from, but it's also walking away from your responsibility to appropriately inform and explain individuals' rights to them and any of those components. So abandoning your commitment to and the requirements that you have, I think is also a form of abandonment, and there should be a level of accountability, not just related to a citation, which is often reduced, but criminal charges if there is someone who repeatedly impacts individuals and their lives in a way that is negative.
Are you suggesting we add criminal charges to this bill?
I did on the abandonment bill, that was in my testimony, yes.
And, okay, great. All right. Thank you. Representative Forty.
Thank you, Mr. Chair. And thank you, Marie, for all you and your office are doing. Again, I've spoken already today about the fact that 2 nursing homes are going through this process in Bristol. Many of the I don't want to say many, but a portion of the residents in these 2 nursing homes in Bristol came from Abbott Terrace in Waterbury, which was owned by the same owner. Abbott Terrace closed in November, I believe. I think it was the beginning of November, and that was closed for them, meaning, that was not a request to close. They were closed because of the conditions that existed there. Is that correct?
Actually, not exactly.
Okay.
They lost their certification from CMS for Medicare and Medicaid. They then decided, because they lost their certification, that they were not financially viable to have the residents living there. And so they decided to close because of that.
Okay. For some reason, I thought that they were more of an emergency closure. But so they went through the same process that the homes in Bristol are going through, essentially.
Essentially, the difference was that the Center for Medicare and Medicaid gave them a date by which things needed to be done, and they weren't. And so they then said they were no longer going to afford them the privilege to receive state and federal dollars for those individuals. And so they would either have to care for them or they would not support them through taxpayer dollars any longer. And because of that, they decided to close.
Okay. So again, my understanding is that they closed in the beginning of November. Did you ask them about the viability of the Bristol facilities when the proposal was made that some of those folks would come to Bristol facilities, the 2 owned by the same owner?
Yes, we did discuss our concern related to the number of people who were transferring to those homes, because proximity was very important for family members and friends that wanted to be able to continue to visit, making sure that things are on bus lines and people can get places. Many of the staff members went from Abbott Terrace because of the proximity. And the other issue is that when there are financial issues related to someone's Medicaid reimbursement, it would be challenging for them to go on to another company. So for some of these buildings, what we're seeing when we get to the point where there's a potential closure or request to close, that something has either happened with the business office, something's happened with someone's Medicaid eligibility, and that hasn't been followed up on. We saw that in Middletown as well. And so the ability for another nursing home or another company to take them on is very challenging. So they go to the same company to have those issues and concerns addressed so that they can then be accepted into another nursing home.
So basically the home they were in wasn't doing what they were supposed to enable them to be continuously insured by Medicaid.
It can impact their eligibility. Yes, we had eligibility issues, which is not uncommon when we have these situations.
Okay. And so when you asked the owner in early November or right before then about the viability of the Bristol homes, was there a response?
It was asked at public hearings. We asked, you know, what might happen with the other nursing homes. They said there wasn't a clear path at that time. I don't remember the exact wording, but we weren't given, I'm sure if we were able to tell the residents that there were going to be closures in those homes, they would not have transitioned at that rate of numbers, the high numbers that we saw.
So again, as you just said, both staff and patients transferred to the
Yes.
Bristol facilities.
Yes.
And the first letter of intent regarding these facilities was sent by the owner at the end of November of the same month. Is that correct?
They were close in proximity of time. I don't remember the exact dates, but yes, they were close in the same
Yeah,
period of
I
time,
think-
which felt a little,
I think within about 3 weeks.
it was very concerning. Because we knew then we were going to have to go and speak to these same individuals that really struggled and had a difficult time and were some of the last individuals to transfer from Abbott Terrace.
Right. Okay. Again, the bill this morning that we heard testimony from the commissioner on with the forensic audits, 7105. Are you confident that that will be a helpful tool? Again, we've talked about a particular owner all day today on this issue. And they still have other facilities around the state. And would this give them the tool to investigate basically all of those facilities and, you know, do something sooner than the point we've seen in the 3 facilities we just talked about?
So I think any additional tool to help rate setting, Nicole Godburn, and the accountability at DSS, look at what's happening in nursing homes or our long-term care communities and have that level of accountability. I'm all for, right? I want to make sure that we have those tools, that they're provided with those tools to have that accountability. I think right now, our state in particular is one of the states that does more of that and looks into things, and they try to move those things forward. So I'd like to see what other tools we can put in place so that we can continue to, again, have that accountability and reduce the risk of individuals experiencing these types of closures.
Okay, thank you. Thank you.
Thank you.
Thank you to the chairs.
Thank you, Representative. Representative Case.
Thank you. And this one's a little bit outside of the box, and I appreciate you coming here. We've had some discussions up here on abandonment. So we have a pretty decent rate of abandonment in hospitals. We're trying to find something outside of the box of somebody who can work with the hospitals to find places or find the right place for these people. Some of these people live in these, whether they're elderly or IDD, some are up to over a year.
Mhm.
And that's abandonment. Can you think about it and maybe get back to the chairs and myself and see, we're trying to figure out where to put that. We need a liaison or an ombudsman to help the hospitals figure out the best place to put these to home them. Because it's not in a hospital, and what it's doing to our hospital rates is. So it's a cost saving to the hospital, it's cost saving to the state, but it brings somebody to a real life place to go live their life. I'm sure you've heard about this happening.
Yes, I was on the work group for that. So I'd be happy to discuss that with you. I think we need to look at individuals' rights to return to nursing homes, involuntary discharge notices that are given, the reason they're given. They're supposed to be allowed to return. The federal guidance says that they're allowed to return to the nursing home pending appeal. We rarely see that happen. They're not supposed to have to sit in the hospital, but getting that transfer to take place and getting the person back to the nursing home during that 2 to 3 month period of time just for appeal doesn't always happen. So, and we, thank you to the legislature, do have our discharge portal. We are getting more and more data over the past 2 to 3 years on involuntary discharges, why they're given, who they're given by, when they're returned. So I'd be happy to discuss that. I have a lot of ideas and ways that could potentially be addressed.
Perfect. Thank you, Marie. Thank you for all you do. It's refreshing to hear that people are out there fighting for the ones who don't have anybody. And that's what I think some of us do up here, which is, it's a good thing. So thank you. And thank you, Mr. Chair. That was only one question.
impressive work, Representative. Thank you for that. Other questions or comments from members of the committee? Seeing none, thank you very much. Good to
Thank
see
you.
again. Next, we have Sarah Makowicki, followed by Tara Venus. Hello.
Hello. Good afternoon, committee chairs, Representative Gilchrist, Senator Lesser, ranking members, Chase and Harding. I am Sarah Makowicki, a student at UConn, getting my master's in social work with a concentration in policy practice. Today, I wish to speak to you on Bill 1421, an act concerning Medicaid coverage for obesity treatment. DSS has decided to ignore the directive of PA 2394 that FDA-approved GLP-1s will be covered under Husky. 1421 addresses drug pricing and creating a working group, but does not go far enough to address the current issues that obese people are having. I am one of those individuals. I am currently unable to refill my GLP-1 prescription because of DSS cutting off coverage. GLP-1s have changed my life. 4 years ago, I started my weight loss journey. I was 438 pounds. I was in constant pain from an old knee injury and needed replacement surgery. But to qualify for surgery, I needed a BMI under 40. At 438 pounds, it was at 69.6, which is considered super morbidly obese. Not something that you want to be super at. But what was super is that because I had lost my job during the pandemic and I decided to go back to school, I qualified for Husky. This provided me the time and the means to start my weight loss treatment through bariatric surgery and eventually using GLP-1 medications. I received outstanding care from Middlesex Hospital and my surgeon, Dr. Klimovich, losing 145 pounds and getting down to a 46.6 BMI. But then I stalled for a whole year. Frustrated that my weight would not budge and I still did not qualify for knee surgery, I started a GLP-1 in the form of Mounjaro, and the weight began to fall off again. I was able to get under the 40 BMI, have surgery, and now lead a pain-free life. Overall, I have lost a total of 229 pounds. I've included before and after pictures in my written testimony to entice you to go and read it. I know that my story is not unique. In Connecticut, 30.6% of individuals are obese with a BMI over 30. Vulnerable populations, such as those making under $35,000, make up 42.7% of the obese population, and it's predicted to rise to 50.9% by 2030. To put that into perspective, in another 5 years, half of the individuals that qualify for Husky will be obese. DSS is telling their obese Medicaid population that they do not deserve to receive life-saving medication. That instead of being proactive and encouraging weight loss with GLP-1s, the individual must wait until they are classified as diabetic, a reactive stance to healthcare. All of this to potentially save money. DSS has stated that by not covering GLP-1s for weight loss, it will save $28.8 million in 2026. But there is no breakdown of how many individuals use GLP-1s for strictly weight loss compared to those that have diagnosis of type 2 diabetes. It is only the first group that will save them money. Studies have shown that healthcare costs for an obese individual are twice that of a normal weight individual. And these numbers only increase significantly with each obesity class. My written testimony provides a breakdown of recommendations that should be added to Bill 1421 to provide a comprehensive approach to help people who are obese and are working to change that status. Thank you for listening to me today, and I can answer any questions you may have.
Well, thank you, Sarah, for your testimony and your compelling and powerful personal story. I think we should, just in the interests of disclosure, disclose that you spent a lot of time in the Human Services Committee, and we're very grateful to have your work as an intern for Representative Gilchrist. And it's been a pleasure to work with you.
Thank you.
I will say, you know, long before we knew you, 2 years ago, we worked very hard, actually over a number of years, but culminating 2 years ago in passing this legislation that provides coverage not only for weight loss medications, as we've discussed today, but also for bariatric surgery and also for nutritional counseling.
Yes.
And it's, you know, struck me in numerous conversations with the department, with OPM, with the governor's office, that they're only looking at one side of the ledger, which is they're looking at how much does this cost? And sure, it costs money. The drugs are very expensive. And I know that the country of Denmark, which produces a lot of the drugs, is doing very well. But on the other hand, and I think we need to do something about it. This bill is attempting to try to figure out what can we do with the federal government to do something about that cost. But there's obviously a benefit as well. And in your case, it seems like a pretty dramatic and powerful benefit. I'm imagining your doctors are happy that you are no longer where you were a few years ago. This is a huge health benefit to you.
Yes.
And I'm guessing a huge benefit to the state of Connecticut if you're not going to have a lot of healthcare costs that would be associated with being, what did you say, super morbidly obese?
Yes.
No.
Yeah, so so is there a question with that one?
Well, that was, there was a question. You answered it. You said yes, that's enough. You don't have to give me you don't have to expand on it.
I can
But,
expand,
but did they, I mean, you're here telling your story, but you're also wearing a public policy hat. And so what I'm trying to figure out is, did your medical advisors give you any sort of quantify the risk to you? I'm just trying to think about how we could get DSS and OPM to start crunching the numbers and look at look at the potential savings in addition to the cost, because I think that, you know, in your case, the time was so quick, right? This was a massive, rapid change, and it made your life much better. I'm imagining the savings are not 20 years down the line, but they're right away.
For me, I was a relatively healthy, obese person. So I was not incurring as many medical costs as others have. I did find a study that talks about the direct medical cost of obesity. So when you're talking about someone that is just in a stage or a class 1 obesity, the annual medical costs are going to be higher, and they're about $2,500 higher than someone who has a normal weight. And that only rises for each obesity class. So also this study broke down private payers and public payers. So it really does show the difference between the vulnerable populations. So for a public payer, they're going to be having to pay about $800 more than private payer for someone who is obese. Also, like I was saying, for each class that just, increases. So you're talking about, someone that is a class 1 obesity, which I actually am still considered an obese person. My BMI is still over 30. So yeah, it's slowly ticking down, but still it's, so someone that has the BMI of 30 to like 35, they're going to be costing, Medicaid about $3,000 a year. With someone with class 2, it's $5,800. And then for class 1, it's $1,700, class 2, $3,000, and class 3 is $5,800. But class 3 really only is categorized up to like a 45 BMI. So as someone that used to be, almost 70, we're talking about a lot of costs.
That is super helpful information, but we love to see the math that you've done to arrive at those figures. Could you just share that with the committee if that?
Yeah.
What we'll.
So,
with-
yeah, a link to that study is in my written
Oh,
testimony.
great. Okay, great. Thank you for that. And I missed that. One other question. I know Representative Gilchrist has some questions for you. I think she's obligated to, but she had some questions. Just my understanding, and I'd love to miss the opportunity to ask the commissioner this question. My understanding is that the department is looking now to specifically, they have come up with this proposal about when to cover GLP-1s and when to cover non-GLP-1 weight loss medications. But what they're specifically looking to do is remove those medications from people whose weight drops. So when the medication works, they want to take that away from folks and say, well, you're no longer obese, therefore you don't need the medication. What happens if we do that?
So, currently I've been off my medication for 3 weeks. It's not fun. My hunger is even worse than when, before, even with like my bariatric surgery and then before the, getting on the GLP-1s. So my budget actually went up because now I'm having to pay more in food costs because I'm hungrier. And then that increases the likelihood that someone is going to gain back the weight. The longer you stay on a GLP-1, yes, it's going to be expensive, but the more you lose that upfront weight, the longer you're going to keep it off. So, I mean, if they would allow someone to be on a GLP-1 for a year, 2 years, then they're going to be able to lose a significant amount of weight up front. And then they'll actually have the tools in place to be able to keep that weight off or maintain that weight loss.
So wait, you lost your weight loss access to medications under the current bulletin?
Yes.
But I understood that the bulletin was not supposed to take effect until June, until after the end of the legislative session. So the
Correct.
department is, that's what I understood the bulletin to say. So you're saying that the law, the bulletin is supposed to be the law. You're saying the department, despite the bulletin, discontinued your medications before June?
Yes. So 3 weeks ago, so that was middle of February. It might have even been before that. I went to go get my regular refill. They said to me, oh, they're asking for a code. I knew exactly what it was because of my work with this bill and with the committee and just, overall keeping track of the bulletin and all of that. So I was like, okay, well, maybe it's just like a glitch. And I'm
sorry, I don't mean to interrupt.
Sorry.
What did they tell you?
So they asked for a diagnosis code. So that is the ICD.
The pharmacist did?
Well, I asked because I knew what was happening. So I was in a different situation of, I knew the background behind the bulletin and like why it could have been not being covered. So I was able to ask the pharmacist, like, are they asking for a code? And she said yes. And so I went back to my APRN and asked her to put in a refill again, just thinking like, oh, maybe it was, pre-authorization or something like that wasn't going through. She informed me that nearly half of her Medicaid patients were not able to get their refills at that time.
Oh, okay. So this is disturbing.
Yes.
And I promise you, we did not plan this. I know
No,
that it looks like we have,
yeah.
but if there's someone from the department who's listening to this conversation, I would be really good to find out what on earth is going on, because that is
I
not
agree.
what we've been led to believe.
And for me, I knew exactly what was going on. And I'm just terrified for those people that don't know what's going on and all of a sudden their medication is being taken away from them. There's a lot of anxiety around weight loss and just these medications in general, getting them because there has been such shortages. my APRN tells story of one of her patients actually drove to Texas to get medication when it was in like the severe shortages time, because they were so worried that they were going to start gaining weight back.
So one last question, I don't want to have, we litigated your personal story and on CTN in front of the people of Connecticut, and I don't want to ask you to share more than you feel comfortable.
I'm an
One
open
question
book.
I had, I know that the DSS has said that they are willing to they're not willing. They are required by federal law to cover GLP-1s for FDA approved conditions. And I know that a lot of folks with severe obesity could be covered theoretically because of other eligible conditions. So that would include cardiovascular risk. I know you say you were a healthy person, but I don't know if you had talked to your APRN and seen whether or not those other diagnoses would fit your situation or not.
So for me personally, I did have to take a sleep apnea study before I received surgery. And I was borderline, but now if I went back, I probably wouldn't, because it was, inflammation in my, breathing region or whatever. And I wasn't even close to being pre-diabetic. I had fairly regular, blood sugars and all of that. The only thing that kind of gave me a comorbidity was my knee, because my orthopedist did say you need this replacement surgery. But my BMI was so high, that they would not do the surgery because of it.
Well, I think we just got a lot of questions we need answers to.
Yeah.
I would love to find out what the answers are, and I think the department knows where to find us. I will turn it over to Representative Gilchrist, who has a lot of questions.
Thank you. And thank you. You've been a lovely intern, but also more importantly, as we've discussed, this is a topic a lot of people don't want to discuss publicly. And so thank you for being someone willing to share your experience so that we can better understand. The question I have, the commissioner was here earlier, and it's been made public that DSS will cover 2 oral drugs for weight loss, Orlistat and Phentermine.
Yep.
Can you share any personal experience you've had with those drugs?
Sure. So both of those drugs have been on the market for over 25 years. Orlistat is at a low dose. You can actually buy it over the counter as Ally. And when I say that, a lot of people go, oh no, because when it first came out, everybody was so excited. And then the side effects are not pleasant. What Orlistat does is it absorbs the fat in whatever food you eat, and then it quickly releases it through your digestive system. So you can only imagine the side effects. And it also has severe stomach cramping involved with it because of the very quick release. My thinking behind it is that if you want these people to lead a healthy lifestyle, they're not going to be eating a lot of fat, and any fat that they do eat should be healthy fat, and that is needed for brain health. So it's just counterintuitive. Personally, I was prescribed the Phentermine Topramate. It's actually most known as Topramate. I had a horrible reaction to it. I experienced severe brain fog to the point where I had to take an incomplete in a class because I could not get my thoughts together enough to finish a paper. At that time I had to give a presentation for a class. Middle of it, my brain just shut off. And it pretty much put me in tears every day because I thought something was severely wrong with me. I'm talking the next day after I went off that drug, my brain cleared. So that is how I know it was because of the topiramate. Also, it is a side effect that is listed on various medical, websites for this drug.
Thank you. The final question, you mentioned having recommendations. What would those recommendations be to strengthen this bill?
Sure. So, I understand that DSS wants to cut costs. And I think that with that in mind, and just kind of putting up maybe some guardrails for unnecessary prescribing, to do some kind of step therapy for BMIs ranging from 27 to 30. So, GLP-1s are approved at a BMI of 27 with a comorbidity. So if you just, take that group and do like the nutritional counseling and maybe one of the other oral weight loss drugs that are cheaper, that may work for that group. And also anyone that is under or has a BMI from 30 to 35 that doesn't have a comorbidity or, cardiovascular or diabetes, that they should start with a step therapy, but no longer than maybe like 180 days, maybe even shorter, because most likely these people have been doing some kind of nutritional counseling or step therapy or, weight loss program at some point in their life, and it probably has not worked. So also, anybody with a BMI over 35 would not need to do any type of step therapy, that they would be able to get the drugs right away, because again, step therapy isn't going to work for them. It's just not. You need to work with a combination of a nutritionist with the drugs so that they are seeing some kind of, proof that they can lose weight. Also, anyone that needs a surgical procedure within like 6 to 12 months, because the higher your BMI, the more dangerous it is. My surgeon was actually very concerned about doing my my bariatric surgery because my BMI was so high. I lost about 60 pounds before my surgery because to prove that I could do it, and also to get my BMI down enough that he wasn't like, this is, a not good, deadly situation. So yeah, so those are kind of the start of what could be added just to provide some support for people who are obese.
Wonderful. Thank you very much.
Thank you. Any other questions? Representative Bale.
Thank you. Mr. Chairman, just one. So if the medication works and you get below a certain BMI, at some point you get to a spot where you maybe have a goal weight, and then would you have to continue to take the medicine, or would you be able to like maintain it once you got there?
So like I was saying before, the more you lose upfront, the more likely it is that you are going to be able to maintain that weight. There are the other oral drugs. I actually take an oral drug that is night suppressant. So that could be enough for someone that they wouldn't need the mechanisms in the GLP-1 to help them either lose weight or just maintain that weight. And also, if you lose a significant amount of weight, you've changed your lifestyle. You've been able to, figure out the tools that you need to be able to keep that weight off. So there is going to be a time when you can come off these medications and be able to maintain that weight.
Okay, thank you.
Thank you very much. Any other questions from members of the committee? If not, thank you, Sarah. This has been
Thank you.
extremely interesting. Next, next we have Tara Boots, followed by Sarah Egan. Tara, you are our last official member of the, we try to do the official testimony in the first hour and we missed that target. Sorry about that. And we're on to the general public exclusively for.
We're here for it. So good afternoon, Representative Gilchrist, Senator Lesser, Representative Case, Senator Harding, and distinguished members of the Human Services Committee. I am Tara Vines, Lead Planning Analyst at the Office of Policy and Management, OPM, and thank you for the opportunity to offer testimony on Raised Bill number 7108, an act concerning autism and intellectual disability. You have a copy of my full written testimony. I'm here to provide a summary for you today. House Bill 7108 reflects a sincere desire to broaden eligibility for services through DDS in the hope of improving access. However, its potential effectiveness is limited as this bill does not clearly identify additional funding or resources that will be required to support the evaluation and future expansion of services. In 2024, OPM contracted with Alterum Institute to develop the report titled Evaluation of Statutory Definitions and Regulations, pursuant to Public Act 23-137, Section 4. Section 1 of House Bill 7108 directs OPM to implement the first two recommendations of that report in regard to eligibility for services at DDS. However, it's important to note that these recommendations require extensive planning and funding to understand their impact to existing state services. If a new definition of developmental disorder is adopted, for example, it would also impact the autism waiver administered by DSS, as outlined in the report. The reference report was completed at a cost of $200,000. However, that study did not necessitate the extensive data analysis, predictive modeling, or interagency strategic planning that would be required under House Bill 7108. Based on industry estimates, OPM projects that funding of approximately $800,000 would be needed to undertake this work. The report findings clearly articulated that because this is a large-scale system change initiative and not a simple definition change. This process would span multiple years, so a reporting date of January 1st, 2026 is unrealistic to complete the scope of work outlined. Given the uncertainty at the federal level with the proposed funding reductions to key programs such as Medicaid and special education, exploring eligibility expansion at this time without knowing the potential impact to existing service recipients, nor an understanding of future funding availability would be imprudent and ultimately not achieve the intended goal of broader service availability. In addition, the governor's budget does not include the necessary funding needed to successfully implement the requirements of this bill and expand future services for those who do not qualify under the current eligibility criteria. And therefore, OPM must oppose the bill at this time. Further, Section 2 of House Bill 7108 directs the OPM statewide autism services coordinator to liaise with hospitals in Connecticut regarding the provision of care for patients with autism and IDD. The provision of direct services to hospitals is beyond the scope of this role. The state's various operational agencies already employ case managers, care coordinators, and ombudspersons and other staff who can assist hospitals. In conclusion, OPM respectfully requests that the committee oppose this bill as drafted. The bill proposes the continuing investigation of expansion that we already know will be costly based on the analysis provided in the study. And engaging in additional analysis without the proper assurance that more individuals will ultimately be able to access services risks unfairly providing false hope to stakeholders. A deliberate approach to broadening service access that is appropriately resourced by the state and federal government and that is operationally feasible is essential to ensure that the state can successfully respond to this population's needs. Thank you for the opportunity to testimony, and I'm happy to answer any questions.
So you don't like it? No, I appreciate your testimony and the concerns. One thing I was not aware of previously, do we have a number for the number of individuals with autism who are receiving the services from the state of Connecticut? Do we have any sense about that?
receiving services by,
Well, from the Department of Developmental Disabilities, but I don't think we have that number. I don't think we know that.
I don't know that they are tracking specifically who has autism and an intellectual disability, but they would qualify under many people who have autism who also have an intellectual disability would currently qualify under DDS. And then those who have an autism diagnosis without an intellectual disability would qualify under DSS.
No, I understand that. And, but I guess what I think we're hoping for is by, you know, having a central coordinator in OPM, you know, understanding that we are really good at siloing things in state government, having a better bird's eye view of the number of folks with an autism diagnosis might be a useful number to have. I don't know that that necessarily on its own solves anything, but it might
I mean,
be
we
useful.
haven't done any of that data analysis in the state to date. We do know that approximately 1 in 36 kids are being diagnosed with autism. So the rates are increasing.
Representative Case and, Representative Case.
And
Very, yeah.
the
Go ahead.
Department of Education on EdSite does have some data on the number of children receiving special education services who have an autism diagnosis.
Got it. Thank you.
Tara, I think thank you, Mr. Chair. And I think through what the chair was talking about, there are many different pots where the autistic population is pulling from, as we talked about when we built 5001 in 2023. So it's not just school age students. You have to go in, you have to look at DCF, you have to look at DOC, Department of Corrections, and they jump ahead of everything to get services when they get out. So there's a lot of different pots that we didn't know when we got you in the position to try to figure it out. Can we actually are we getting there with finding out all the agencies that have?
I have not done a census, to see what, how many people are in what department. Like I said, I don't know that. I would have to follow up with DDS to see if that's data that they can pull. I'm not sure that they track by diagnosis more who meets eligibility criteria. So that would be like a data analysis project that would be extensive to find out.
So once we diagnose and through 5001, does that put them in the age out, or is that just for IDD?
So the age out planning through DDS is anyone who has an intellectual disability and meets their eligibility criteria. That may be somebody who also has a diagnosis of autism.
Okay.
But they would have to have the co-occurring diagnosis.
So there's still a lot of works in progress. I think that the one that really shocked me was the DOC one. I'd like to see those numbers and see how that plays into the game. I didn't understand that in the beginning, and DCF one, we're protected because those are the numbers we didn't know. We couldn't get those from Department of Ed. So I guess there's more to come, but thank you for what you're doing, and hopefully we can lock down the numbers and figure out where we're going. But thank you, Mr. Chair.
Thank you, Representative. Representative Gilchrist.
Thank you, Mr. Chair. Thank you for being here today. Back to the initial piece of your testimony in section 1. So a study was done, right, on IQ?
Correct.
And in reading that study, there were next steps outlined. Is it correct, though, that in the governor's budget and for your department, there's no plan to take next steps?
The governor's budget does not include the additional analysis for the recommendations, correct?
And so then what we've proposed in this bill, does it align with the next steps that were outlined in the report?
The first 2 recommendations were to do additional research, specifically the predictive modeling, because it would, if we looked at what other states did, Washington, for example, if you want to look at the best way to look at it was Washington. So I would read that section in more detail, because they did change the service definition or the definition of intellectual disability in legislation. And then it took them multiple years. They're still working on trying to implement that. So that's a really great comparison. A lot of the other states, transitioned to more of a managed care model as part of a whole system revamp. But all the states took multiple years. So the first two recommendations are to do the additional predictive modeling and analysis to see what it would, it would impact the state. And then the second one is the definition change, but it clearly says they would not recommend a definition change without doing the additional analysis.
Okay, and so I said this earlier, I'll say it again. I would like to see us move forward. This is nothing to you. This is in your testimony about in this building. At this point, my head is spinning because it feels like when people don't want to do something, they're bringing up the federal administration. When they want to do something, they're saying we can't predict the future. And again, not you. This is now every room I'm in. So I'm gonna recognize what's happening federally, but I'm gonna keep moving forward for the things I want to see happen. And so I would like to see us, continue in this path. The other piece with Section 2 and the liaison, Representative Case and I had a meeting where this was brought to us by the Hospital Association. And so I guess I see where you've listed off some recommendations. It'd be helpful as we move forward, if it isn't your department, if you could help us kind of fine tune where that person could be, because what we're hearing is there are folks being left in hospitals, 1 or 2 each hospital, and the costs are astronomical, and the hospital staff does not have the capacity, time, training, it appears, to get those folks into the services they need. So we're hoping to get some kind of liaison who can connect for those folks.
Yeah. Yeah, no, I can, I know that I read through some of the other testimonies, and I know that DDS offered testimony that shared that they have people and staff that are already having these conversations. I don't know specifically who, or who at DSS is doing that work. But that's something that, I can follow up on and get back to you on. And reach out to them and see if there's a specific person. But I don't know who that is specifically.
Okay,
I
it'd be
just
great
know
to
that they have
continue.
case managers, if somebody's connected to the department already, they may have somebody who's operating in that capacity.
Okay, fantastic. And I'll check out their testimony as well.
Okay.
Thank you. Thank
You're
you so
welcome.
much.
Thank you, Representative D'Amico. You had a question? Yeah, why I was confused by the.
Well, I wasn't sure if I was, I didn't want to jump the line, Mr. Chair, but I guess it's my turn.
You
Thank
have not
sir.
dropped any lines.
Right. Thank you, sir. So thank you for coming and waiting and testifying. Appreciate it. So my questions and concerns are similar to those of Representative Gilchrist that she just expressed. So I understand the difficulty in implementing. Well, I kind of understand the difficulty in implementing what is called for in Section 1, which is to implement the first 2 recommendations from the November 2024 report. So I don't know that I necessarily agree that it's going to be that big of a burden, but I understand it's not called for in the governor's budget, but there's a lot of things that aren't called for in the governor's budget that need to get fixed, as we well know. So you're familiar with that expression, the journey of 1,000 miles begins with a single step. So what would your agency say is the single step to get us started in implementing these recommendations?
I think that what we're saying is that there has to be an investment in that, and that there isn't currently. The level of data analysis and predictive modeling, that's going to impact 4 state Medicaid waivers.
Okay. But it can be done, but it will take a lot of money and a lot of time. Is that what you're telling us?
That's what I'm telling you.
Okay.
When the other states, based on the data from the report, when the other states engaged in this type of process, it was a multi-year strategic planning process. So it was something that they did as a system, as an entire system reorganization, not just expanding access to one population.
Okay. And again, I share the good co-chair's frustration and desire to make some progress on this. So if you could give us some recommendations, I guess you did. You said you were going to have to dump a lot of money into this. Is that what it basically comes down to?
That's what I'm saying.
Okay. All right.
That's
Fair
what
enough.
the other states, experience was. And like I said, a lot of them moved to a managed care model. And I think that Connecticut has shown the service based on, so that's another factor that came into play with the report as well. So.
Okay. And just for my own knowledge and everyone's knowledge, how many other states do things the way we do it as opposed to the way that we are contemplating doing this?
That's a good question. I think that's where it gets complicated. Because you have to look at what states are doing fee for service, what states have a managed care model, what their level of need determinations are. Even if they're, they've expanded access by a specific diagnosis, it doesn't necessarily mean they're not using other level of need determinations to, allocate resources based on what they have. So I think that's where it gets really complicated. And that's why it's, the comparisons that were offered in the report help to guide us a little bit, that we can lean on what other states have done. Washington is the closest to Connecticut. So I would encourage you to read that in more detail if you're going to pick one to look at. And they did a lot of that system testing before they implemented it because they wanted to make sure that the change was actually increasing access. And that's why we would have to take a closer look at our level of need determinations. We would need to do extensive predictive modeling to ensure that that definition change actually translates to increased access. Because otherwise, all we're doing is increasing wait lists.
Okay. All right. Thank you very much.
You're
Appreciate
welcome.
it. Thank you,
And
Madam
I'm
Chair.
happy to have further discussion offline if needed.
Okay. Thank you.
Thank you, Representative. Representative Dathan has a question. She's on Zoom.
Thank you so much, Madam Chair, and thank you, Tara, for your testimony. It's nice to see you virtually today. I'm sorry, not in the room. I was a bit disappointed because we've put a lot of investment into looking at this. This affects a lot of people in our state that, really want to see changes that are made. And I think, one of the key things is, we do have a wait list of about 2,000 people on the autism wait list, but we don't have an idea of what, they're on the waiting list for. Maybe they're on the waiting list for transportation or job services or housing. We're not 100% sure. But I think without further investigation and continuing to look down this road, the recommendations are pretty clear and straightforward. I'm kind of at a loss how we've estimated an $800,000 cost for implementing recommendation 1. When some of these things, our Office of Healthcare Strategy does a lot of developing models and diagrams and does analyses to understand, the sort of drivers of these sort of things in our state. So I was a little bit surprised by that. And really, I think, and disappointed to hear that instead of trying to investigate how we can incrementally do this and make these recommendations and understand that this is a multi-year process, we need to have kind of a plan on how we get there. And I need to understand how we can service the neediest in our state. And I know, I understand that the Washington model is very similar to how we are, but we can certainly start this sort of process. And I think we can do it in a very cost-effective way. And really just wanted to say that because I was a bit, as I said, I was a bit surprised at the number in your testimony. and trying to understand that we really aren't going through all the sort of needs of the community and figuring out what our current wait list is waiting for and what they need. And really determine who are the most neediest. I mean, we have people who have a higher level of need that are over 69 IQ. And, Connecticut's one of a handful of states that has this sort of black and white sort of number that they're using to decide who gets services and who doesn't. We have a very effective tool in place with our lawn scoring and our lawn testing. And I do see that mechanism would be very useful in evaluating the waiting list and helping probably the neediest folks that need services, and just hopefully we can figure out a path to get there. And I'm delighted that I have people who are as excited about this, including Madam Chair and the ranking member of the House and others on the committee that have expressed their support for this. So I do hope we have an opportunity to continue to evaluate this, because this is so important for so many people. No specific questions. Thank you, Mr. Chair.
Thank you, Representative.
Mrs. Chair, I didn't realize we were.
That's okay.
And I can offer a little insight to the cost if you would like me to provide that, or I can.
I would love that if you could. I mean, because, here we have, the cost of the study was about $200,000. And I thought it was, a good analysis that was done. And when I saw your testimony having 800,000, it kind of caught me pretty off guard, because I was under the impression that looking at, the recommendations 1 and 2 were not as anywhere near that sort of ballpark. And I would love to get more information.
Yep. So I reached out to the consultant who did the work because they had the direct contact with other states to see if they knew what other states had spent to do that strategic planning process, and also what they, and, as a consultant who does HHS work nationally, if they had, some prediction on what this, would cost based on their work with other states. And so that's how we came to that number. So we did do some outreach to try to get some information based on what other states had spent.
Okay.
I didn't pull it out of a hat.
No. It seems a lot higher than when reading the recommendations, it didn't sound like it was going to be that extensive.
It's the predictive modeling for multiple waivers.
Yeah.
Data analysis, and then also over multiple years. So
yeah, and I guess I'm just confused, because this building does a whole lot of analyses in regards to doing, financial impacts to our budget. And when we look at legislation, when DSS goes through and does analyses over things, and, this is one of the key things that they do. So I was a little surprised that it was going to be quite so extensive. And again, just kind of would really like to figure out a pathway we can kind of get there. And understandably, it's not an overnight thing, because we don't want to leave people hanging in any form as we do this sort of process, but just want to carry on the discussion. So thank you so much, Tara.
Absolutely.
All right. I don't see the other hands. Thank you so much for being here.
Absolutely.
Next, we'll hear from Sarah Egan, followed by Catherine Strout.
Good afternoon to the committee. My name is Sarah Egan, and I'm the Executive Director of the Center for Children's Advocacy, which is a nonprofit legal services organization representing low-income children throughout the state. Here to testify on 7108 and 7109. Both bills we strongly support. They have multiple components. I won't go through all of them. I just wanted to highlight a couple of things beyond supporting everything the committee is talking about moving forward with what we have to move forward with to expand services for individuals with disabilities. Looking at section 2 of 7108, I just wanted to highlight when we talk about creating a liaison role for individuals stuck in hospitals, that also includes minors. And that data that Carolyn has put out as a behavioral health ASO for last year showed that kids with ASD are dramatically disproportionately stuck in hospitals. And in the fourth quarter of 2023, stuck kids with ASD in emergency departments were stuck there on average 11 days in the emergency department. So we have a lot of work to do to get these kids also unstuck from hospitals. Sections 3, 4, and 5, which have to do with reporting obligations about abuse and neglect of individuals with developmental disabilities. Our testimony contains some specific recommendations for your consideration about how to make that reporting meaningful, because it is a problem. I think this whole issue of how abuse and neglect is detected for people who are dependent on state services and how those concerns are resolved is one of the most important things I'd encourage the committee to add language about, so that the reporting is not just the incidents and how many were substantiated, but how many gave rise to a programmatic concern, how many gave rise to a directed corrective action, and in what time frame was that corrective action resolved. In my professional experience, that concern remains systemic and longstanding and unresolved. And we need some accountability mechanisms here at the legislature to make sure that those concerns, which are the type that state and federal auditors continue to find in Connecticut persist, need to be resolved through enhanced reporting and oversight. Last thing I'd highlight, 7109 which has a lot of wonderful provisions to enhance funding for behavioral health services for kids, including kids with autism. Obviously, and I understand why, the bill has language about increasing Medicaid rates within available appropriations. However, I wouldn't be doing my job as a lawyer for kids if I didn't underscore the fact that all of the problems we're talking about here in terms of access and availability have gotten worse over time for kids, and that kids covered by Medicaid have a federal entitlement to services within a reasonable period of time that are necessary for them, and not making those available because appropriations are not available is a violation of their rights under federal law. So I wanted to respectfully make that clear, but we support both bills and are happy to work with the committee on any enhanced language around those abuse neglect reporting provisions. Thank you.
Wonderful. Thank you so much, Sarah. And I know I'll be going back and looking and following up with any questions. Thank you so much for your work.
Thank you.
Next, we will hear from Catherine Strout, followed by Adrian Benjamin.
Can you hear me?
Yes, we can. Go right ahead.
Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Catherine Strout, and I'm speaking in support of House Bill 7108, an act concerning autism and intellectual disability. I have a 27-year-old son with a fairly high IQ, well over 69. He has many gifts and potential, but his challenges make it hard for him to function on a daily basis. His anxiety and executive functioning deficits challenge him every day. He could benefit from a mentor, job coaching, transportation, and help with activities of daily living. He needs scaffolding to help him to reach his potential. He will be able to work and pay taxes, but he needs help. IQ is not a good indicator of how a person functions. I'm also the co-chair of the Connecticut Council on Developmental Disabilities, and I have been trying to reach out to families in need with dependent adult children with IQs over 69 to help them utilize what little services there are in Connecticut. Here are a few examples of needs of people with the IQ over 69. A family has a son with an IQ over 69 who chases school buses and has been in trouble with law enforcement several times because of it. He needs constant supervision. He cannot work or attend school. Families of adult children with an IQ over 69 who have connective tissue disorders that leave them with short-term memory issues and cognitive impairments. They can't work or attend college. They are totally dependent on their families. They get no services. A great majority of individuals, specifically with higher IQs, are at home unsupervised because parents need to work. They have debilitating anxiety. They don't leave the house. They have poor hygiene. Some won't leave their rooms. They overeat, play video games, and have no idea how to change their situation, and neither do their parents. I have an idea. They need scaffolding, just a little help to show them that they have worth and build up their self-esteem. But Connecticut doesn't consider them disabled. They get no help. We have individuals in wheelchairs in need of personal care assistance with an IQ over 69, totally dependent on their aging families, who get no help because of IQ points. They may qualify for the PCA waiver, but that too is underfunded, so they get no help. I read both testimonies from the commissioners of DDS and DSS, citing lack of resources and staff that this bill would require. They say it's a bad year and that we don't know what Washington will do this year. When do we ever know? Wasn't last year a bad year and the year before that? Why can the majority of states provide for all people with disabilities no matter the IQ, but Connecticut can't find a way to do it? We can do it, but we're choosing not to do it. This bill is requesting that we do this process thoroughly and thoughtfully so that it is done the right way. These disabled individuals are waiting for us to step up and recognize their needs and show them that they matter to us. Connecticut continues to discriminate against disabled individuals with an IQ over 69, and it needs to stop. Please pass this bill and tell all individuals with disabilities in Connecticut that they matter more than IQ points and money. Thank you for letting me testify for this bill.
Thank you, Catherine. Thanks for hanging in there and thank you for testifying.
You're welcome. Thank you.
Next, we'll hear from Adrian Benjamin, followed by Wayne Grau.
Good afternoon. It's good to see so many allies. My name is Adrian Benjamin. First, I'll show you a picture of my daughter Zoe, because I'm speaking for her. She's a nonverbal 28-year-old with severe, profound autism. And she's adorable, and I adore her. But she is like a toddler. She's nonverbal. She has no safety awareness. I do appreciate all of you here. Representative Gilchrist, Case, Fortier, it's nice to meet you. Comey, I hadn't met you before yet. D'Amico and Dale, thank you so much for being here. I'm going to pretend like Senator Lesser is here because I want to answer the question he asked. The answer is no. DDS does not track autism. I have been on the Council on Developmental Services. This is not my speech. I have something else to talk about, but I have been on the Council on Developmental Services for 12 years and have asked repeatedly, could we please track autism? The numbers are going up, and 26% of people with autism have the kind of autism my daughter has, intellectual disability and autism, and are getting services from DDS. But we don't have the data to bring to you all next year. Hopefully we could do that and say, look at all these people that we're serving, but we don't have autism classes for staff. We don't have training. We don't have special resources for people with autism because they need different kinds of services than other folks that have IDD. So hopefully that can happen this year. But that's not what I'm here to talk about. I guess I'm always here to talk about all of these things. I like Bill 7108. My focus is on the investigation aspect of it. Let's see. Oh, I forgot to say my daughter lives in a group home run by HARC. My experience with investigations of abuse and neglect began on August 6, 2021, when I noticed bilateral hand fingerprint bruises on my daughter, on her arms like this. I was furious and worried. I took pictures, showed the house manager, showed the staff, and everybody says, we have no idea what happened. There's no report that she was upset and somebody had to restrain her, or that she was in danger. There was no mention of the fact that this had happened to her. So the investigation begins, and I discovered two disturbing things. First, agencies investigate themselves. That's the norm throughout DDS. Clearly, that is not really an independent investigation. Big conflict of interest. Second, once the investigation begins, parents and guardians receive no information until the investigation is over. I was politely told numerous times by case managers and others, no, we cannot tell you anything until the investigation's completed, which leaves family members very worried. Is that staff member still there? What's happening? My daughter cannot talk. She can't use a message board that explains things. So,
Your time is complete. Please summarize.
okay. The investigation is supposed to happen in 3 months. Her investigation took 6 months. That delay is very serious. And the way investigations are run, the answer is either substantiated or unsubstantiated. Because they could not find who did this to my daughter, the end of the report was it's unsubstantiated. So in DDS data, those bruises don't exist. Those bruises happened, they're documented. And yet the way unsubstantiated or substantiated happens, I'm sure we can all think of things where we don't know who did something, but that doesn't mean that thing did not happen.
I am unfortunately going to have to ask you to summarize.
Okay. I am.
I
Four,
know.
four
I know.
suggestions.
Okay.
4 suggestions. One, there should be a third option. The report should have said, we know Zoe was injured by a staff person. Unfortunately, we don't know who. That should have been the result of the investigation. They should be independent. Maybe DDS could collaborate with police departments and train independent investigators to do this work. And there needs to be some transparency for the family because it's just terrifying to know that someone's hurt your child and you don't know who, and they might still be there, and that's it. Thank you very much.
Thank you, Adrian. Don't go anywhere. There's some questions. I want to start, I don't think I quite got there for you all, but in 7108, I don't know if you have the bill in front of you and you don't.
I do not.
Okay, that's fine. It's requiring that the Secretary of OPM in the autism department track the total number of people waiting for autism services versus receiving autism services and their associated levels of need, and to do a plan for addressing those with autism with high care needs. I missed the part of what is the number of individuals with autism. So I would just love follow-up from folks so that we can get the pieces right on what we're actually looking for.
Okay. Well, I'm part of Profound Autism Alliance and Connecticut Advocates. It's a group of about 25 of us who've been meeting monthly, well, twice a month actually. And we want to know how many people DDS serves that have autism.
Yep.
Now, who's on there's also a waiting list of 100 people on an emergency list and 700 people on an urgent list. But they also have levels of needs and a history. So we should be able to get those numbers too. Every person who's graduated from high school has a diagnosis, right? So, and we all have every individual has a case manager and the case manager has that data. It's not like they have to start going back hundreds of years or dozens of years, but they do have to get someone to coordinate and obtain that data. I think it would help us immensely.
Thank you. Representative Comey?
Thank you so much. It's great to meet you. Adrian, right?
Yes.
Thank you.
Thank you.
And thank you. Your daughter's very lucky to have you and your husband I see behind you. Oh, that's not him.
I'm just a friend. Unfortunately, my husband's not here.
All right. All right. We'll just move on to my question. So,
we're buddies.
Forget
We're
it.
we're colleagues. We're
that'd be
colleagues.
nice. All right.
We're colleagues.
I hear you. So I'm a little confused about, you said that your daughter was at a Hark house.
Yes, group
Okay.
home. Yeah,
A
she
group
lives in
home,
a
sure.
group home.
Group home.
After my husband died, I couldn't take care of her anymore and she had to move into a group home.
Absolutely.
Yeah.
You reported that she had injuries, or you suspected that she had, been injured by some staff or some other person. Did you report it to the police?
No, I
Okay.
reported it to it didn't seem severe enough for me
Sure.
to report to the police.
Sure.
I reported it to the first to the house manager.
Mhm.
And second, I called my case manager and told her. And she said, well, we have to have an investigation. I said, of course, because everyone here says they have no idea what happened.
And that's where I'd like to come in and say, so you're saying, I mean, I know that Park is an independent nonprofit.
Yes.
Although, so I'm just wondering, you said that DDS investigates itself.
The
So I'm
ag-
trying to see the connection here.
The agencies investigate themselves. So DDS trains people at the different agencies, the
Okay.
management team.
So when you meant agency,
To
you meant
do,
Park.
yeah, so agencies and Hark investigates themselves.
I see.
It's 2 months, they have 2 months to do their investigation, and then
Mhm.
DDS has an arm for more investigation.
Mhm.
They basically go over the investigation
Sure.
to see if it's adequate. And it took 6 months for me to get the answer that her
Yeah.
injuries were not substantiated.
Yeah, I actually was, it reminded me of, a case I'm helping a resident, a constituent of mine. She, had been hit by a car and they couldn't
Okay.
find the person. So it's now been almost, 6 months at least. And the police are saying it's unsubstantiated as well.
Wow.
So I don't know if that's
Wow.
part of, I don't know a lot about the judicial system, but I'm wondering if that is sort of connected. But I just wanted to explore a little bit more about that, but I thank you for coming in and being an active participant with your organization. That is a excellent advocacy group. Thank you.
Thank you so much.
And a few more. Representative Dathan, followed by Representative Vale.
Thank you so much, Madam Chair. And Adrian, sorry I'm not in the room today. You've been such a wonderful advocate for Zoe and for this whole community. And again, I'm sorry you've had to experience this. Just a quick question, because one of the things I think that people don't recognize is, we have these long waiting lists, and we have it broken down, as you had said, from sort of urgent to, critical and whatever level of where they are in the wait list. When you were waiting for a place for Zoe in some sort of group home, how long had you been waiting before your husband died? And what kind of where was she on this sort of wait list, if you will?
Well, before he got sick, I mean, he ended up getting cancer and he was sick for about 6 weeks before he died. We were on the urgent list, meaning we wanted to have support like in a year or two. We weren't yet on the emergency list. Once he got so critically ill and it was obvious that we were gonna lose him, Zoe went to the emergency list. But it took 3 months to find a place for her, and it was during the pandemic. I mean, I'm incredibly appreciative because DDS and Hark bent over backwards to help us and find a place for her. So 3 months wasn't bad. I know there's
Yeah.
people that have been on the urgent list for 6 years.
Well, that was actually going to be my question, because those are some of the stories that I heard. You have the sort of planning list of we're going to need services at some stage, and then you have the urgent list and then the emergency list. And I've heard stories along the way that, folks are staying on these emergency lists. And I think Rep. Case had mentioned earlier that folks, sadly, are in a position where they are so desperate, needing help for their loved ones and can't get it. And frankly, rely on emergency rooms to manage the
Yeah.
situation. And I'm pleased to hear that, Zoe was able to get a placement relatively quickly. But it is difficult. And because the list, as I had referred to earlier, we don't kind of break out what the services are for the autism. We do for the DDS services, so folks understand, what the sort of needs are, but we don't do that for the autism on the autism waiting list. We had tried to achieve that in our 5001 bill in 23, and that unfortunately is still not quite happened yet. And I know that we're working towards it, but it's advocates like you that really get this message out there to folks to really see and amplify the need for these services and the need for people to, for us to get some more information to help everyone. So thank you so much, and thank you, Madam Chair.
Thank you very much.
Thank you. Representative Dale.
Thank you, Madam Chair. Good afternoon. You had mentioned that the numbers of autism cases are on the rise. Is that correct?
Yes.
And again, I was 20 years old before I ever even heard of autism. Now is obviously we're much more aware. And obviously the only reason I heard of it is because of that movie, Rain Man. That was
Right.
actually, and so, it's much, you think we just didn't talk about it as much and people didn't know about it as much back then and now people are more aware? Or do you think that it is actually increasing? And if so, why?
Well, I would love to have the answer why, because we do not have the answer. When my daughter was, when I was in graduate school in 1986, the rate of autism was like 1 out of 1,000. And then when she was born in 1996, it was 1 out of 300. So that's a pretty big leap in those 10 years. Now it's 1 out of 36. And certainly there's more awareness and more concern for the earlier the diagnosis, the more chance there is you can help somebody. But there's genetic factors, could be environmental factors. I mean, the CDC is working on this, an agency, a journal in England called The Lancet, a very respected medical journal, is still asking questions.
That's pretty significant though.
Yeah.
Based on the numbers, that's like a 30% increase.
It's incredible. Yeah.
That's, so there's got to be something contributing to that. So,
Absolutely.
all right.
Yeah.
Thank
No,
you.
it's quite a crisis, actually. Yeah. Thank you for asking.
Thank you, Representative. Let me just check Zoom. I don't see any other questions. Thank you so
Okay,
much for
thank
being
you so
here,
much.
for your
Thank you.
continued
Thanks
advocacy.
so much.
Wayne Grau, followed by Rick Sebastian. Just have to push. Oh, there you go.
Thank you. Good afternoon, Chairman Gilchrist and members of the committee. Thank you for allowing me to testify about HB 7106. We are opposed to the legislation simply because the work that this committee did last year is working. We are lowering the repair times for wheelchairs, and we ask that we're given enough time necessary to continue improving repair times for consumers utilizing complex rehab technology or CRT equipment. My name is Wayne Grau. I'm the Executive Director of the National Association for Assistive and Rehab Technology, or NCART for short. NCART works with manufacturers and providers of CRT equipment by focusing on access issues for consumers. The service and repair issues facing the CRT industry have been building nationally, and it's just not specific to Connecticut. However, with the passage of SB 308 last year, Connecticut now leads the country with meaningful legislation to improve repair times. NCART actually highlights this legislation. I'm working in 14 states, and I use you guys as an example. The industry has collaborated with consumers on areas of improvement starting well before the legislation. The industry has also made significant investments into the repair system without any increase in state funding for travel and evaluation time. The companies have added and are continuing to add technicians and third-party companies to help out and to assist with repairs. The data from both companies continues to show a month-over-month improvement, as we're getting approximately with the new numbers at 82% compliance within the 10-day deadline. The average for repairs beyond the 10 days is about 12 days, and that brings us up to over 90% compliance. Now, the Connecticut law eliminated prior authorization for Medicaid consumers effective July 1, 2024, and was applied to other insurance effective January 1, 2025, just a couple months ago. However, I just need to make you aware that still 35 to 40% of Connecticut's consumers still fall under insurance that requires prior authorization for these repairs. Now, at the consumer's request, we have been reporting all this data, even though those numbers would be skewed a little bit higher. We've also been very cooperative in reporting data beyond the original law's scope because we want to fix this issue in Connecticut and the entire nation. The law just went into effect January 1, 2025, the full effect. We asked the committee to allow us the time to continue meeting, which we want to do, and making the improvements to the CRT repair process that Connecticut consumers deserve. Thank you very much.
Thank you. Thank you, Wayne. Representative Case.
Wayne, thank you for coming. I know you had to travel. What in this bill here, we talk about the wheelchair and mobility scooter. What does that change throughout this legislation?
We were originally, when the task force was put together, the consumers had brought up scooters. We were a little surprised by that because the original task force only really covered CRT equipment from our perspective, okay? And adding scooters, I just need to make you aware the scooter market is much different than the complex rehab technology market. There's over 175,000 units or scooters that are sold in the United States every year. There's over 300 internet companies that sell scooters directly to Connecticut consumers. And most of your home medical equipment companies and local pharmacies also sell scooters as well. Our concern is, and my concern is, how are you going to regulate that? Does DSS, do they have the ability to do that if that's the regulatory body? Again, scooters were originally developed for more seniors. That doesn't mean some people with debilitating diseases like ALS, they may start in a scooter and then eventually progress. But scooters are really designed for people who walk long distances. That's why you see them in grocery stores and airports and other areas. So I'm not sure if the committee understands how big of an issue that is. And that would be just a concern of ours.
Thank you. And, our main concern in what we're trying to do is make sure that those people, that anybody who needs something repaired, I don't care if it's your wheelchair or your car, you want to have the best place to go and get things fixed on a timely manner. I was fortunate to sit on the first task force and work through a lot of things. It's crazy, but if you don't have your mobility, you don't have your life. And I think you're in the business to try to keep the mobility. But I look at it also as there's a difference between a provider and a contractor, correct?
Yes, sir. A provider is someone that just has a relationship or meets the requirements of the state or an insurance company to do it, which, a contractor would be specific and have to meet, certain areas. Otherwise, they're in complete violation of that contract. I'm not a lawyer, but that's how I understand it.
And I just say that because I want to make sure that we're clear when we do legislation, because we have contractors, we have MTM, we have non-emergency medical training. They're a contractor. That's all they do. You're a provider that works with private insurance, state insurance. How does that work for your company throughout other states? I think this is pretty comprehensive legislation. We're trying to work and make sure, once again, I'm a big proponent of special needs, bigger proponent of people of the most vulnerable population. We got to get to the bottom of it. We got to get things fixed.
Yes.
Where does this compare to in other states?
You guys are way ahead of the curve. California used to have the reputation as being the most disabled, individual-friendly state. You've bypassed it now. The legislation that you worked on last year is working. And again, we're taking that information, we're taking that language. I'm working in 14 states. I'll be in Oregon and Washington next week. So I would say, let us continue to do what we're doing, continue to show. We want to continue meeting. The meetings with the consumers have been good. Sometimes they can be a little contentious, but that's okay. But we are working to get this better. And that's got to be the most important point because, sir, you said it. Consumers deserve to have their equipment fixed as fast as possible. We agree with you 100%.
And I think we beat it up pretty bad the first time around as far as staffing. Everybody wants more staffing. I mean, the business I'm in, I can't get enough staffing. You're in 14 states, I'm in 28. So it's difficult all the way around the country, everywhere we go. I just want to put the bottom line, and people come and they're passionate, and my heart drops because we need to make sure we're doing the best we can. And I just hope we can get you and your counterparts to stick with it, but we have to be, everybody talks about the private equity, well, we're having that, and also the nursing home industry. Everywhere you go, But I talked to a nursing home the other day. They have to bring a private equity company in because they have no money to do the upgrades. They don't do the upgrades, they close. I don't know how that affects your line of work. But I think you have the passion to make sure people's stuff is fixed. Is that correct?
Sir, I looked at all of you. Originally started talking to Representative D'Amico, met with the chairs, met with you, and I gave him my word. We were going to get this fixed. We are. We just need that time to, finalize it and get it to where it needs to be. We need to make repairs as fast as possible, and I believe that we're heading in the right direction, and with over a month is showing that.
And just for full disclosure, I had to go and visit your place. I think it was one of yours.
It was one of our members, yes, sir,
So,
new motion.
It's imperative that for us to look at it if anybody hasn't, because the back warehouse is just jam-packed with labeled jobs ready to go, just waiting for parts. We got to get past that.
Yes, sir.
We got to get things fixed. And you had a lot of used stuff that you were quote unquote pilfering to try to get used parts to move on. You saw a room of stuff, but some you have to fix with factory parts.
Yes, sir.
And not Band-Aid. It's a bigger issue than a lot think, but I'm here on Human Services. I've been here 13 years doing this. It's important that we make sure people get their mobility. And I think that's what your job, that's what we're charging you. There's a lot of stuff going on. This bill passed the way it is. We'll have to hit 3 other committees if we don't adjust it. I don't want to see that happen because when things move to 3 other committees, we're not going to get anywhere. Because it has to go to insurance, has to go to judiciary, has to go to appropriations. We need to get something done in here so everybody can back on the page. I hope you guys stick with it and you keep moving forward so we can have a comfort level that we're doing the right thing. I thank you for coming out.
Yes, sir. Thank you.
Mr. D'Amico.
Thank you, Madam Chair. Wayne, thank you for coming in and testifying, and I will second what Representative Case had to say. You were involved in this from the beginning. You and I had many conversations. You were involved and very cooperative and helpful in the original task force that Representative Case was on, and yourself and many other people. So I appreciate all the willingness to cooperate and work together. So I just wanted to acknowledge that. But now I'm going to ask you a couple of questions.
Yes, sir.
As you can imagine. So the first question has to do, and we've talked about this a little bit today, and I just want to get your take on it. I appreciate your statement that repair times are getting better. But we've heard from so many people in both oral testimony and written testimony that in many cases, the repair times are not getting any better. So to what do you attribute this problem, and what can we do to fix it?
Well, sir, one of the people that testified was Mr. Tubman, and he had, I think everybody got a copy of a letter that he had sent to New Motion CEO to cease and desist, educating consumers about quicker repair times within the shop versus in the home. Okay, even though the letter did say technically it was correct, but in there he had cited a number saying that one of them, New Motion's particular, was at 35% compliance. I looked at that letter again. That's October of 2024, 2 months after the start of the first initial phase of the bill. We didn't get prior authorization eliminated for insurance until January 1, 2025. But again, the data that's being reported, the last data showed, and this just went in, I think, Monday, that they're upwards to close to 80% and NSM's higher than that. So again, it's really the trajectory that's happening rather than just one particular number that was based on 2024, October. So as I would say, I would look at those numbers and see it. Let's look at the data and how it's being reported.
Okay, thank you. I'll have to take a closer look at some of these numbers. I appreciate that. So the second question for me, if I could, Madam Chair, is I was struck in your testimony, in your written testimony, in several places you mentioned that I don't want to misquote you, so I'm going to look and see here. There's no need to legislate something the industry is doing in cooperation and willingly. I think you've said that several times. There's no need to legislate something the industry is doing in cooperation and willingly. So, which sounds fair enough. However, what's wrong with putting it in legislation? I mean, it seems to me that in order to do this right, rather than just take it on the good faith of people, and people in industry come and go, as you know. So rather than just take it on faith that they will do things willingly and cooperatively, what's wrong with putting it in legislation?
Sir, I would say to that, at the beginning of this initial task force, as I said, it wasn't always, we disagreed a little bit. And part of that was on the scope of the law. What would include, what it would not. Scooters were one of those issues, but was it just Medicaid? And you're gonna have to excuse me, I forget the third one, okay? But when the consumers, we talked about it, we agreed that, you know what? They want the data presented this way. Let's do it. Matter of fact, the folks worked with Mr. Tubman and Mr. Sigworth to go ahead and develop the form so we can get a consistency to it, okay? So I would simply say we're already doing that work. I don't know why things would have to be legislated. You could always, if we stopped, I'm sure we would have a bill introduced saying you got to do it. But again, we're willing to do it. I just don't see the need to go ahead and legislate that if we've said we're more than willing to do it and continue to do it. That's just my perception, sir.
Okay, I don't know if I agree with that, but I appreciate what you're saying. Okay, all right, thank you very much.
Thank you, sir. Good to
And
see you.
again, thank you for your willingness to talk about all these issues. Thank you, Madam Chair.
Thank you, Representative D'Amico. I've got to sign up. I've got to grab this computer over here. Is anybody online want to speak up? Is there anybody waiting? Okay. All right. Thank you very much, Mr. Grau, for advocating on behalf of your membership. Thank you. Next, we have Rick Sebastian.
Good afternoon. I'm Rick Sebastian. I'm the president and CEO of the Kennedy Collective, headquartered in Trumbull, Connecticut, and doing support services in about 105 communities throughout the state, specifically for people with disabilities. The Kennedy Collective, formerly the Kennedy Center, is celebrating our 74th anniversary this year of providing services and supports to people with disabilities. I'm here today to speak in opposition of House Bill 7107, an act concerning janitorial work for people with disabilities and other economic disadvantages. This is a restated bill from last year, Senate Bill 312, and I oppose that bill as well. The title of the bill sounds good. The nature of the services inside the bill, not so good. This particular bill, if enacted and going forward, would result in the elimination of employment for several hundred people with disabilities. It also eliminates the ability of social enterprises like the Kennedy Collective to do business as a contractor for the state of Connecticut. We've had janitorial contracts, we've had groundskeeping contracts, we've had warehousing and distribution contracts as a private nonprofit contractor, not as a funded entity. We're using our social enterprises, which are triple bottom line businesses, the bottom line of increasing employment for people with disabilities. If we look around the country, the unemployment rate of people with disabilities ranges from anywhere of 75% to 82%, depending on the country, being unemployed. The second bottom line in a triple bottom line social enterprise is a positive impact on the environment. The Kennedy Collective has invested thousands of our own dollars to become a SIMS GB certified, internationally certified janitorial contractor. We're a federal janitorial contractor, a state of Connecticut janitorial contractor, and a private commercial janitorial contractor. This particular bill would eliminate us from being a state of Connecticut contractor and moving all contracting to the small business world. We also relate to small businesses. We partner with service-disabled small businesses, woman-owned small businesses, minority-owned small businesses. We are a workforce producer for the small business community. The terminology that's also being used that's somewhat difficult in this particular bill has to do with the nonprofit sector being community rehabilitation programs. This particular bill points to a preferred purchasing program that dates back to 1974 and a newer program dating back about 12 or 13 years ago, the Qualified Partnership Program. If we were to go forward with the QP program here in the state, the nonprofit contractor, like the Kennedy Collective, would cease to exist as a commercial entity because we're not recognized by DAS as a certified commercial business. We've proposed language, we've given it to representatives. That language hasn't made it into this particular bill. We're happy to have conversations about what language could actually continue to support and create increased employment for people with disabilities and economic disadvantages. I could speak to every bill that has
Your
come
time is
before the
complete. Please
committee this
summarize.
afternoon. And one of those pieces of speaking to every bill is that we're a traditional human services contractor and we're an innovative entrepreneur in creating employment. I believe that the bills that we've just heard about with 7106 and the wheelchair repair, the social enterprise community, the disability community who employ people with disabilities could potentially become an answer where we are providing technicians to repair those particular wheelchairs, and we have people with disabilities who can do that. 7108, the autism bill, we have a number of high functioning people with autism that have IQs over 69 that could also be providing supports for these types of people living in wheelchairs. So I respectfully submit that if we move forward with 7107, it will result in less employment for people with disabilities rather than what the intended title of the bill is. Thank you very much for your attention and for your consideration.
Thank you, Rick. I do see Representative Dathan has her hand raised. Go right ahead.
Thank you, Madam Chair, and thank you, Rick, for your testimony. It's nice to see you virtually. Sorry, I'm not there in person. Just wanted to kind of highlight a couple questions. I know there was a few people who supported this, including the ARC of Connecticut, which is an advocacy group that helps people and advocates for people with disabilities. And they were supportive of this because it's regarding a technical change. And I guess my question to you is how can we kind of figure out putting these two things together? And I hear what you're saying, but I'm also hearing what the advocates are saying. Could you share that with me?
Sure. Thanks, Representative Dathan. I failed to mention in my introduction that I too am an advocate. I have an adult daughter with a disability. I've spent my entire professional career advocating for people with disabilities and terminal illness. As it relates to what we can do to assuage certain advocacy groups or even the state, include the nonprofit contractor in the bill. Don't eliminate nonprofit contractors who are janitorial contractors and have been janitorial contractors. The Kennedy Collective, Easter Seals up here in Hartford. We have CW Resources. We have any number. We have Easter Seals down in Waterbury. We have any number of nonprofit contractors with the state that currently have contracts. Those all get taken away if this bill is moved forward, because that contractor then becomes a placement agency to a small business who has less of a responsibility to employ the number of people that we're employing as a nonprofit employer. And so that's one particular aspect. The second aspect of bringing this together is to look at what the intent of the bill is supposed to be doing. While the language that came over from Senate Bill 312 last year is essentially the same, the addition this year of a task force to look at increasing employment here in Connecticut is admirable. We actually support that part of the bill. The task force is a great way to start. I just shared that the social enterprise community, those organizations that are committed to creating employment, have solutions. Listen to those solutions. Listen to those nonprofits, not asking you for increased funding, but asking you for an increased level playing field as it relates to being a contractor with the state of Connecticut.
Okay, that's helpful. Because I know the Nonprofit Alliance also spoke in favor, but I'm looking at your testimony and I am hopeful that I can work with my good chair here to figure out a good solution because, everybody wants to have a really good solution for folks with disabilities to be able to have satisfying work. So thank you for your testimony. And I also agree that the task force, as much as it is hard to go and study stuff and do this, I think it's really the right direction of our leaders in this committee to recognize that. So thank you, Madam Chair.
Thank you, Representative, and I welcome the opportunity to work with you on this. And we'll be reaching back out. So thank you
All right.
so much.
Thank you.
Next is Victoria Staub, followed by David Morgana.
Great. Thank you. And thank you for having me today. My name is Victoria Staub, and I'm the clinical director of the ICAPS network. That is the Intensive In-Home Child and Adolescent Psychiatric Services. And I'm here specifically in reference to HB 7109. That has some workforce stabilization recommendations specifically for the ICAPS network. So just a little background in case anyone is less familiar. ICAPS is kind of the program for kids who are in psychiatric crisis. It is an intensive home-based program that works with a child and family for 6 months following an inpatient psychiatric hospitalization or residential stay. We're working with families who are highly stressed and threatened and often have layers of complexity and difficulty in multiple domains of their lives. We have 16 sites across the state with no coverage in Windham County or New London County. ICAPS was initially envisioned as a level of care to be offered to all kids across the state needing this kind of intensive service following a psychiatric inpatient hospitalization. Just kind of to maybe push back against some of the thoughts folks have maybe on that this intervention is too expensive. We've really run the numbers and found that 6 months of ICAPS is almost equivalent to a 12-day inpatient psychiatric hospitalization. So, the loss of the service would mean for a child who is decompensating, maybe they would go to outpatient, but outpatient would be intense enough. They would be hospitalized and then need some kind of step down. And this is where ICAPS would come in. We know from decades of quality assurance and improvement data that this program is very successful at reducing inpatient hospitalizations, reducing the number of days a child needs to be hospitalized when they are hospitalized, and reducing emergency department visits. This is really one of the most vulnerable subgroups of children and adolescents with behavioral health needs, and in my view, as such, should really be invested in. Last year, largely due to legislative advocacy, ICAPS Medicaid rates were increased after well over a decade of neglect. At that point, the network was really on the point of potentially kind of crumbling with several sites about to pull out. But because we got kind of through a lot of the work done on these committees, because we got supplemental grant funding and Medicaid rate increase, we had several sites stay in the network.
Your time is complete. Please summarize.
So I guess the big asks are really to, now that the network is stabilized, to have some kind of way to onboard sites that cannot take the financial loss associated with onboarding. So the training and the quality assurance and analysis is really an additional cost. And additionally, we are kind of looking for other sources of money to support our training and quality assurance section. So I guess that's all.
Great. Thank you so much, Victoria. I continue to learn so much whenever you testify, so thank you. Anyone with questions? I don't see questions. We'll go back and take a look at your testimony. Thank you.
Great, thank you.
Next is David Morgana, followed by Matt Barrett. Is David Morgana with us? Okay. Matt Barrett. There he is. And then we'll hear from Todd Johnston.
Thank you, Representative Gilchrist, and to the distinguished members of the Human Services Committee. On behalf of the Connecticut Association of Healthcare Facilities, a trade association of skilled nursing facilities and assisted living communities, my name is Matthew Barrett, and I'm the association's president and chief executive officer, and I appreciate the opportunity to provide testimony. Although I do want to indicate I'll be testifying against a number of bills on today's agenda, beginning with Senate Bill 1415, an act concerning Medicaid and Medicaid funded programs. Section 1 of the bill would require a Connecticut nursing home to implement a schedule of wage increases to employees who provide direct care, so that all such employees attain a minimum hourly wage of $22.50 no later than January 1st, 2026, and $25 not later than January 1st, 2027. And the bill goes on to define direct care in a way that is consistent with the existing definition of direct care under the Connecticut General Statutes, and also consistent with the pending nursing home staffing regulations that are before the Regulations Review Committee. And at the outset, I want to say a provision that correlates the sufficiency of available state resources and an intended wage increase amount is, in our view, essential to assure both the nursing home operators and their direct care employees that funding simultaneously be increased and specifically included in the Connecticut state budget to fully fund the increased costs of any new mandated requirements, including the incremental increases in the minimum nursing home wage from $25 by January 1st, 2025. For example, in the past, nursing home wages, benefit, pension enhancements have been specifically delineated in the final Appropriations Act of the year that they're designated. And there has also been a corresponding statutory provision for the purpose of implementation of those detailed wage enhancements. And this bill, while very admirably spells out, unless state rates of payments are sufficient to fund such rate increases, I want to emphasize that language, unless state rates of payment are sufficient to fund such increases. And I want to say that I love that language, but I also want to point out to the committee that mountains of things have to happen to connect those two issues, the sufficiency of funds and the public policy that is adopted. We think, and it should be adopted under the statutes. And so we're recommending that much more detail be included in any provision, whether it's this provision or a provision in another bill, or if there a final provision in a budget implementation bill later in the session, which is commonly the way we have seen these events unfold. And our testimony provides a lot of detail of the measures that we think should also be in the statute, including not just the wage, benefits, and pension enhancements, but making sure that the set-aside appropriation for the wage, benefit, and pension enhancements also accompany a very detailed fiscal impact analysis that aligns with the appropriation that is set aside, and also a statutory implementation language that also aligns, and that the fiscal impact and the appropriation should address all of the identified cost increases. Yes, the wage and benefit and pension enhancement, but there's also a whole range of co-related increases.
You've
Like-
reached 3 minutes. Please summarize.
But I'll summarize by saying that I usually say I've submitted detailed testimony that includes all these provisions. I do want to confess I will plan to submit the detailed testimony after I leave the hearing, and I brought it with me today. But in any event, I have details concerning the language that we think would be necessary in this bill or another bill. I'm grateful to the Human Services for raising this issue. So I think this is a hugely important concept, aligning the sufficiency of resources with the public policy on wage enhancements, whatever it is, or wherever it's adopted. I have similar concerns, which is why we're opposing Senate Bill 1417, an act concerning the establishment of a nursing home workforce standards board. Again, testimony on that regard. Testimony in several other bills. And if I, with just your indulgence, Representative, I do want to register our strong opposition and indicate that we hold Commissioner Barton Reeves in the absolute highest regard for her integrity and the job she's doing as Commissioner of Social Services. But we fundamentally disagree with the authorities that the agency is seeking concerning forensic audits of just 3 provider groups: nursing homes, residential care homes, and facilities that care for the developmentally disabled. Hospitals, every other provider community is not subject, isn't proposed to be subject to the forensic audit requirements that are proposed here. And with that regard, thank you so much for the opportunity to testify.
Thank you. Thank you very much. And once you submit, we'll go back and look at it. Thank
Okay.
you. I appreciate it. Thanks for being here. All right, Todd Johnston, who's online, followed by Hannah Hussey.
I am the Vice President of Advocacy for the Spinal Cord Injury Association in Connecticut. I'm a 64-year-old paraplegic who uses a power wheelchair. I am in support of HB 7106. After having a repair done on my power wheelchair at New Motion, I took my dog for a walk on a trail near my home. After going about a mile down the trail, my wheelchair stopped functioning. The joystick gave an error. I would turn it off and turn it back on and perhaps be able to roll a couple of feet. I kept doing that procedure until it just stopped. I used my personal emergency response system to get assistance. While waiting for help, I called New Motion and left a voicemail. And then I received a text message stating that someone would come out on Saturday. A couple of policemen came out and found me on the trail. They assisted me back to my van. Once at my van, I turned on my chair and it worked. I rolled up my van's ramp, got into the van's driver's position, and requested that the policeman come to my home in case the wheelchair should die before I get underneath my ceiling lift. I parked my van in the garage and I rolled down the ramp and the chair died again. The policeman then assisted me into my bedroom underneath my ceiling lift. A New Motion technician came out on Saturday, and knowing the repairs that were done prior, he brought with him a couple of batteries, which he replaced in my wheelchair. The wheelchair ran, so he put it underneath my ceiling lift so I could get into it after the batteries charged. After 4 hours, I got in my chair and started to cook dinner. While I was cooking dinner, the chair died again. My PCA pulled me back into the bedroom and put me underneath my ceiling lift. I contacted the New Motion technician who just put in the new batteries and told him the chair died again. He said he could come out on Sunday, which he did. He looked at the chair and saw the error and he swapped out the joystick cable, but the error still existed. Unfortunately, Monday was a holiday and New Motion was closed. On Tuesday, a New Motion technician came out and checked all the cables, made sure that they were all seated properly, and the chair worked fine after that. So, Friday afternoon until Tuesday around noon, I was out of the ability to use my power wheelchair. Under the suggested revisions of HB 7106, it says, make clear that the duty of emergency repairs, the need for which occurs on weekends and holidays, extends to actually repairing the device on those days. Please support HB 7106. And I would like to add, Wayne Guru from NCART was only talking about remote in-shop rates for New Motion, not in-home. Their January data says 37%
You reached
is what they did
minutes.
for
You've
in-home.
reached 3 minutes. Please summarize.
Thank you for allowing me a testimony.
Thank you, Todd. Thank you for sharing your experience. Have a wonderful evening.
Thank you.
Next, we'll hear from Hannah Hussey, followed by Jan Kitzman.
Hi, good afternoon.
Senator Lester, Representative Gilchrist, and distinguished members of the Human Services Committee, thank you for this opportunity to testify in support of House Bill 7022, an act promoting equity in Medicaid coverage for fertility healthcare. My name is Hannah Hussey. I'm a staff attorney at GLBTQ Legal Advocates and Defenders, also known as GLAD Law. And I'd like to start by thanking the chairs for their leadership on fertility and reproductive health issues. Turning to HB 7022, I'll say that LGBTQ people strive to create families just like other people do, but they often face barriers to obtaining the health care they need in order to do so. This legislation is important to promote equitable access to fertility care for Connecticut residents. Right now, Connecticut does not provide adequate health insurance coverage for people on Husky Health who need fertility treatment. We appreciated the testimony this morning indicating fertility preservation may be covered in some circumstances. That was really the first that we've been hearing of that. And in fact, we're aware of people who have experienced denials for needed fertility treatment and preservation services. This gap harms those who may be least able to afford to pay out of pocket for the steep costs associated with fertility healthcare, exacerbating disparities. For example, even though Black women are twice as likely as white women to experience infertility, they're less likely to receive fertility care. Similarly, data suggests that LGBTQ people are more likely to be covered by Medicaid than non-LGBTQ people. For low-income LGBTQ people who need but cannot afford fertility care on their own, existing state policy leaves them with few options to build their families. Importantly, this bill would define infertility to align with the standard of care articulated by the leading medical organization in this field. It would secure and expand coverage for individuals enrolled in Husky, including fertility preservation services and some forms of fertility treatment. And it would provide for further study on the cost of providing IVF coverage through Husky. The bill would also align Connecticut with other states in supporting its residents in accessing the care they need to build their families. 5 other states provide Medicaid coverage for fertility preservation, and at least 4 jurisdictions provide Medicaid coverage for fertility treatment. GLAD Law would support a very small tweak to the language as written, just for the sake of clarity. And we'd suggest that in section 1B, the words fertility treatment could be inserted between the words such and coverage, which is in line 40. I'll close by just saying family building is incredibly important to so many people. And unfortunately, this is healthcare that's just so often out of reach due to cost. HB 7022 is an important step to ensure that Connecticut provides fair access to fertility health care. GLAD Law hopes this committee will support this legislation and help move Connecticut families forward. Thank you for your time and consideration.
Thank you so much, Hannah. And I appreciate you bringing up the preservation. I had heard too, I do work with endometriosis here at the legislature and had heard that for those with Medicaid, they couldn't get preservation. So I'm interested to know more about the medically necessary that the Department of Social Services. What has been your experience? Can you elaborate on that just so we can better understand the maybe?
Again, our understanding is that there's a lot of people who are not accessing it. I understand the testimony this morning was that when medically necessary, there may be circumstances in which people are. That's great. Again, we haven't been aware of that, and that's not, I think, may not speak to many people who really need this coverage in a more expansive way.
Great. Thank you. And I'll look at your testimony for that technical fix. Senator Lesser.
Thank you. Can you, and appreciate your testimony and your support of the legislation. Can you, I'm also interested in the preservation part. Do you have more information about what other states have defined as medically necessary? We're just trying to understand what that means.
I would have to pull that up, but again, I think what this bill is looking at is the ASRM definition, which is really the gold standard in this field. And that includes several different components when talking about infertility. And that's, I think, the aim of this bill is to ensure that there's a definition that speaks to the range of needs that Connecticut residents have around fertility.
Okay, and that's available on the ASRM website, is that?
And we've cited to it in our written testimony. I mean, I can, if you want,
No,
tell you it's, okay.
Well, thank you. I'll
I'm
find-
happy to read it, but I know you've got a lot of folks still on the list.
we have a few bills, a few little testimony in front of us today. So thank you very
Yeah.
much. I'll take a look at it and really appreciate it, Madam Chair.
Absolutely. Take care.
Great. Thank you. Have a great evening.
You too.
Jan Kritzman, followed by Gretchen Raffa.
Please press the button, Jan.
I'm not loud enough. Good late afternoon, members of the Human Services Committee. My name is Jan Kritzman and I live in Newington. In 2004, my husband and I each bought long-term care insurance policies from Transamerica Life. It seemed like a wise choice at the time since our experience with our own parents proved that statistically 50% of people will need long-term care. Of course, that was decades ago when the cost of nursing home care was not up for discussion at the kitchen table. Two of our parents needed long-term care while the other two parents died after brief illnesses. In our case, what seemed like a straightforward, affordable product, $1,000 each annually, has now ballooned into an expensive trip to the casino, and policyholders are the losers at the wheel. Do we get rid of it? Do we take the buyout? They've offered us a buyout. I'll get to that in a minute. And do we continue paying painful premiums? This year, it's going to be $7,000 for both of us. Or do I keep buying Mega Millions tickets so I can ditch these policies? Here's my ticket. They draw tomorrow. We'll see what happens. Last week, my ticket landed in the trash. I have no reason to oppose Senate Bill 1420. I would just like to see some more meat on its bones. It's too skinny. Senate Bill 1420 should also include a buyout offer, not just a return of premiums. There is a difference. For example, Transamerica Life doesn't offer a refund of premiums, just a buyout. My buyout offer from Transamerica is $71,000. They aren't offering me a refund of premiums, fine, because that would only be $35,000. But for my husband, Transamerica offered him a buyout of $23,500. His refund of premiums would be $35,000. For him, that's a much better deal than a buyout. See, a policyholder should have a choice. The face value of our combined policies is $1.1 million. This is after 21 years with an inflation clause. The buyout is 9% of the value of these policies. Transamerica would get off the hook real easy if we take the buyout. Of course, then we don't have long-term care. The policyholder should have a choice. The language in the bill, I think, should have to say that. These long-term care companies should be mandated within Senate Bill 1420 to offer an either or. By the way, either option is both state and federally taxable. Another fly in the ointment. Why the great disparity between my husband and me? I'm told when I called a very robotic lady on the other end of the line at Transamerica, quote, because you're a girl and he's a boy and girls live longer than boys. So much for gender equity, and that's not the case in my family. Example, add buyout to Senate Bill 1420, Section 1, Paragraph C. Now, about reinsurance payments to long-term care companies. Some of these companies get a percentage of their money back when they have to cover claims paid out. Did you know that? So where is their loss?
Your time is complete. Please summarize.
I think you legislators should develop an Office of Long-Term Care Funding where everyone pays a small percentage of their paycheck toward this fund, just like paid family leave. Because right now, long-term care is in shambles. I await your questions.
Thank you very much. And Representative Vale has his hand raised. Go right ahead.
I guess it's evening-ish now.
Yeah.
Good evening,
Yeah.
late afternoon.
Yeah.
So when you initially, do you remember what your premium was when you initially bought the policy?
As I have stated back in 2004, it was $1,000 each.
Each.
And also we were told that it wouldn't raise up. The premiums wouldn't raise up.
It
anymore.
shouldn't theoretically, because your benefits that you're purchasing at the time are they rise with inflation because you got
I had an inflation.
you had an
clause.
inflation
Yes,
clause.
which I
so-
paid for.
Yes, so it's a per diem, right? It used
No,
to pay X
no,
per
it's a,
day
no,
to-
no, it's a set amount.
Yeah, it's a set amount per day.
Yeah.
And that would increase every year. But the policy premium shouldn't increase. I actually know something about this, so I just want to
Good.
get confirmation from you. So it's like buying life insurance. You purchase life insurance when you're 35, and they do the calculations based on statistics and actuarial information that says, okay, if you pay this per month, then you're locked into that whole life policy at that rate. Well, long-term care insurance was supposed to be the same because you're purchasing a benefit that's the same no matter what.
No, it's not the same. No.
I think
Okay,
you're
it's not.
misunderstanding me
Can I,
because
can I tell you, when we first bought the policies, it's a partnership with Connecticut Partnership
Yes.
Policies. Each policy had a face value, was worth 200,000 each.
Yes.
I paid extra for a 5% inflation
Yes.
clause. Now I reduced that inflation clause from 5% to 1.98 to reduce the premium by, I don't know, maybe a couple of $100 each 3 years ago.
But so there's initial cost for the premium. You added a rider for that inflation so that it would go up, but you have the same amount of coverage regardless of what the nursing home cost. It was $200,000. How much is it now?
About 535, 550, something like that,
and-
after 21 years.
Exactly.
Yeah.
So we're on the same page. I just don't think when you get health insurance and you
Mhm.
go there, the cost of health insurance goes up, your cost of insurance goes up. Your plan is worth $535,000
Each.
regardless of
Mhm.
what the nursing home charges, is what I'm trying to get at.
Yes, of course.
Okay, so
Yes,
yes.
any nursing home,
So
yes.
it should be able to, it's supposed to be set at that rate and that calculation. What are your chances on going into a nursing home?
50,
Basi-
50.
You know,
50,
well, based on when you bought it.
Mm.
Okay, so it's all actuarial stuff. I'm on your side on this. So I don't understand why it has to go up. The only reason it would have to go up is because more people are going into nursing homes and it's costing them more money.
Can I
Or
tell
they
you-
did the wrong calculations to begin with.
Bingo.
So that's on them. But
Mhm.
because they put it in there and when you were sold the policy, you were probably told it's very unlikely that those premiums would ever increase.
Bingo.
Okay, so I understand that, but they leave a little clause in there so they can increase them based on the claims that are made. Then they have to come in front of us and ask if they can do it based on the cost and all this other stuff, which is kind of BS. Okay, so I'm with you, but you got to understand, it's a different than health insurance. It's a indemnity policy.
Mhm.
So at the end of that, and if you participated with the partnership, that at the end, then you would have went through the policy and then they would start to go through your assets would be protected up to the amount.
to the
Now
amount.
it would be 535,000.
Mhm.
When you originally got it would be 200,000.
That's if I
So-
choose to keep the policy.
Yes. Now, if you
It's
don't keep the policy, all
$7,000 a
that
year,
benefits
all
go
that
away.
Go.
Yes.
All the money that we put in, total together, my husband and myself, $70,000 down the drain.
Yes.
Okay.
And-
Now, if I take the buyout, let me explain. If I take the buyout, my buyout and his buyout is about $95,000. This is Connecticut, state of Connecticut income taxable and federal income taxable. Okay. Puts us into a very much higher tax bracket. Okay. And disturbs our social security benefits. So I'm debating, should I take the buyout or not? Should I keep paying?
But your premiums should offset any, so if you paid $70,000 in and they're offering you a $90,000 buyout, you should probably only be
No,
paying
no,
taxes.
they're offering me 71,000. My husband, 23,005.
Okay.
The buyout, because he's a boy and I'm a girl, and girls live longer than boys, or so this woman told me on the phone from Transamerica.
But it is based on those actuarial
Okay,
statistics.
can I tell you something about actuarial statistics?
Yes.
Okay. Every year or whenever, every 2 or 3 years, whatever, the Transamerica asks for an increase in premiums. They'll ask for like 78% and they'll get maybe 35 or 40%. And it's spread out over a period of 3 years. I would love to see it spread out over a period of 5 years. It's a lot easier to take than just 3 years.
So
Okay, 3
I'll
years goes
assume,
by real quick.
I'm going to assume you were about 25 years old when you bought your policy. Okay. So,
You flatter me without any reason to
Okay.
flatter me.
right. So,
Guess,
should be,
guess how
but
old I
at-
was
I'm not saying anything other,
21 years ago. Be brave. Tell me, how old was I?
36,
No, 57.
57. So,
21 years ago. You add it up.
but I got it.
Yeah.
But based on that, at that time, it should be based on the probability in your lifetime that at 57 years old, that someday you're going to need to go into a nursing.
One
If
of
that's
us,
what,
50,
so if you
50.
were 53 at that time, you would have paid less, obviously.
It
but
would
it-
have been a little bit less.
But it's
About-
all
about-
based,
About $800
yeah,
a year.
it's
instead of
all
1,000.
based on the probability of
Mhm.
during your life that eventually you might go into a nursing home.
Okay.
And those numbers should not go up the way they have.
No, they should not. Okay, now what happens is they request every year. I think Transamerica's made a request 5 years in a row for rate increase. And they ask for the moon and they get a couple of stars and another planet thrown in, okay? And we pay, and it's really outrageous. The reason why we are told by the Connecticut Insurance Department is that, well, the actuaries, they misjudged the whole thing. They didn't think people would live so long. Well, excuse me. I didn't mean to live so long. Okay. And then they had no idea that inflation would enter into it. You know, I've lived through lots of periods of inflation. What are they? Stupid? They didn't count on any inflation. And if I had known then what they were really doing, which was kind of like tricking you into buying this, it's not good insurance at all. Okay. Tricking me into buying this, I would never have bought it.
Well,
I would have bought, I don't know, Bitcoin or, I got that lotto ticket there.
yeah. Well, it's tough because you're one of the few people that actually took the initiative to buy it to protect your assets
Yeah,
and to
yeah.
make sure, but instead, so there's no incentive for people to purchase that type of insurance if they're going to go through this. And then everyone's going to end up, having to rely on the government
On
to
Medicaid.
do that.
Yeah.
So
I
it's very frustrating that this is
at
happening.
the time, okay, that I would, even now, right now, I consider if I dropped the policy or take the buyout, which is not particularly inviting, if I drop the policy, okay, I may at some point, 5-10 years from now, wind up in a nursing home, use up I will have no insurance if I drop it, okay? Now, Medicaid. Thank you, taxpayers of Connecticut Title 19. I think Medicaid is going to go bust. There's so many people going on if they didn't buy this. Maybe it was smart that they didn't buy this. When I'm in the checkout line at the grocery store or at Sam's or at Costco or something like that, and I say to the person next to me, and I say, do you have long-term care insurance? Of course, they think I'm crazy, which probably is true. And they turn to me and they say, no, I think I'm all set. And I say to them, you must be a multi-millionaire. The next person in line, I say, do you have long-term care insurance? No, they look really, really worried. I said, well, what are you going to do if you land in a nursing home? And they look at me and they say, I don't know. I don't know.
Well, they're going to bleed down your assets unless,
Yeah,
again, and
yeah.
there's a 5-year
What
look
about the
back. I
spouse?
think it's used to
about
be
the
60
spouse?
months.
What about the spouse that's
Yeah.
not in a nursing home?
They're screwed.
They're screwed.
It sounds like it, yeah.
Sounds like it, yeah.
Mhm.
Uh-huh.
So I hear you, but, all right, so I don't know.
Well, here,
Certainly
can
listen
I say-
more about it.
can I say one more thing? I'm looking at you folks on the Human Services Committee, and some of you look pretty young, okay? And some of you look, a little bit older. And the ones that look old, the ones that look young, okay, they haven't even thought about this. And the ones that look older, like you, sir, a little bit worried, all right? Okay, now you older people, you look a little worried, and with good reason. Remember, 50% of you will wind up needing long-term care. That's you, not you, not you, not you, and you.
Thank you very much. I don't see any other questions. We really enjoyed your testimony.
Oh, by the way, I have just to ask, Rep. Dathan. Rep. Dathan, she maybe left. Anyway, maybe
Yeah.
we could, get her a message from me. She's on the, what's the committee? That's a new committee this year. She's the chair
Mhm.
of, what's it called?
Government something, government oversight.
Oversight. She might want to dig into this problem, needs a little oversight.
Okay, we will let her know. Thank you very much.
You're very welcome.
Following that act, we have Gretchen Raffa, followed by Richard Rothstein.
I'm not going to guess any of your ages though, because I don't want you to do it back to me. Oh my gosh, good evening, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. My name is Gretchen Raffa, Chief Policy and Advocacy Officer for Planned Parenthood of Southern New England, testifying in support of raised House Bill 7022, an act promoting equity and Medicaid coverage for fertility healthcare, and House Bill 7102, an act concerning maternal and infant healthcare. Serving almost 50,000 patients last year at 14 health centers across the state. PPS&E believes all people should have access to quality, affordable health care as a basic human right. We believe every individual has the right to full bodily autonomy and the ability to make personal decisions about their body, life, and future, including if and when to start a family. It's our responsibility as reproductive health care and providers and advocates that our work must be inclusive to ensure that people have equitable access to not only abortion and contraceptive care, but also ensure people have access to pregnancy and postpartum care and access to fertility health care. The reality is for many people, they require fertility assistance to have children, yet often that health care is often out of reach due to the high cost of that health care. HB 7022 will address a critical need by eliminating barriers to fertility healthcare coverage and will align healthcare coverage with the medical standard of fertility care, which clearly includes LGBTQ+ people and single people, among others, so more Connecticut residents have the opportunity to build their family. This bill is an important first step to improving coverage in the Medicaid program for essential care. While there's broad coverage of many services for people with low income during pregnancy and to help prevent pregnancy, there's almost no access to help people with low income achieve pregnancy, which has a disproportionate impact on women of color, particularly on Black women who are more likely to experience infertility, yet less likely to seek that care. This is a critical part of the fight for reproductive and economic justice in our state to ensure all people have the freedom and power to build their families. Moving on to House Bill 7102, we have been proud to support laws passed in the most recent year, including Public Act 23-147 that have prioritized maternal health in our state, including allowing for the licensure category of birth centers and establishing a voluntary certification for doulas and including doulas in the maternity bundle. Increasing equitable access to doula services, especially in under-resourced communities, has been shown to improve outcomes for both mothers and their newborns. House Bill 7102 is a necessary and urgent next step for the important work our state has done to improve maternal and infant health outcomes, and we thank the administration, this committee, the legislature, and the Black Maternal and Infant Health Caucus for continuing to prioritize maternal health policy this session. Our maternity care system is failing communities who are most impacted by the burden of structural inequities due to this country's legacy of racism and other forms of discrimination. The United States continues to have the highest rate of maternal deaths of any high-income nation, despite a decline since the COVID-19 pandemic. And within the US, the rate is by far the highest for Black women, who are 3 to 4 times more likely to die from pregnancy-related causes as their white counterparts. Most of these deaths, over 80%, are likely preventable. PPS&E has long fought for a person's right to control their reproductive lives, which includes planning their family, having a healthy pregnancy, giving birth to a healthy child, and raising their family in safe and healthy environments. That's why we urge this committee to support House Bill 7022 with a minor amendment that you heard about from Hannah to improve fertility healthcare coverage, and House Bill 7102 to address health inequities and support maternal health in our state. Thank you so much to the committee for your time and consideration of these two important policies.
Thank you, Gretchen. Thanks for your continued advocacy. Next, we'll hear from Richard Rothstein, followed by Richard Jennings.
Good afternoon, Senator Lesser, Representative Gilchrist, Representative Case, and members of the committee. My name is Rick Rothstein. I live in West Hartford. My son lives in West Hartford also in a group home. Some of you may have seen this last week at another meeting. My son has profound autism and severe, very complicated medical issues. Today, he's fine, but twice in the last 4 years, my son has been the victim of abuse or neglect. And in both cases, the The abuse was substantiated. In the first case, it was a sexual assault. The agency did their own investigation and never contacted the police. They had given me a choice of contacting the police right at the beginning, but at that time, I didn't even know the facts, and I didn't know the facts for approximately 6 months, which is the time it took to get the investigative complete. Even at that point, when I requested a copy of the complete report, the report was not complete. It did not include pictures that were taken of the of what happened by another staff person off my son's video monitor, because he has a camera in his room. And we didn't have access to the witness statements. All of the names are redacted. It was so redacted, my son's name was redacted. Obviously, I knew who it was, but you don't get to know anything. And the group home staff member was sent home and was fired for cause the next morning based on the verbal and photographic evidence. The provider recommended that the person be put on the registry. I only know that because I saw the redacted report. I don't know the man's name, and you are not allowed to know what happens at the registry hearing. There's an administrative hearing. I get that. Before the person could go on the registry, but the families are completely closed out, and I think a little sunlight is warranted here. And as my friend Adrian spoke earlier, we need some sunlight on this issue. And while I was on the Council of Developmental Services, we requested data from the commissioner, and because we had formed a subcommittee to look at the whole issues, and we got stilted information. We wanted to know what percentage of cases were substantiated, and they gave us substantiated, open, and total. They didn't tell us the total for the year. So we didn't know if the open cases were from a year ago, 2 years ago, this week, or 6 months. We had no idea. During our investigation of investigations by the council, we did develop about 8 recommendations.
Your time is complete. Please summarize.
And those were delivered after approval by the council, they were delivered to the commissioner, and he has never acted on any of them. So this area needs top to bottom review. I'm hopeful that getting the statistics is a good first step. And families, all of you, the administration, need to know the extent of the problem. And so I look forward to working with you as this goes along, and thank you for your support.
Thank you so much, Richard. And it can't be easy to have to tell that story time and again. And so I really appreciate you sharing that with us. I plan to go back and look at your testimony, and we'll follow up as we work on this bill. Senator Lesser, followed by Representative Bale.
Yeah, I'm kind of speechless. I'm very sorry about what happened to your son, and I'm very frustrated. What can we do? There's nothing we can do, but what should we do to make sure that this?
I think Adrian's recommendations were good. We need independent investigations. We need investigations that are delivered timely, and we need more transparency to the families. I made a comment at Family Hearing Day last week that the system seems to be there to protect the employees, the agencies in the state, and not to protect the families and the individuals that they're supposed to be protecting. So second case was even worse. I won't get into it, but when his mother and I got to the emergency room and we saw him, we were terrified. We were absolutely terrified. And He was neglected during his day program, and the only thing that came out good from all of this is that he eventually did get all the support that he needs. He's now a line level 8, which is the highest. There are only 272 people in the state at that level. And he has one-to-one coverage in his day program and his residential program when he's awake. There's a video camera in his room that a staff member is required to carry during the night. And God bless our case manager, because the first incident happened during COVID. We had a big meeting about it. And with the agency and his mother and I, and case manager said, put a camera in his room. And there is a process for that, which of course during COVID was suspended. But it took DDS about 3 years to come back, between 2 and 3 years to come back and say, we never gave you authorization for the camera. And so we had to go through HRC, the Human Rights Commission, and demonstrate that it was necessary. And fortunately, his doctors are great, and they gave us a substantiation for the camera, which wasn't the abuse. He has a seizure disorder, and of course, when you have a seizure, his usually happen during the night. And the first thing the emergency room asks you is, how did this present? And we have no idea. All we know is at a 15-minute check-in, they saw that he was having difficulty. So. Anyway, thank you for
Representative
your
Vale,
support.
hold on one more.
I'm sorry.
Good afternoon, evening. I just want to understand your story correctly. So, there was abuse, but what triggered the investigation? An incident?
The investigations should be done independently.
I agree. No, in your son's case specifically,
In this first case, which I described, it was done by the provider agency, who I have great confidence in. We didn't leave them. I'm a past chair of the organization, was on the board for about 18 years. I still support them today, even after the second incident.
so it was determined after the investigation that your son was sexually
Yeah,
assaulted?
the second investigation was done by a private investigator and was complete in about 90 days. And the private investigator did talk to his mother and I during the investigation to get more information and to give us an idea of where it was headed.
And so he wasn't arrested?
The person was not arrested.
They were fired.
The second case was a neglect, and it was substantiated, but no criminal charges were presented. DDS investigation training says that if at any point there's a possible indication of a criminal activity, the investigator is supposed to contact the police. I was given that option at the beginning. Do you want the investigation done by DDS, or do you want it done by the police? I didn't even know what really happened, and I wanted to see how it was going to play out. And the private investigator, who was a retired state trooper, told us that if you have anything that you think could be a problem, a criminal problem, ask for the private investigator, and DDS can use the rework that the private investigator does, but the court system can't use the DDS reports.
So it's determined that there was abuse and neglect. And because of who did the investigation, were you given the opportunity to press charges?
No, well, I mean, we still could press charges today, I guess. The statute's open. But I don't even know the person's name, and I don't know that, I assume DDS would release it to us if we had an attorney request it.
I mean,
But
that's
our
crazy.
primary goal was getting this person out of the company that he's with and making sure he's not working anywhere else where he could affect anyone else.
I don't want him to be around anyone, period. But man, I'm sorry that you went through that. And
Yeah.
certainly Hopefully DDS is watching this and I'm sure they
Yeah,
are.
well,
This
I think
this is
CDS
good.
needs some watching.
Yeah,
So
they
I know
do.
that's not your principal mission here.
Well,
That's in Lucy Dathan's committee.
well,
but,
I'm on that committee too.
So,
all right. I'm sorry that you went through that.
okay, thank you.
Thank you so much for being here today.
Yeah, thank you.
Oh, I'm sorry. Wait, Representative Case.
Representative Case.
Thank you. We need more people like you to come out. You know, 1996, my father got cancer and my brother went in a group home.
Yeah.
He was abused.
Yeah, I wasn't able to come to his funeral. Many of
No,
my colleagues
this
did.
was the first time before his funeral. So his funeral's later down the road, but he was abused. That group home was closed. I had to take the person that ran the group home, it was CTH home, to court. Just a restraining order against, he couldn't come near me, but he had to go and be in another house, embezzled his money and abused him. So
Well, DDS talks about all of these independence things that we want everyone to be independent. We want everyone to be independent. Well, I agree that everyone should be as independent as possible. My son cannot live independently. My son can't work in a competitive job. He has had a couple of minor job assignments over the last 20 years since he's been out of high school, but nothing sustainable. And he needs that level of supervision. And
no, and I thank you for
he'll
coming out.
never
because-
drive a car.
Richard, it's good, you know, it was 1996 where he was abused in a CTH home.
Yeah.
It was 2016 when he died in a group home.
Yes,
And we'll leave it at that.
I
So-
remember that.
Let's keep talking and hopefully we can get some of these things moved along
Yeah.
a little bit faster because
Yeah.
it's not right to the families, and you're correct. The reports can't be used.
Yeah, and people need to know about it. So thank you very much.
Thank you.
Thank
Chair.
you. Next is Richard Jennings, followed by Melissa Biggs.
Madam Chair, members of the committee, thank you for having me. I'm here. Well, I said my name. I'm from Short Beach, section of Branford, the home of our favorite daughter, Robin Coleman. Yeah. I am here testifying in support of House Bill 702, enacting maternal and infant health care. Section 1 in particular, which is promoting the opening of more birth centers and birthing hospitals. So I'm a retired midwife after 42 years of catching babies, over 20 of those years in birth centers. What I want to start out is because this 3-minute thing has me spooked. I want to talk about my recommendations and then I'll give reasons until the time runs out. So the first things that could be done is right now, the executive director of Women's Health Connecticut would purchase the Danbury Health Center, which had been open under maternity hospital regulations for over 20 years. Commented on the fact that the legislature changed the regulations and allowed for birth centers to be licensed in Connecticut for the first time. The problem is that the regulations have a life of 5 years. And after that, the certificate of need, which is a burdensome and expensive process, would be reinstated. So that's something that the legislature could do, is to take away that 5-year window. We're almost halfway through that. And then to convince DSS to increase birth center reimbursement for Medicaid patients. Right now, they reimburse at $2,500, which, as the executive director of Women's Health Connecticut said, they couldn't keep open at that reimbursement rate. Also, we're going to try and get, we need to increase midwives in order to have more birthing hospitals and birth centers in particular. So there's a category of midwife under our same professional organization. We're trying to get licensed. They're called certified midwives. They just don't have to have all the nursing requirements that a certified nurse midwife has. Longer term, we going to push for equal reimbursement from all carriers for midwives. Right now, the limiting factor in creating more midwives in Connecticut is the dearth of clinical sites where student midwives can get experience. So the federal government pays physicians to precept residents, and we're going to work on that at the federal level. And then the magical cure is if we were able to bundle payment for maternity services that included the mother and the newborn, so that a hospital system would get X number of dollars for a pregnancy and birth and postpartum and newborn care. And then the fewer C-sections that happen and the fewer admissions to neonatal intensive care units would increase the amount of profit the hospital was able to garner.
Your time is complete. Please summarize.
Great. All right, so there's ample proof that birth centers improve outcomes. And so I got 6 o'clock last night, which was the cutoff for submitting written testimony. So I sent a truncated something in. So do I have permission to send a written testimony after this?
I'd love that, but will he be able to do that? I'm just
Written testimony is accepted at any time
wonderful. Thank you so much.
Do I just send it to you?
through the online portal that.
All right, thank you so much.
Thank you. And I hope the 3 minutes wasn't too jarring for you.
It came up quick.
You did great. And please do submit that testimony because you have a lot of valuable information that would be wonderful for us to know.
Great.
Yeah, Robin, Representative Comey would like.
Thank you, Richard, for coming out. It's you're always grabbing my ear about these issues, and I just want to thank you for spending the day with us and advocating on behalf of something you care passionately about.
I think I'll do Zoom next time.
We'll travel safe home.
All right.
See you in the neighborhood.
Thank you.
Thank you. Melissa Biggs, and is it a panel? Okay, come on up. I think you all know, but as you speak, please just say your name for the record.
I believe we have one person joining us behind, most of the record, virtually.
Is that Jan Graber?
That's right.
Correct. She is ready to go.
Fantastic, thank you.
Excuse me. Sorry about that. My computer is, it took a nap. We've been here a while.
That's always the way. As soon as it's time, some kind of electronic thing breaks down.
Members of the committee, Representative Gilchrist, Senator Lesser, and other distinguished members of the committee. My name is Brooke Foley. I'm from the Insurance Association of Connecticut. I'm here with Melissa Biggs from representing AHIP, and I'm here with Jill Rickard from ACLI, and on the screen we have Jan Graber from ACLI, and we are here to discuss Senate Bill 1420. Right.
Thank you, Brooke. So as Brooke said, thank you so much, Representative Gilchrist, Senator Lesser, distinguished committee members. My name is Jill Rickard, and I am here on behalf of the American Council of Life Insurers, together with the IAC and AHIP. Thank you for the opportunity to comment in opposition to SB 1420. Although the bill is well-intentioned, it would have serious consequences for both consumers and insurers and potentially undermine the financial stability of long-term care insurance. Like all insurance products, premiums for long-term care insurance must be actuarially sound. This means that premiums plus the reserve account must be sufficient to cover benefits and expenses. Connecticut law requires any increase of 20% or more to be spread over at least 3 years. This helps policyholders avoid sudden financial strain. Insurers must also notify policyholders at least 30 days in advance of an increase, giving them the opportunity to adjust their coverage and maintain meaningful benefits at an affordable cost. ACLI, the IAC, and AHIP believe these existing regulations strike a fair balance between consumer protection and ensure financial stability. We recognize the challenges in the long-term care market. Some policyholders with older policies that have lifetime benefits and inflation protection have experienced large rate increases. When a policy is initially priced, an insurer attempts to determine a level premium for the life of the product based on actuarial assumptions regarding things such as mortality, the number of people expected to maintain their policies, the number of people who will use benefits, and interest earnings. When policies were initially sold in the 1970s, assumptions were based on limited data, and some of them turned out to be wrong. For example, advances in healthcare mean that people are living much longer than expected, and the lapse rate, which is the likelihood a person will drop their policy before needing benefits, has been much lower than original data indicated. This demonstrates how much people value their long-term care insurance, but also means that more people will use it than expected. When long-term care insurance was first introduced, over 100 carriers offered standalone long-term care coverage. Today, fewer than 10 remain. Unlike other lines, long-term care insurers must collect adequate premiums to cover claims that may not arise for decades. And because policies are guaranteed renewable, insurers cannot cancel a policy due to changes in an individual's risk. However, they must have the ability to adjust rates over time to ensure they can continue to pay claims. Arbitrary restrictions on rate adjustments can threaten the ability of insurers to fulfill their commitments to existing policyholders and cause even more carriers to be unable to provide this product. Finally, I'd like to acknowledge that long-term care is deeply personal. Many of us will need to help loved ones as they transition from living independently to needing care later in their lives, and most of us will require some sort of long-term care in the future. This is the second greatest financial concern for Americans, behind only retirement savings. The cost of long-term care is high and increasing. According to a recent survey, adult daycare costs about $20,000 per year, assisted living about $49,000 per year, and a private room in a nursing home over $102,000 per year on average. Long-term care insurers paid out more than $10.9 billion in total claims in 2021 alone. In 2023, loss ratios for long-term care averaged 176% for individual products and 131% for group products. This means that on average, long-term care pays more in claims than it earns in premiums. Compare that with major medical insurance, which has average loss ratios of 79% and 87% respectively. I provide these figures to demonstrate how rich and important benefit long-term care insurance provides and how crucial the coverage can be for individuals and families planning for or needing long-term care. With that said, we urge you not to pass Senate Bill 1420, and we thank you very much for your time. ACLI's senior actuary, Jan Graber, has joined us by Zoom and can answer any questions you may have.
The other folks are here for questions.
We're just here for support.
Okay. You go first? No. Representative Vale has his hand. Rep. Vale?
Thank you, Madam Chair. Good evening. So I used to sell long-term care insurance. I still licensed to. I don't know how, with a conscience, I could possibly sell it right now. It's a bag of money, right? Not selling. Health insurance can go up, and your coverage will have to go up with it. So that makes sense. When you buy life insurance, you're buying a fixed amount based on your life expectancy. When you buy the policy, you buy it when you're 25 and you get $500,000, a whole life policy. It's going to cost X based on your height, weight, all these different determinants that are going to determine what your life expectancy is. And that's how rates are determined. And you're getting a set 100,000, a million, whatever it is. You buy the same person, 35, slightly overweight, obviously they're going to pay more, and it's based on their life expectancy and how much premiums they're going to put in. But that's how long-term care was sold to people, as whether it had the insurance, the rider for inflation or not. All that was supposed to be figured in by actuaries. Now, whether it started in the 70s, most of it seems like, to me, most of the problems, people are coming in who bought policies in the 90s, and that should have been figured out in the 90s. So I'm having a hard time. The cost may go up, but the only determining factor that should be different when you buy a specific dollar amount of coverage is if more people are going into a nursing home. If it costs more, is irrelevant. because your cost benefit is originally $300 a day, because maybe that was the going rate for nursing homes at the time. But then you kick in the 5% inflation rider, and that should have been figured out by intelligent actuaries who are the smartest mathematicians in the world. And they figure out this based on probability over a long period of time. But it goes up increasingly. Goes up the exact amount. It's not different. If it's 5%, I can sit here and do the math. You know what it's going to be worth 20 years later. It's a fixed amount. And that's what they're paying for, fixed benefit. So if they pay for $300 a day and it costs $500 a day, they're $200 a day short. So their policy will cover. It's not like health insurance where it goes up and now they're going to pay the whole thing minus your deductibles and stuff. So I don't understand why these premiums have gone up leaps and bounds. The lady who testified, who called me old earlier, said that hers went from $1,000 a year to $7,000 a year. So that means her projected cost, to me, theoretically, mathematically, has gone up by 700%. That doesn't make sense to me. And I know when you sell a life insurance policy, it's not guaranteed that a whole life policy doesn't go up, but it's very seldom that happens. So I just have a major problem with this. I used to be on the insurance committee. I usually stick up for you guys too on a lot of stuff, because I think you get thrown under the bus on a lot of stuff that isn't your fault. But this one you guys got all wrong. It's an issue. So I wouldn't in good conscience feel good selling someone a long-term care policy, say, hey, it shouldn't go up. It's based on a daily benefit over the next years, but like seven times the amount for long-term care. How few people actually took the initiative to buy long-term care, and we're going to punish them for doing that, So, I have a major problem with this. I don't know that I thought I had a question when I started, but what's up with the actuarial numbers? Why were they so far off? And why are they off where they're continuing to go up every year? Just makes no sense to me.
Well, if she would like to venture a response, we do have our senior actuary online, and she is probably much better than me at answering this question. Maybe she's there.
Yeah, sorry, somehow I hit my camera. I'll start off by saying, long-term care is one of the hardest, most difficult, complex products to buy. So you're correct in that you buy a set amount per day. But what varies is, and this is where we've seen the large, really significant increases, is on the benefit period. A lot of these products, especially the ones that are seeing these large increases, they were sold with compound inflation protection and unlimited benefit periods. So when you price long-term care, even though the benefit is defined, we have to make estimates about the number of people that will keep their policy up to the point when benefits will actually be paid. So, in the case for long-term care, you have to look at actual experience, but then when experience starts to evolve in later years, you have to be able to adjust. And so what has happened is people are living longer, or they're staying on plane longer than originally anticipated, and more people are keeping their policies. So if you think about that, and you think about how treatment for conditions like Alzheimer's, which is a benefit trigger, has changed just over the most recent years. Back when these products were originally priced, people were living with Alzheimer's or maybe staying in a nursing home for maybe 2 to 3 years. And now, because of medication and treatment and that kind of thing, these people are living sometimes 10 years. And so what happens is we're, in those policies that have an unlimited benefit period, yes, your daily benefit is the same, but instead of paying that daily benefit every day for 2 years, all of a sudden I'm thinking, okay, I'm going to have to pay that same daily benefit for 10 years. And so as a result, that it results in, a product that is, I guess, richer or more valuable in benefits than what was originally priced for. Does that make sense?
Okay, so to me, the only thing that makes sense is the fact if someone buys a lifetime policy, that the actuaries miscalculated that. Well, and based it on, I guess they based it on what the average time someone spent in a nursing home that went in and never came back out, because that's why you would have a lifetime policy. And maybe that period of time is longer than anticipated. So that's what's driving up a lifetime policy. Is that what you're saying?
Well, that's true. That's part of it. But like I was saying, there's a lot of, different assumptions that go into pricing long-term care. So in addition to you staying in the nursing home a certain period of time, you think about, well, the care settings themselves have changed. So previously, people may have had family at home that took care of them. These comprehensive policies, yes, they cover care in nursing homes, but they also cover care in, assisted living, home health. And so people are, again, triggering those benefits earlier. And so that results in more benefits having to be paid out. And then you have, if we go back, when long-term care was priced, you think about life insurance. Life insurance basically is priced using mortality and interest. And mortality has pretty much, been, we can pretty much predict mortality. But then when you start getting into long-term care, it's a lapse supported policy. So that means that, you have coverage as long as you pay your premium. But if you lapse that coverage, then the reserve that's been set aside from that premium, you do get a return, you get a benefit equal to the amount of premiums you paid in, but you also have a reserve account that has been sitting there associated with your premiums. And so that reserve account goes, that part of your premium that part of the reserve that comes from your premium, that should go to pay, or that goes to pay benefits for other policyholders. That's just how a long-term level premium product works. And so, when these products were first priced, life insurance had been around forever, but there really wasn't another type of long-term product like long-term care. So as actuaries, we have to base our assumptions on, actuarially sound data. We can't just say, well, we think it might be this. And so what actuaries did back in the 80s, 70s, 80s, early 90s is they looked, there wasn't the experience on long-term care products. It was, it wasn't credible because it hadn't been around long enough. So we had to look to other long-term type products. So we looked at life insurance. And so, okay, well, with life insurance, it's kind of the same. You pay benefit, you pay based on based on your age when you purchase the policy. And and then the benefit is not paid, sometimes 30, 40, 50 years in the future. Well, so we look at the assumptions for those long-term products, and the lapse rates for life insurance policies were, 10 to 12%. And so that's the assumption that we used for pricing long-term care. Well, when in reality, as Jill mentioned in her testimony, people see the value of these policies, because you may end up paying, yes, $60,000-$70,000 in premium over your lifetime. But if you trigger a claim and you have a long-term care event, that policy could pay out well over $1 million. So people are looking at that and they're saying, well, you know, yes, my premium's gone up quite a bit. You know, I'm paying an extra $1,000 a year for this coverage, but you know, potentially if I have a long-term care event, if I don't have this coverage, I'm going to have to pull over $1 million from my retirement. And so what
when you made those rates initially, it was based on not anticipating them going up. Right? So you had the data, not you, but the industry had the data. Maybe their data wasn't as good as they would like. They made a guess and they guessed outrageously wrong. Right? Because in this lady's policy, since 21 years old, that means she bought it in 2004. So that's beyond the 90s. And she started at $1,000 a month for her and her husband. And now they're paying $7,000 a month. This is not medical insurance. Like medical insurance is a different story. It's a per diem issue. And number two, if we go back to the 90s, and we go back to the Partnership for Long-Term Care, that was put in place as an asset protection program for people to encourage them to buy long-term care so that they didn't try to do that. Now, you had to get, correct me if I'm wrong, but a 5-year plan. And I think that was tied into the look back period. So if you sign over your assets and the state and you go into a nursing home and the state can look back 5 years. And so if I gave my kids and I went into a nursing home and I gave my kids all my assets, the state can look back. Oh yeah, you just gave your assets away 2 years ago. We're going to go take all your assets from your kids. So the whole point of the long-term care, the partnership, was so that people could buy a 5-year plan, not a lifetime plan. And that would cover the 60 months, the look back period. And then people could sign their stuff away and wouldn't be taken. So I think that was the thing. You could correct me if I'm wrong, but all these were put in place. So I don't think, are the rates for non-lifetime policies going up at the same rate or for shorter terms?
Well, the biggest driver of the largest increases are the unlimited benefit periods, or even a 4 or 5 year benefit period. And even if you bought a 2-year benefit period, that's going to be less expensive. And I'm not sure how carriers would differentiate in the underwriting between if you're trying to.
I'm sorry. I don't know what's happening, but there's some real audio issues and we're having trouble hearing you. So I'm not sure if there's something on your end that you can configure, but you were really dropping out and we were just having trouble hearing what you were saying.
Is this any better? I can move a little bit closer.
Yes, that's better.
Okay, sometimes when I lean back, I think that throws my computer off. So it's not, it is the benefit, the unlimited benefit periods that are the biggest drivers, but there are other drivers. It's, as I said before, it's the lapse rates, it's the interest rates on reserves. And so all of these things, so if you step back a minute, long-term care, when it was originally priced, it was priced as on a lifetime loss ratio basis. And when products are priced on a lifetime loss ratio basis, that's really there to ensure that premiums are not set too high. And what we found, as we started to go into the 90s and, start seeing this experience evolving that was significantly worse than expected, the concern was no longer that premiums were too high. It was that the concern was that premiums were too low. And so that's when regulators, got together, industry was part of that. And we established what we call the rate stability model. And so, yes, that is priced to be, that is sold to be a kind of an issue age product. So rates remain level over your lifetime. And unless there is a material change in your underlying assumptions. And so as kind of a, so part of that rate stability was, yes, we want to try and price this more conservatively. We're going to even add a 10% margin to the price. So, if we think our assumptions are X, let's move them up, 10%. And so it was meant to be priced very conservatively. But again, what happened is, that was not enough because people are holding on to these policies. Even if they have a 2-year benefit period, the assumption may have been that those people with a 2-year benefit period may only stay on claim for 12 months. Well, now, if you have everybody that's reaching their maximum benefit period, you're paying out way more claims than you expected. And so as part of kind of this whole rate stability, actuaries said, okay, we don't, we can't take on the risk of pricing a 40, 50 year, duration product as a level premium product without the ability to increase rates on a policy basis. So rates can increase on an individual's due to changes in health status, but if the underlying assumptions on that block of business turn out to be wrong, then the guaranteed issue provision says companies can increase rates for that policy form if it's actuarially justified. And, nobody saw this coming. Companies, did not misprice on purpose. Again, actuaries were bound by actuarial standards.
But let me get to the point because we're getting too deep into the weeds.
Okay.
How many times, how many times in the last 10 years has the industry come to the insurance and asked for rate increases?
So I do want to just throw in, and I can't answer specifically, but I can say I'm an avid OLR researcher. And I pulled out a report that they had provided where they said the Department of Insurance has rejected requests more than they've approved between the periods of 2010 and 2023, saying that they are going through and they're making sure that these rate requests are appropriate. I also want to flag, we completely appreciate that consumers are having a difficult time with these rate increases. That's not, we're not trying to deny that. I will also flag the Department of Insurance testimony where they said that this has become a national problem, where they are discussing this at the NAIC, and they are looking for a plan that they can bring across to every state. So while I don't have a specific answer, I do want to say we are regularly reviewed by the Department of Insurance. They are not just giving us carte blanche to raise our rates. And yes, they have risen more than I think anyone would like. But the reality is these companies have to stay solvent in order to pay out these claims.
I think they should take a moratorium on selling long-term care policies until they figure it out. This is ridiculous. Don't sell anymore. Try to fix the ones you have. And you shouldn't come back every year. If there needs to be a fix because there was a miscalculation, we should have the data now. So there should be one fix. You should ask for one payment. These type of policies are indemnity policies. They're supposed to be a specific benefit. So when the cost goes up, it's irrelevant. It's if more people are staying and they're staying longer, I understand that. All that stuff was supposed to be factored in, and it's not. And so that was 1990. We had the 2000. Now we're here in 2025. Figure it out. Because a woman, that's $7,000 a month.
Yeah.
That someone's paying, they paid $1,000 a month per year, no, a year. I stand corrected. That's what I meant. And it's not okay.
And I
You
will
got to
say,
figure this out.
this General Assembly has done great work in trying to ensure that we put consumer protections in statute. So one of that is limiting the amount of rate increases we can have over a 3-year period. So there is a specific
It
rate.
should be 0 now. Figure it out. Seriously.
I
Like,
appre-
it's an indemnity policy. Figure out. You got more data to work with now. Figure it out, please.
Okay. All set, Representative? Okay. One question, and I know, I used to be the chair of the Insurance Committee, and when I asked Senator Looney to please reassign me somewhere else, I thought I wouldn't have to talk about long-term care insurance anymore, and yet here we are. So, this is not the Insurance Committee, and I think the reason this committee is looking at it and not the Insurance Committee, at least I think they're also looking at it, but the reason that we are taking a look at it is not from the general angle of long-term care insurance. That is entirely their cognizance. It's because of the specific partnership program where we're trying to allow people to get access to the Medicaid program. And so, this bill is particularly looking at the pre-certification process and the extent to which, unlike the rest of the industry where we haven't signed off, people, buyer beware, people should have to make their best judgment, and sometimes things turn out badly. Here we have pre-certified these plans, and the state of Connecticut has promoted them. And I feel like that is a different situation than there is writ large in the industry. So what is the industry's role in the pre-certification process? Can you just educate the committee briefly? Because I do know that there are an awful lot of people who are trying to testify on a whole lot of other stuff, and I want to get to them too.
So thank you for your question, Senator Lesser. So first of all, I just want to note that I don't think the bill limits its provisions to partnership policies. And if that's what you're intending to do, the language might need a little bit of revision. But partnership policies are sold by the same insurers that sell non-partnership policies. The pre-certification is that these partnership policies have to have certain required minimum provisions that are required by the state. So for example, inflation protection, minimum daily rates, coverage for home care services are a couple of them. Otherwise, I think they're subject to the same issues that regular non-partnership long-term care insurance is subject to.
And are there any consumer protections around excessive rate increases other than what apply to just generally in the?
I don't believe so. Yeah, I mean, the insurance department regulates them the same way that they regulate non-partnership policies. There is some additional input from the OPM office but that is just in terms of its relationship to Medicaid.
But when the state of Connecticut says, unlike most the state of Connecticut would never sell me homeowners insurance, right? They're not on the business of selling private insurance companies products. But in this case, we're actually saying, this particular class of long-term care policies, we are pre-certifying, and I don't know what people read into that, but I think there is some folks out there may still have some faith in us when we sign off on this particular policy, that there's something backing that up. And so I appreciate that may not be the case, other than the couple of the specific things there. But otherwise, I'm not sure why we're in the business of pre-certifying if we're not providing some additional protections there. So that's where I'm struggling with this, because I feel like there's a market failure, as Representative Vail documented writ large in the long-term care industry. We've seen all sorts of every assumption that the industry went to the insurance department on 30 years ago on was wrong, as Representative Vail documented. But for the non-pre-certified part, okay, mistakes happen. But here we are saying we promoted it. You can go on there's a State of Connecticut website right now that says buy this stuff, and I feel like that's a little bit different. I don't know if there are specific things that we should be looking at to provide additional protections for that population, but if you could give us guidance, I think that would be really helpful.
I would ask if Jan has anything to add to that online, but I mean, we'll definitely we're willing to work with
If you could, if you could take that back to us,
Yeah,
that would be great.
thank you.
Thank you very much. I want to be respectful of the other folks because there are a lot of folks who want to testify. Thank you so much. Really appreciate your testimony. Okay, next we have Rose Reyes, followed by Ben Shaker.
Good evening, esteemed members of the Human Services Committee. Thank you for the opportunity to speak today. My name is Rose Reyes. I'm an educator, AFT Union, nice and proud. We love our nurses and hospital personnel. And I'm a simple member of a courageous civic group advocating for maternal health justice and equity in the quiet corner of the state. I'm here to support Senate Bill 7102, an act concerning state infant and maternal health care. It's an important bill for me, given the town that I'm from. The town that I'm from, in which I reside, work, and exercise my civic responsibility, was subjected to a loss, and we have been courageously trying to address it. And having this bill, it's a critical step in reestablishing the services that we would like to have, especially in regards to a birthing hospital. It's not just about funding; it's also about preventive care and impressing upon people that equitable access to all with community involvement in this maternal care service area is really critical, especially in the quiet corner. The Medicaid reimbursement is a necessary step towards stabilizing our healthcare system for sure. One thing I'd like to consider us to look at is also providing strong oversight and accountability measures for these events, quality improvement initiatives, such as the maternal health care service ratings that would help. Yesterday, I think it was yesterday, I was listening to some very sad testimony about maternal issues and complications, and I just want our state to have an understanding of how important it is to have ratings to help us. And of course, evidence-based best practices. So I've submitted my testimony, and pretty much I just want to say that this legislation is an important critical step toward reducing maternal mortality and complications, closing the disparities that we've encountered in birth outcomes, and strengthening the healthcare infrastructure. And again, I'll just urge that you support 7201 as an investment and a moral imperative to protect the health and well-being of all families across our state, especially in the quiet corner. Thank you.
Thank you, Rose. I see the great representative from the town of Wyndham, the city of Atlantic, is here with a question. Representative Johnson.
Thank you so much, Mr. Chair, and thank you, Rose Reyes, for testifying in this. We really appreciate your participation in this, and we appreciate all the people who have been working with Wyndham United to save our healthcare. So thank you so much, and thank you so much, Mr. Chair.
Thank you, and appreciate your thoughtful testimony. And we want to support the folks in Willimantic. Any other questions? Seeing none, thank you very much. Next, Ben Shaken, followed by Sharon Byrne.
Evening, Mr. Chair, Representative Case, members of the committee. My name is Ben Shaken. I work for the Connecticut Community Nonprofit Alliance. We are the statewide association of nonprofits. As you all well know, we've submitted testimony on a number of bills. Today, I want to touch on three. First, Section 3 of House Bill 7109 includes language about certified community behavioral health clinics. These are clinics that the state has applied and received a plan grant from the federal government to support, thanks in part to the advocacy of this committee last year. Language in the bill addresses parts of the CCBHC as their known program that already exist and will exist in the state's program as it is stood up. We're a little bit concerned that there is an attempt in this bill to legislate downside risk for providers. Certainly something that's allowed in this program, but we're a little bit concerned about what might happen if it's put into statute to force the Department of Social Services ultimately to implement it. Secondly, House Bill 7107 about people with disabilities working for state employment. We support the technical changes in the bill, very much support the task force that's also in the bill. This is clearly an issue that we need stakeholders together to work on. I want to spend the bulk of my time, though, today talking about Senate Bill 1415, which would increase wages for nonprofit staff that are working in IDD group homes funded by DDS to $25 an hour over the next 2 years. We are very supportive of funding these services at a rate that would allow nonprofits to pay that rate, but we are very concerned about the bill as it's drafted. Ultimately, the bill would repeat mistakes of the past that have happened. It would create significant wage compression, and it would not account for the increase of other things besides wages that have increased in cost, things like energy, food, rent, those kinds of things. It's very similar to an agreement that the legislature reached back in 2021, which raised the minimum wage in DDS funded programs to $17.25, provided very small increases to folks who were making over $17.25. But it's not similar to the last agreement that the legislature reached in 2023, which instead provided a 7.5% cost of living adjustment to providers on their contracts. And that's what we would recommend. If the legislature intends to increase funding for community nonprofits, and we hope you do, and we very much would like you to, we would like you to structure it in the way that allows nonprofits to pay their workers what they need to be paid, but also gives them the flexibility to work both in a unionized and non-unionized environment to cover the costs of their programs, to pay people who might be making more than the minimum wage in those programs, significant increases, people with longevity, people in managerial roles, et cetera. We think it's the best way to fund services. Just briefly to summarize, I know my time is running out. What happened in 2021 is people who had been working in programs for many years, who might have been making $19 or $20 an hour, got a 3% increase. And people who were hired off the street that day, from one day to the next, got a 45% increase. And those people who were making $18, $19, $20 an hour went to their management and they said, hey, can we get that 45% increase? Management said, no, you can't, because state law says you're not allowed to. We can't give you the money that we've been provided for those purposes. And so what happened is exactly what you think would happen. They left the industry, and the IDD field lost a lot of very experienced people with longstanding relationships with clients. And so that's the biggest reason, I think, why we are hoping that you will consider increasing funding as a cost of living adjustment. I'm happy to take any questions. Thank you.
Thank you very much. Are there questions or comments from members of the committee? Yes, Representative Lewis.
Thank you, Mr. Chair. So if I'm assuming your testimony, the written testimony you submitted, it recommends the language in terms of structuring that reimbursement rate. Is it part of the reimbursement for nonprofits that you guys testified in front of APROPS, or is that, it doesn't correlate with that? I'm just asking.
Yes.
Yeah.
Thank you, Representative. It's a good question. The language that governs this funding in the past has always ended up as part of the state budget. I think with one exception in recent times when a standalone bill passed, and essentially the way that it is always structured, and I couldn't tell you why this is, it's just how we do it in Connecticut. So the legislature appropriates a large block of money to the Office of Policy and Management under a line item called private providers in the state budget, and then tells the Office of Policy and Management to distribute that funding across the state agencies that fund the state's Health and Human Services Network, which is provided by nonprofits. That's actually another concern that we have with this bill. This bill, as it's drafted, only applies to people that work in nursing homes and in group homes that are funded by the Department of Developmental Services. It doesn't address the tens of thousands of people who are working in behavioral health situations and community justice providers in the other places in the Human Services Network. Often, or in many cases, those people are doing the same job, sometimes in the same nonprofit organizations as people whose work is funded by the Department of Developmental Services. And so as drafted, the bill would create a pretty significant disparity between workers with very similar jobs across multiple funding state agencies. So yes, the language for this would be the same language that would govern the sort of standard cost of living adjustments that the legislature has provided through the state budget.
Okay, and through you, Mr. Chair, was there a recommendation to appropriations to OPM to change the way we do it in Connecticut, or in terms of just a line item in the governor's budget?
We have not made a recommendation to change how we do this in the state. This is a very this system is funded. I don't know the number of line items in the state budget, portions of many tens of line items across 7 or 8 different state agencies. It's an improvement over the way things used to be done, which
Sure.
is actually sort of what this bill would go back to, which was a low wage pool. Back in the days of the Rowland administration, providers there'd be money appropriated and providers could apply for it to raise wages. And it ended up meaning that providers were given money in a disproportionate way. And that same thing would happen under this proposal. If a provider is currently voluntarily starting their wage at $19 an hour today, this bill passed, they would get less money than a provider who was paying $17.25 today, because they would need less money to achieve the wage marks in this bill. And that's in fact what happened back in 2021. And so the COLA is, it's the best way that I think the legislature's figured out how to distribute these dollars. Sure, it could probably be improved, but that's above our pay grade. So our ask has always been to just fund that line item and have it distributed out to the nonprofits that are delivering the services by OPM to state agencies to the nonprofits.
Great. Thank you. That clarifies that for me anyways. I hope for my colleagues. Thank you.
I forgot who was chairing this here. We've been alternating. Thank you. Thank you, Representative. Are there other comments or questions from members of the committee? Seeing none, thank you for your testimony.
Thank you.
Thank
Have a great
for
evening.
Next, we have Sharon Byrne, followed by Francis Trisecki, late in the day, followed by Arlene Kay. Nope. Oh, I'm sorry, Catherine Marshall. I saw a notation and I misread it.
Hello, my name is Sharon Byrne. I'm the Executive Director of the Women's Liberation Front. We are here to oppose Connecticut House Bill 7022. Women's Liberation Front is a national, radical feminist, nonpartisan nonprofit dedicated to restoring, defending, and advancing the rights of women and girls. We appreciate the legislature attempting to assist low-income individuals with reproductive issues and conceiving a child. Women's Liberation Front supports full reproductive rights for all women. However, we oppose this bill for 2 reasons. Surrogacy is often included under the banner of fertility services. So our concern is that the state would be seeking to enshrine surrogacy using Medicaid with taxpayer funds. And that would look to us like state sanctioned and state funded commercial sexual exploitation of women, which we vehemently oppose. We consider commercial surrogacy in the same vein as prostitution and human trafficking. They exploit a woman's body for money, and they require the job site for the work to be inside a woman's body. This is highly dangerous to women. Legitimizing commercial surrogacy requires placing women in second-class status automatically, as only women can carry children and give birth. Usually lower-income women are targeted for surrogacy, and it is too easy for it to be folded under human trafficking. So since only women can be rented or exploited by surrogacy, we feel that it is very deleterious. Using taxpayer funds to extract resources from women's bodies like this is completely unacceptable. We also strongly object to what is being unsaid in the bill in requiring that Medicaid would cover the freezing and storing of a person's reproductive materials for future use, because that person could have undergone gender affirming care to attempt to become the opposite sex, which is not possible. The state would be attempting to normalize mutilation of one's body for sex change surgery, possibly while still a minor, when these procedures are widely known to result in permanent damage to reproductive capabilities. We do not agree with forcing Connecticut taxpayers to freeze and preserve someone's reproductive materials after they have permanently damaged themselves or before they permanently damage themselves in the con game of transgenderism. So for these reasons, we vehemently oppose HB 7022. Thank you for letting me testify.
Thank you so much for your testimony. I would just point out for the record that nothing in the bill refers to either surrogacy nor to gender affirming care. The reason that, and there's no question here, I'm just going to point for the record, the reason that fertility preservation is included is for a bunch of reasons. But I happen to write the law for insurance coverage that involves fertility preservation, and that was specific to women battling cancer. And so if you get chemotherapy, you can frequently lose your fertility. And we were finding, and there's a long documented hearing record that you can review over the insurance committee, ma'am. But people were delaying getting needed life-saving essential care for their cancer because they were worried about the fertility consequences of that treatment. And the idea that because of some culture war battle in some other state, we would say no to women on the Medicaid program getting the life-saving care that they need is, I think, a mistake. And I would encourage the members to think carefully about what that could mean for cancer survivors, for people needing essential care. This is something we was a bipartisan basis in the legislature decided was very important about a decade ago. We had a courageous advocate, Melissa Thompson, battling stage 4 breast cancer, come up, spend many hours, days, actually years of her time here battling to pass that into law. And I think it would be a grave mistake if we decided to make this about some cultural battle. It has nothing to do with what the language is about. But I appreciate your testimony, and if there are questions or comments from members of the committee, I would be happy to turn it over to any of them. Thank you very much. Next, we have Francis Trzaski.
Good evening, and thank you for taking my testimony. My name is Fran Trzaski. I live in Canton, Connecticut, and I am the parent of an adult daughter who has a developmental disability. I also serve as the chairperson on the Connecticut Council for Developmental Disabilities and as the board treasurer for both the ARC Connecticut and FAVAR, the ARC of the Farmington Valley. I am testifying today as a dad, however, and a concerned citizen, not on behalf of any of those organizations. Testifying today in support of HB 7108, an act concerning autism and intellectual disability. You've heard a lot of testimony already on this topic today, so I will kind of summarize mine as best I can, not get into all the gritty details. You know, you've heard about the arbitrary nature of an IQ, of using an IQ of less than 69 as the threshold for support services, the significant number of individuals who have IQs greater than 69 and profound levels of need, the incredible hardships that those families face as they work with those individuals, and our need to have the state of Connecticut implement a system based on level of need, as is done in at least 24 other states. HB 7108 simply requires that we take the next step to complete the studies, develop the models, and understand the costs involved in solving this problem. That is, finish the work that would allow us to take the next thoughtful steps. We've also heard from at least one agency today who indicated that this would cost at least $800,000 and probably take more than 6 months to complete, and that we shouldn't bother because it might not come to an implementable outcome. As one who has spent a career in financial analysis, both in the corporate world and in the not-for-profit world, these cost and time estimates strike me as pretty outrageous, particularly given the amount of information that is readily available right now and easily available for these kinds of studies. There will, of course, be cost and fairness issues to consider in whatever models we might eventually consider for implementation. But we can't possibly know what's practical or not until we complete the work that's envisioned in this bill. My own daughter is lucky enough to qualify for DDS services and have those benefits. This is simply the right thing to do for so many other individuals with developmental disabilities who desperately need support. I urge you to pass Bill HB 7108 and continue our progress as a state toward a more appropriate model for supporting developmentally disabled people with IQs of greater than 69 and profound levels of need. Thank you.
Thank you. Thank you so much for being here and for your testimony. Next, we'll hear from Catherine Crashall, followed by Arlene Kay.
Now, Mama.
Okay, hold on.
Talking now.
And her guest.
Yes, sorry, guys. I got a little late in the evening, so I have a cameo appearance. All right. Hello, Senator Lesser, Representative Gilchrist. You guys can hear me, right?
Yes, we can.
Okay, thanks. Representative Gilchrist and distinguished members of the Human Services Committee. My name is Catherine Crashall. I'm a law professor at Northeastern University, and my research focuses on reproductive justice, fertility care, and assisted reproduction. I live in Mystic with our son and my wife. I'm here to testify today in support of Raised House Bill 7022, an act promoting equity in Medicaid coverage for fertility healthcare. State law has required insurance companies to cover fertility care for some Connecticut residents for nearly 20 years. And the state's employee health plan was also updated to clearly cover fertility care. So HB 7022 poses a simple question. Do people who receive their care through Husky deserve the same access to reproductive health care as those on private insurance, or the same as the employees of the state government? I think that this legislature that supports reproductive rights, and particularly reproductive justice, should respond with an easy answer. Yes, and yes to HB 7022. Continuing with the state's status quo of private insurance coverage, state employees coverage, and no Husky coverage will perpetuate racial disparities in care. As others have testified, Black women are disproportionately likely to experience infertility, but are underrepresented in the patient population that accesses care. Owing to factors including institutionalized racism, Black and Hispanic individuals are also disproportionately represented in our Husky program. So while ensuring care for those on the private plans or who work for the state government improves access for some, it is inadequate to address issues of disparities in care. In fact, last year, I co-authored a piece published in the American Journal of Obstetrics and Gynecology with a statistician from Amherst College and a reproductive endocrinologist from Yale, and showed that states with private insurance mandates that do not provide coverage through their Medicaid programs may, in fact, exacerbate racial disparities in fertility care. Moreover, limits on accessing fertility care especially burden members of my LGBTQ community, and we are under attack. While President Trump recently issued an executive order requesting policy recommendations to improve access to IVF, it does nothing to make access to care more equitable or affordable. And given the administration's other threats launched on the social safety net, we have no reason to think whatever his administration comes up with will improve access to people covered by Husky. However, with HB 7022, Connecticut has a real opportunity to make fertility care more accessible. I urge the committee and legislator to vote favorably to improve fertility healthcare coverage so more Connecticut residents have access to the essential medical care that they need to build their families, no matter how they are insured. Thank you.
Thank you, Catherine. So good to see you. And I know you've got the guest, but I'm just going to ask a couple of questions, if that's okay.
Great.
So this bill differs from prior attempts here in this committee. And earlier today, we heard that I guess what my question is, are there other states that have this level of coverage through Medicaid?
Where is Jillian?
Jillian is right there. She's on the screen. Sorry, Representative Gilchrist, sorry. Yes, there are you're right that the previous versions, previous years that we've put forward similar bills would have provided for more expansive coverage. And this is a more modest attempt to start somewhere with the state Medicaid program. And it was modeled after coverage that's been enacted. Sorry, he turned 4 this week, and this is a big number 4 balloon. But it's modeled after coverage in Washington, D.C. that was enacted, I think, 2 years ago now, as well as in New York, that provides for coverage for some medications and for medically necessary fertility preservation, but doesn't go quite as far as previous year's proposals did regarding the full scope of IVF fertility coverage.
Wonderful. Thank you. That's very helpful.
I saw it.
And what's your son's name?
Did this
This is William.
Happy birthday, William.
Do you hear Jillian say happy birthday? Can you say thank you? It's always his birthday when I'm giving around the time we do this each year. It has been. So anyhow.
Thank you for being here and your testimony.
Yep. Thank you.
Next we'll hear from Arlene Kay, followed by JP Weisky.
My mic on? Yes. Good evening. And I want to thank this committee for being sturdy and hanging in there with all of us today and being so compassionate and aware for the myriad of issues that are being discussed here today. I want to really thank the distinguished members of the Human Service Committee, and I'm going to provide testimony in support of House Bill number 7109. My name is Arlene Dworkin Kay. I'm Clinical Director of Children's Behavioral Services at Benhaven. I'm also the Public Policy and Legislative Chair with the Connecticut Association of Behavior Analysis in Connecticut, which is the voice for close to 1,500 behavior analysts in the state. CTABA strongly supports the changes outlined in Section 1 of this bill. Behavior analysts in Connecticut, as well as the Medicaid families we serve, are well aware of the problematic issues that result in a lack of access to ABA services in our state. This raised bill captures many of the more troubling issues, which I'm happy to detail now. Although CTABA appreciated the 3.5% increase that was provided for behavior analyst services in the Phase 1 Medicaid study, this rate increase still left Connecticut dead last among our area states for these services provided by behavior analysts. The extraordinary low rates have resulted in practitioners refusing to accept Medicaid patients or leaving the Medicaid market. The rates need to be brought to an equitable level. Another issue, which is huge, is Husky B. Medicaid services for autism, children with autism, currently provides for Husky A, C, and D. Husky B was omitted. Personally, I have 4 cases this month, 2 of which lost their services because they went beyond the threshold of Husky A. 2 were with preschoolers who I had to say we could not provide services for because they had Husky B. It is a huge hole in funding, and it is devastating for a family that needs these services, or especially somebody with a preschooler who's exiting birth to 3, who needs these services, and it will affect their child for the rest of their lives, and they have no access to them. It is something that really needs to be repaired. Also, at the current time, there is no Medicaid code for caregiver training. Building family capacity is core to providing ABA services for children. Commercial insurers understand this, and they often encourage providers to increase the levels of caregiver training because we want to build family capacity. Unfortunately, in Connecticut, there is no code. As caring professionals, we of course provide this service. We don't get reimbursed for it. There needs to be a code. Finally, the state of Connecticut, unlike most states, has never revised the state codes from provisional to permanent codes, which caused a lot of confusion when they did the Medicaid study. And we're really out of steps with commercial codes and with codes that other states are using. So we're asking that this relatively no cost change be made. Once again, I'd like to thank this committee for addressing these issues. They are ongoing barriers to families and children with autism who are trying to access Medicaid-funded ABA services in Connecticut. We appreciate your commitment to the most vulnerable of populations, and we urge passage of this bill. Thank you for your time.
Thank you so much. And we'll be sure to go back and look at your testimony. You have a lot of great
so much.
suggestions. Thank you. Next, we'll hear from JP Weisk, followed by Tom Kosker.
Thank you. My name is JP Weisky. I am representing the Partnership for America's Healthcare Future Action. I will note in a prior role, I was the Deputy Commissioner for the state of Wisconsin. My comments here reflect my experience nationwide across many states. We urge you to reject Raise Bill 7101, a study of the single payer system for the state of Connecticut. As H.L. Mencken once wrote, for every complex problem, there is a solution which is clear, simple, and wrong. Single payer is just such an issue. I'll highlight a number of issues that highlight in more detail in my testimony. I apologize for the length of that written testimony. I apologize for the length of it. But there are a few important issues to consider. Cost first. Single payer healthcare is very expensive. California has estimated implementation in that state, even with the federal dollars coming in, would significantly exceed the entire state budget of the state of California. Federal waivers, number two, the bill looks to try to find ways to deal with federal waivers. It is certainly unrealistic to assume that this administration will approve the waivers necessary for a single payer system. And these waivers have been notoriously difficult for a number of states in much simpler efforts to get approved. Employee issues. Employees who work in multiple states or work only temporarily in Connecticut will have deep problems in coverage, as will workers from Connecticut who work outside the state. It creates a complicated system where Connecticut almost operates like its own country. Union issues. Single payer has created some concerns in states that it could destabilize unions through union trust funds. As employers stop contributing to health plans on a national basis, and the union faces a significant loss of workers inside a state. It also creates some liabilities with the benefit banks that a number of unions put together as a piece of this. Last, legal issues. Union plans are multi-state and governed by both their contracts and by Taft-Hartley. Multi-state and large employers are under ERISA. It's not clear that a state has the ability to, in fact, waive any of these laws. In fact, the only state that has an ERISA waiver is the state of Hawaii, which had a prepaid healthcare plan predating the passage of ERISA. With that, I will stop and see if there's any questions. Thank you for your time.
Thank you so much. Yes, Representative Case.
Thank you, and thank you for testifying. You sparked a few things that I just wanted to ask. You talk about a multi-state employers.
Yeah.
So I happen to work for one that we're in 28 different states, but how would that impact? And the second question is, what is your thought on how this would impact the state budget?
Yeah, so I think first, related to the multi-state employers, all of the single payer systems presume a tax. It starts becoming very complicated for a multi-state employer when you're looking at different employees at different benefit levels across the states. That's the whole reason ERISA was put in place in the first place, was to protect the ability of employers to design their benefit package to reflect their employee needs and have a common benefit structure across the states. This would certainly blow that up potentially. It would either put multi-state employers at a disadvantage in the state of Connecticut by paying additional taxes and providing a health insurance package to their employees, or it would put those employees in a different sort of setting than every other employee in every other state. So it does have a potentially destabilizing impact on meant by large employers in the state when they take a look at it. From a financial standpoint, it is a very expensive prospect, especially when you're looking specifically at single payer. You're looking at global budgeting. You're looking at other sort of pieces about how you pay for this. I think we've seen time and again that when you come up with an estimate of what something costs in healthcare, it's always wrong. You've certainly seen that in long-term care, the long discussions today about the estimates with actuaries who did this work. You certainly saw that, for example, inside the ACA. The ACA has hit many goals, including near universal coverage across the country. But certainly the costs inside the Affordable Care Act have been significantly higher for both insurance premiums and for the taxpayer subsidies that attach. Same thing would apply here. In fact, in the state of Wisconsin, in the first 3 years of the ACA, our plans lost almost $400 million over those 3 years in reserves as a result of wrong estimations in the ACA market. And that has just continued through time, that the costs are not meeting sort of what the expectations are. They get closer and closer as you get more and more experience, but it will be really expensive. And I'd also note, apologize for going on and on here, but I also note that a number of states have looked at this. Vermont came very close. California has looked at it, and they all moved away from the brink because of the financial implications, because of the lack of the ability to do waivers. It's a very long and complicated process. And in the state of Washington, it's highlighted in my testimony, they were looking at long-term care, a takeover of long-term care in the state, and it resulted in just mass chaos. And that was only a long-term care market, not the entire health insurance market. Apologize for going on and on, but happy to answer.
JP, thank you. You answered the questions. I appreciate you coming and testifying and giving your thoughts. Thank you very much.
Thank you.
Thank you, Madam Chair.
Thank you. I don't see any other questions. Thank you for your testimony.
Thank you.
Next, we are going on to Tom Kosker, followed by Rob Burrell.
Good evening, representatives and senators. A lot of familiar faces. It's good to see you all here. Thank you for your support. I'm testifying today on HB 7108, an act concerning autism and intellectual disability. My name is Tom Kosker. I am an advocate with Disability Rights Connecticut, the protection and advocacy system here in Connecticut, as well as a parent of a 16-year-old son with intellectual disability, as well as an 18-year-old daughter who's in college. I'm going to speak about specifically just about sections 3, 4, and 5, which are on the abuse and neglect complaint system in Connecticut with DDS. We've heard a lot of testimony today on a lot of different aspects of this. So I just want to raise, as an advocate, I work with a lot of individuals who interact with this system, and many of those interactions are not so positive. We've heard some of those today, some heart-wrenching stories, and I hear many of those on a daily basis as I work with clients. So I'd like to raise a few aspects in addition to, I love the idea, we support the idea of the transparency of the reporting, the annual reporting, and some of those aspects. But as some others have testified today, there are some details I think that need to be considered and issues that we've come across in my work. So one of those is the lack of independent investigators. So very often the investigators that are doing the investigations are employees of the provider, at which the abuse and neglect, suspected abuse and neglect has happened. So that's an issue, as we can all imagine. They do have independent third-party investigators who do participate at times, although they're limited and there's not many of them. The timeliness of the reports and the investigation is also an issue. Oftentimes there's continued exposure by the individual who has been potentially abused or neglected, who might be continued to be experience those conditions while the investigation is going on. Another issue is when these reports are issued by the investigator, there's, as you would imagine, at the end of the report, there's a series of recommendations. Often those recommendations, there's not a lot of follow-up on whether those were implemented, right? Often they involve maybe some actions with the employees that might have done the abuse or neglect. There's also like training that might be required, some kind of systemic provider-wide issues that might need to be corrected. And there's not a really good system in place that we've seen to ensure those things actually happen, the accountability to make sure those corrections take place to avoid that in the future. And kind of going along with that same idea, there's often situations where repeated abuse and neglect. We talk to clients who've had repeated abuse and neglect over many months and years and substantiated abuse and neglect. And yet there's problems with the system and how those providers are treated and how corrections are made and improvements made. Or sometimes a provider things might have to happen. We had one group home that got closed because there was just too much repeated abuse and neglect in those places. So I think there's some issues around there. So I know I'm bringing up a lot of issues. I do have recommendations that I'll provide in my written testimony as well. The last thing I just want to bring up, which is relevant to, I know I'm at my 3 minutes, the transparency of the reports to the parents or guardians of the individuals. So it is really tricky. And I tell you, Mr. Rothschild, Rothstein actually talked about it briefly. But when you ask for those reports as a parent or guardian, it's, first of all, it's really tricky to understand what you're allowed to get. And there's kind of like a shortened version that you get as a parent or guardian. And you need to request directly to the DDS commissioner to get a full report, and redacted, of course, for obvious reasons. But that whole process is very tricky as a parent, and usually a parent who's going through kind of a traumatic event through this process. So, you know, fortunately, if they connect with someone like us, we can help them through that process a little bit. But it's a very tricky and cumbersome process to go through. So anyway, those are just a few issues that I'd like to raise today. So thank you for hearing me.
Thank you so much. Yep, Senator Lesser.
No, I don't have any questions. I just want to thank you for your really substantive and thoughtful testimony, and look forward to diving in more detail to see what we can do to strengthen this bill.
Thank you, Senator Lesser.
Great. Thank you so much.
Thank
Have a
you.
wonderful evening. Next, Rob Burrell, followed by Jeremiah Luis. Oh, Rob's here.
He's having issues getting his link to work, so
Okay,
we
so
have
we'll
to come back to him.
Okay. Is Jeremiah with us? No? Okay. How about Susan Pleasant? Nope, that
Who
she didn't.
was not accepting the invitation to promote, but
Susan is in?
she will be now.
Is she, okay. Should we keep going?
No, she'll be here in a
Okay.
second.
There she is.
Good evening, Human Resource Panel. I have a new appreciation for lawmakers today, as I've been sitting here all day waiting to speak. Last spring, I had the honor of visiting our state capitol. There on the wall in the lower level beneath our state flag and the flag of the United States of America hangs a plaque with the name of Fighters of Freedom. Today, I fight for the freedom of those who reside in our state, who desire to build families, who are in the need of reproductive rights for reproductive assistance. The privilege and right of parenthood should not be divided amongst social classes. It is important for us as intellectual citizens and intelligent lawmakers to push and pass HB 7022. Social class and gender discrimination not only exists in our cities or state, but in our nation. Reproductive rights should include both male and female medical reproductive procedures, including mental health and wellness. Passing HB 7022 would give each class and gender a path and right to build a family. Who are we to judge the medical availability and support of those individuals, not only in our state, but our society? That society which is bringing in many medical advancements, including medical advancements and treatment for those who want to build families. As an example, if a man or woman has a blocked artery, who are we to say that blocked heart artery cannot be unblocked? In the same context, if a woman has a blocked fallopian tube, who is anyone to say we cannot unblock that fallopian tube? Who judges which procedure is more vital or more necessary over another one? Not all medical procedures affect all people, nor do they have the same weight. Family building, family planning sometimes includes the need for assisted reproductive therapy. Sometimes medical assistance is needed for family building and planning. Blocks in family building need more than just a diagnosis as provided by state Husky Insurance. It includes and necessitates stimulating hormones, blood work, follicle monitoring, and other important procedures and therapies not mentioned. Today, I urge lawmakers in Connecticut to pass House Bill 7022, being pioneers for family building rights of individuals and couples in our state, in our great nation. Thank you.
Thank you, Susan. Thank you for hanging in there all day with us. And thank you for your
Thanks.
testimony. Next is Leslie Bennett, followed by Diane Rakakot. I'm sorry.
Good evening, Senator Lesser, Representative Gilchrist, and Representative Comey, and distinguished members of the Human Services Committee. My name is Leslie Bennett. I am a Brantford resident, and I am the co-chair of the Connecticut Rare Disease Advisory Council. I am here to testify on behalf of the council. We strongly support HB 7103, the Katie Beckett waiver work group recommendations, and we're hoping that this bill will help help lower the wait list. And we understand the concerns of the Department of Social Services, and we do hope that they're addressed in the next bill. The bill that is very concerning to us is House Bill 7108, the Autism and Intellectual Disability Bill. We appreciate all the work that your council has done to try and help those with autism and developmental disabilities who have an IQ above 69, but have a level of need we understand that this is difficult for everybody. However, we feel this is an equity issue. The RDAC, for once, is a group that deals with a large number of people who have intellectual disabilities. According to the 15 centers designated by NIH as intellectual disability research centers, this includes the Johns Hopkins University Kennedy Krieger Institute. There are over 1,000. There are thousands of rare diseases that are rare genetic diseases that are known to cause intellectual disability, that our council wasn't involved in this. We're not named in this bill, and we should be. It's inexcusable that really to members of the rare disease community that we weren't, and for a couple of reasons. So if you're going to proceed with this, we feel that you need to include language where the RDAC is named as a participant. Revising the intellectual disability definition should not be left only to the autism community and the developmental disabilities community. It has to include our community as well, and any other groups that are involved in this. The Kennedy Krieger Center, the reason I mention it is one of our members is a physician. She is a full professor of medicine at UConn. She is an endocrinologist, and she is also still an adjunct professor at Johns Hopkins University because she is one of the world's leading experts in rare bone disorders. So she works closely with the Kennedy Krieger Center. They will tell you that disorders like Fragile X, Rett syndrome, Angelman's, PKU, Gaucher, Tay-Sachs, and Prader-Willi are all known to cause intellectual disability. For more than 40 years, our state has included Prader-Willi in the definition of intellectual disability, and it is still part of the criteria for intellectual disability waivers under DDS.
Your time is complete. Please summarize.
The thing that we're asking for is we agree that you have to expand the waivers for the other groups, but please do it through the autism waiver or find a way to carve out a separate waiver under the DDS waiver program for those with developmental disabilities that do not have an intellectual. Please do not go through our community, and the people with intellectual disabilities are scared to death right now that their access to these waivers is going to be damaged. I have families of children who have disorders that we know will cause intellectual disability. They're waiting until their child is 7 to get tested, and they're afraid that they won't be able to get a waiver because if you open this up to all the others, the damage is going to be done. There are going to be huge waiting lists there. And for our community, there's only 3 waivers that families have ability to access. One is the Katie Beckett, and then the 2 under DDS. And there's wait lists for all of them. So please, help us. If you do modify this, one of the things that we would like to see if you're going to modify the definition is to go back to it's a conditional waiver that's awarded to children under DDS, either birth to 6 or 3 to 6. where these are children who have severe developmental delays that are either identified in the Birth to Three program or by their physicians. And they used to do this. My daughter Kelly was on one of these conditional waivers under the Department of Mental Retardation. So this is, you know how far back we go with that. But it does really help these families. And we'd like to see that included in the definition. We'd also like to see if it's possible to add a compassionate waiver for children with neurodevelopmental disorders that are progressive. This would have helped the Negron family. And in states like New York, they are awarded. It could be, a small amendment, wouldn't take long. And we're only talking about 20, maybe 25 slots for that. So thank you.
Thank you. And you learn something new every day,
I know.
hopefully. And so, learn today what the information you shared about rare disease and IDD. So
I
thank
know.
you for that. And,
Well, that's why we had
Yeah.
wanted to come to talk to you.
we appreciate
Um,
it.
And we would still like to come and sit down and
Yes.
talk to your committee. I think at some point, the physicians who read the OPM Altarum report were just outraged when they read it. They were just like, these people do not understand intellectual disability and the scope, the number of people it's affecting. So that's
Interesting.
why we would like to have a meeting with you at some point when everything slows down. We'd like to sit down and talk to you about that.
That'd be fantastic. Thank you. Representative Comey?
Thank you, Leslie. I just wanted to ask you, I'm glad you got to bring up just briefly the OPM report, which you mentioned to me that you had real concerns about that. Is there anything else you want to say about that?
It's just, they needed to include more. I did contact OPM when we found out about this. Our council's only been around for a little over a year, and we had a meeting with DDS and Krista, Asta, I always mispronounce the name, but she was one that told me that they were having it. When I contacted Tara Vines, she was like, oh, you're not part of the, Public Act 23-137, you weren't named, so you shouldn't be part. And I'm like, you have no idea. We have so many disorders that fall in this. We really should be included because our view is a little bit different than the autism and developmental disabilities. We want to protect those with intellectual disability. And that's our primary goal. But we also think that the others, deserve help as well. We understand that, but why tear apart a waiver system that's working for a group? And intellectual disability and the services they need are different than those with autism and even different from those who just have developmental disabilities without intellectual disability. They all need something a little bit different. So let's focus on, it's not so much silos as the needs of these people. We have to really focus on their needs. And intellectual disability, it is tough. I know the state went through, Kelly was old enough that I'm aware of all the stuff that went on. And I know when they went through and set the hard, IQ of 69 was financial. They figured there would be too many people. And if you look at it in that mild group, if you look at the outbreaks by the department on the people that are served, the ones that are in the mild IQ, they're the ones that are the bulk. 60% of those have a level of need, 40% of those have a level of need above 5. When you start moving down, you'll see the level of need in the moderate group is about 60%. By the time we hit the severe, it's over 80%. And by the time we're at, profound, it's 98% of those have a level of need over 5. So you can see that progression as well. But we really do need to protect these people. We need to give those who are most need those services. And then we can, help all the others. But we need more waivers, bottom line is it. And you know that.
Yeah, we certainly don't want to pit groups against each other and everything's so individualized. It's difficult. And so you did mention that include in the definition, the conditional waiver and the compassionate waiver as well. Is that all in your written testimony?
No, that has come through. I will I'll send you information more about that. Everybody was hitting me with everything. We were trying to get all the testimony in, and on top of it all, my husband had a stroke over the weekend. So it's minor, but it's just been a little crazy. So that's why the people, the Rubio family, for instance, would be helped by a conditional waiver. they would be eligible for it. And, you know, they're a family in Branford that's has an ultra rare disease that is very involved.
Okay.
The Negron family who came here last year to testify about the Katie Beckett waiver
Sure.
would have been helped by the compassionate waiver. These are for children. I mean, their daughter, the minute she got the diagnosis, she had a lifespan of maybe 3 years and she passed within 2. These are conditions that are going to go very quickly, but those families need help desperately. And I do understand
Thank
the
you for
waivers do
being
help.
there
Thank you.
for all of, you know,
We
all of
try.
the families and
We
the
try,
RBO
we try to get them
families.
all.
All right.
Thank you. And thank you for all the work you do.
Thank you, Madam Chair.
Have a great evening. Thank you so much.
Okay, thank you.
We're going back to Rob Burrell and then we'll go to Diane Rassick. I'm sorry if I'm mispronouncing.
Thank you so much. Good evening, Senator Lesser, Representative Gilchrist, and honorable members of the Appropriations Committee. My name is Rob Burrill. I'm president of SEIU 1199 New England, and I apologize. I'm having some trouble with the video on my my camera. Our union represents 25,000 healthcare workers here in Connecticut, including about 7,000 nursing home workers and 3,500 group home workers. Those are low-wage workers in long-term care industries who've seen their wages decimated, frankly, due to the fiscal guardrails over the past many years. And we thank the committee for taking a look at ways to address the crisis in terms of the poverty level wages that folks are working under. Senate Bill 1450 is looking to address those low-wage concerns that our members have. We appreciate the support in the bill. However, we do have some concerns about some elements of the bill as it is currently written. It doesn't address the low wages amongst non-direct care workers, such as dietary and housekeeping workers in nursing homes. The crisis of unlivable wages exists in every department in our nursing homes, and we don't feel that we can solve this problem without taking a holistic approach to solutions. I would just refer people to the fact that you know, many of our members are making between $18 and $22 an hour. One of our members just literally texted me 2 days ago a help wanted sign from McDonald's where workers are being hired currently at $22 an hour. So wages have outpaced long-term care worker, caregiver wages, even in fast food. We're also concerned about some of the language in Section 1B of the draft of the bill. It doesn't require nursing homes to provide a minimum wage if it's determined that state funding is not sufficient to provide for an increase. Furthermore, there's not a definition about what constitutes sufficient funding. So we just think that we've got to be sort of specific and intentional in terms of how we're looking at addressing the problem of poverty level wages in long-term care industries. Finally, we think that there's an excellent frame that's provided within the bill on how to achieve those wage increases, but that it's too slow in terms of the wage progress that it's directing for long-term care employers. We can't wait until 2027 to reach $25 an hour for workers in these industries. They need relief desperately now. I was in a meeting with 60 of our members in long-term care a week ago. I asked the room how many of those workers had worked 100-hour weeks. 55 of those 60 workers raised their hands. I then asked how many had coworkers that had at some point in their work lives been homeless. Half of the room raised its hand. So we really are at a level of crisis in terms of the wage and benefit standards in both of those industries. So we are supportive of Senate Bill 1417, the separate bill, which would establish a nursing home workforce standards board here in Connecticut. We represent 1 out of every 3 nursing home workers in the state, and we are fighting to ensure that our membership has livable wages and proper training. But there are many, many thousands of nursing home workers across the state that do not have union representation and therefore have no ability to advocate for their own wages and benefits. So we would finally, I would conclude by just asking the Appropriations Committee to pass Senate Bill 1417 and Senate Bill 1415 with the amendments that we will be submitting. Workers in Connecticut's nursing homes and group homes, as well as the people that they care for, can't afford to wait any longer. We thank you for your time and for your attention to these workforces.
Thank you. Thank you so much, Rob. Next is Diane Rassicot. How did I do? Is it close?
You did fine. Thank you very much.
Ms. Gilchrist. Thank you, committee, for letting me be able to speak today on Bill 7106. An act concerning recommendations of advisory council to wheelchair repair. I was on the task force for the wheelchair repair program. I'm also a member of the advisory council. I'm the only member representing the industry in the entire council, which is a little disappointing because it kind of outweighs the recommendation and votes which have come across. I'm not going to go point by point in this bill because Wayne Grau from NCART did a very decent job on kind of hitting the highlights with his testimony and some points. Some points I do want to bring up is some concern I want the committee to consider in regards to this bill first originally came out in regards to complex rehab, which is our most disabled clientele that we service. That's what my company, I represent National Seating Mobility. I'm their vice president of payer relations for them. I'm involved in working with all the insurance plans and also working with policy and working with Medicaid offices, CMS, et cetera. When I looked at the changes that were added into these recommendations, what really stood out to me was a little bit of a concern. Is this bill now added in standard DME items of scooters? We at the company, we only sell like 2 scooters. I mean, we do it, but most complex rehab companies are not their forte because they specialize because of the uniqueness of what complex rehab involves. My concern with this additions of adding scooters and mobilities, you only had 2 current companies in the state of Connecticut reporting even on this current bill that was established. That was us and New Motion. You had 2 other suppliers that do complex rehab in the state. Nobody's even stepped up and reported their numbers yet. My concern is who is going to oversee when you have over 150 different DME companies that can do this service. Who's going to monitor all those type of things? I'll be honest with you, since we started this repair program, I have a number of scooter repair orders that come to my company that are not scooters that we supplied. It's a problem across the industry as a whole. It's a concern. You have out-of-state providers, but this bill does not cover those for out-of-state being accountable for service what you sell. So I do want the committee to take that in consideration when they had these additions that were put in. There's a lot of things that were shared in the task force before that I know Representative Case and yourself, Representative Gilchrist, were part of those and Lesser in those communications. But I urge the committee to make sure to go back and watch some of those other hearings that we had from the task force itself for this advisory council. There's a lot more that goes into these things. So I'm a little concerned with those additions and who's going to monitor it and who's going to be accountable for those. The other thing I had noted in here that was a little bit of concern was some of the things around the language for definitions of text, what that means, times, how we report some of these things. The key thing for this intention of this bill is making sure we had those 10-day windows. And my concern was some of how this was written up is going to deter other people coming into this workspace. We're challenged as an industry to have enough suppliers doing this business to begin with. Some of these things, how they're outlined, may be a deterrent. We want more people in this space. We need more people doing these type of services. You're down to 2 or 3 and typically in every state that's doing the CRT services. We need to be looking at why is that the case? And what can we do to improve that? Some of these things, how it's written, I think might be a deterrent, especially when you see some of the penalizing language at the end of this additions. I understand you want people to get this done super fast. We're working at that. We're doing it extremely well for how fast this came out and for the things that we had to develop for IT systems, some routing systems.
Please summarize.
Thank you. And what I just asked that if the council would go back and read through what the task force did before, in addition, watch some of the hearings that we've had posted from the advisory council to understand the nuances, because it is complex, but just take those things in consideration. I appreciate time to speak for y'all.
Thank you so much, Diane, and we'll take a look at your testimony and circle back. Thank you so much. Oh, wait, one question. Senator Lesser, go right ahead.
Thank you.
He's chewing. That's
Thank you.
And I haven't eaten yet either, Senator. I would like to go to the dinner soon.
all 8 people watching at home on CTN now have that. Thank you, Representative Gilchrist. I just wanted, I don't have anything to add other than to just say thank you for serving on the task force. I know a lot of work has gone into that and appreciate the work your work and the work of all the committee members. It's been a lot of work, and hopefully we get to a better place in terms of improved customer satisfaction in the city. Thank you very much.
Thank you.
Thank you. Next is Mag Morelli, followed by David Schwartzer.
Thank you so much, Representative Gilchrist. Senator Lesser, members of the committee, my name is Mag Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit and mission-driven provider organizations serving older adults across the continuum of aging services. On behalf of Leading Age Connecticut, I'm pleased to provide testimony on several bills before you today, so I'll just summarize. First, on House Bill 7105, an act concerning forensic audits. This bill authorizes DSS to conduct forensic audits of nursing homes and residential care homes and is similar to a bill proposed last year, with some changes made to reflect concerns that were raised at the time. While we appreciate these changes, there are still several issues with the bill that concern us, including the proposed procedures for conducting these audits. Because these audits are of such a serious nature, we are requesting that the statute that governs them be drafted clearly and that the provider be afforded appropriate rights and due process, including those afforded under the DSS audit statutes. We've outlined our concerns with the bill in detail in our written testimony. On Senate Bill 1416, an act expanding long-term care options, Leading Age Connecticut lends our support to this bill, which appears to call for expanding the options and services offered through home and community-based Medicaid waiver programs for long-term services and supports. Now that we've nearly reached our rebalancing goals, it is appropriate that we look to our Medicaid waiver programs to ensure that we continue to provide a robust and high-quality system of long-term services and supports in the community. On Senate Bill 1417, an act concerning establishment of a nursing home workforce standards board, we oppose this proposal to establish an independent workforce standards board. A similar bill was enacted in Minnesota in 2023 and has resulted in nursing home financial hardships, discord between providers and worker organizations, and a pending lawsuit. As established by this bill, the Workforce Standards Board would be funded by the state legislature, but its decision-making authority would be independent of legislative oversight and approval, thus giving it unchecked authority over the entire nursing home sector. While we encourage the committee to support our nursing home residents and the employees who care for them, we cannot support this bill, and we respectfully ask the committee not to move it forward. And finally, on Senate Bill 1415, an act concerning Medicaid and Medicaid funded programs. While we know that this bill is proposed with the best of intentions, we cannot support it at this time due to the financial impact it would have not only on the nursing home sector, but on the entire field of aging services. While the bill would require nursing home minimum wage for direct care employees of $22.50 no later than January 1, 2026 and $25 no later than January 1, 2027, the jump from $22.50 to $25 is dramatic, an 11% increase in just one year period. This would exceed any historic increase in the Connecticut minimum wage and may be too much for most nursing homes to afford. These mandated minimum rate increases to the nursing home direct care employee wages will also impact the wage scale for all other employees in the nursing home and will place wage pressure on the other sectors of aging services who draw from the same pool of employees. While this is a laudable goal, the fact is that there needs to be increased revenue to pay for these increased expenses, and that's where our concern lies. While we fully support our aging services workforce, we cannot support this mandatory minimum wage scale proposal at this time. Thank you for the opportunity to provide the testimony, and thank you. I appreciate the ability to come up and testify right now. I'm happy to answer any questions.
Great. Thank you so much, Mag. Any questions? Senator Lesser.
So you've submitted written testimony with regard to the audit.
Yes.
You've been here for a lot of the day. I don't know if you were here when initially in the commissioner's testimony.
I was not here.
Okay. So she went on to with some detail about why she thought that was really essential as we're trying to address the issue of, in some cases, chaotic closures of nursing facilities. And she felt that having the powers, as the department is proposing, was really essential to getting the information about where we were and sort of provide a more even-keeled system going forward. Since you didn't hear the testimony, I'm not going to ask you any more questions about it, but I would love to sort of.
Yeah, I mean, our issue is more on the process. In particular, and this is what we testified to last year too, is that there's no threshold for when the department can ask to do such an audit, and the audit is very expensive. The provider is asked to pay for it, by a third party. So there's, if we were to put it in state statute, there's nothing to say that, say, the next administration or the next administration wouldn't decide, let's do a forensic audit on every nursing home. So we really are looking more as to why, you know, putting in sort of a threshold where they can request it. And then once they do, you'll see most of our testimony is just about the procedures. It's more technical testimony that we put into place, like clarifying that they have the rights of any other audit, that type of thing.
Yeah, what she told us was that when they get a whiff that something is amiss, for example, there's a whistleblower, or you have reports that a worker is not getting, you know, there's been a problem with their health benefits, or some other issue, their taxes are not being paid, that sort of suggests that there might be something amiss. Right now, the department's only power is to request documents from the nursing home, and that this would really be essential if the nursing home is not really being forthcoming in their particular financial circumstances. And so, yeah, I agree with you. I don't want a future hypothetical governor using the power to drive nursing homes into financial ruin for arbitrary and capricious reasons. But I assume there's some sort of language that we could put in that would protect against that eventuality.
Yes, I think there is. There definitely is. And we'd be happy to talk about that,
Great.
both to you and DSS.
And I appreciate your testimony on the other bills, and I think we'll have a greater ability to sit down in some depth and engage on those as well.
Terrific. Happy to.
Thank you very much.
Thank you.
Great. Thank you, Senator. Thank you so much. Good
Thank
to
you.
see you. Next is David Schwartzer, followed by Dominic Cotton.
Distinguished co-chairs and committee members, good evening. My name is David Schwartzer from Newington, Connecticut, and I'm here today in support of Bill number 1420. As I'm sure this committee knows, there are an estimated 100,000 Connecticut residents, mostly seniors, who purchased long-term care insurance policies 15, 20, 25 or more years ago. They purchased these policies with an expectation that they may need the protection it offers many years in the future. What they did not know is that the long-term care insurance industry was lying to them to trick them into buying a policy that was financially doomed from the start. They lied about what future premium increases would look like, and they didn't disclose that the industry had intentionally created a scheme that would raise premiums so high that in the future, policyholders would have to choose between buying groceries, paying their rent or mortgage, or using several months of their Social Security benefits just to pay their premiums. These policyholders don't understand how the industry could say that for 20 years, the premiums on these policies had never increased, and yet today they are paying increases of 200, 300% and more. These lies have been compounded by our own insurance department, who seems to favor the industry over the policyholders. They hide behind the excuse that they are following the laws as written, and has said that if people want a different outcome, the legislature should pass new laws and they will follow them. And yet, our own insurance commissioner opposes this bill. I believe Bill 1420, with some minor enhancements, provides those new laws that will finally bring relief to the long-term care insurance policyholders in Connecticut. In my limited time today does not permit me to discuss each aspect of this bill. Those details are in my submitted written comments, but I will say this: requiring a full refund of all paid premiums in exchange for cancellation of the policy, requiring insurers to disclose both incurred and paid loss information as part of any rate increase request, and requiring the insurer to provide detailed information regarding reinsurance contracts associated with the policies that are the subject of that rate request, all of which are contemplated in this bill, are substantive changes, with some minor enhancements to ensure these requirements bring the desired results, which I discuss in my written comments. I believe Bill 1420 has the potential to bring real relief to the Connecticut policyholders. Thank you for the opportunity to speak to you, and I would be happy to answer any questions you may have.
Representative Hughes, go right ahead.
Thank you, Madam Chair. Thank you, David. We've been in communication about proposing these bills for a couple of years, I think. It's hard to believe that there's only 100,000 policyholders of long-term care. And I know my household has 4 of them. My mother is an additional 5 of the 100,000. One of the things that we have talked about in terms of proposing policy, and that you talked about a little bit in your testimony, is what can our state control and what's out of the control of, for instance, the commissioner and or the insurance department. And I'd like you to say a little bit more about that, especially as we think about long-term savings. Like, presumably if us 100,000 folks have a long-term care policy, that is going to save the state from us, needing Medicaid or Husky or long-term care, home care for the elders, or whatever the program is, because we will be paying for that care, hopefully in our home with our long-term care policy. So what have you learned in terms of our back and forth about what what can we regulate, if you will, or legislate, if you will, in terms of some of those things, especially for these out-of-state companies?
So even though the companies are out of state, if they are licensed in the state of Connecticut, then the state of Connecticut has the ability to regulate the way they do business. There are a couple of things, and I think Representative Vail will probably understand this perfectly. One of the biggest issues that I have learned is that the industry comes forward to the insurance department and says that they have paid all of these claims, the premiums that they have collected are insufficient, and as a result of that, they need these rate increases. The best example I can give you is a rate increase that was requested by Bright House Insurance in 2024. In their initial filing, the people who filed on behalf of Bright House disclosed that since 2008, Bright House Insurance has had 100% reinsurance on their policies. And what that means is they pay a claim, they turn around to Genworth Financial, who gives them their money back. Genworth Financial turns around to their retrocessionaire, which is owned by GE, which originally was Genworth Financial, and Genworth gets their money back. That means that while Bright House tells the Insurance Commission that they have paid hundreds of millions of dollars in claims, they've actually done nothing, paid nothing. I questioned the insurance department about that because there was an article in the Hartford Courant about a year ago that indicated that when the insurance committee or the insurance department is looking at rate increases, they do consider the cost of reinsurance, which they deduct from the earned premium. This, of course, increases the loss ratio for the company. They do not consider reinsurance recoveries. So the long-term care carrier benefits on both ends. They get to reduce their premiums because they paid for reinsurance, but the department will not even consider the reinsurance collectibles. I think, as indicated in 1420, requiring not only the company to discuss or to reveal their reinsurance, but requiring the insurance department to consider that reinsurance in terms of the loss ratio is a very important option.
And what other technical revisions were you suggesting?
So in section, just give me a second. there is a section in the bill which discusses I'm sorry. There's a section in the bill that talks about a return of premium. As Jan Kritzman indicated earlier, right now I'm only aware of one company, Transamerica, that is offering a policy buyout or a return of premium. You know, it really kind of means the same thing. As she indicated, they offered her about $73,000. They offered her husband about $28,000. I know another couple that had a Transamerica policy. The wife was offered about $50,000. The husband was offered nothing. And they questioned Transamerica about why that was the case. And Transamerica's answer was, statistically, women go on claim more than men, so we want to buy back their policies in order to avoid the liabilities that go with them.
Wow. On International Women's Day, there you go. Okay.
The other suggestion that I make in my written comments is in terms of incurred and paid loss information. I believe the bill as currently written indicates that the carriers need to provide an annual report about that information. My recommendation is that they need to provide that information for each rate increase that they are requesting, and that the insurance department needs to look at the paid loss information in addition to the incurred loss information, because as you may know, incurred losses include something called IBNR, which is incurred but not reported. That basically is the insurance company saying, we know there are claims out there, we just don't know about them yet. And while most insurance companies are very strategic about figuring out that number, it's also a number that can be easily manipulated. And I believe that the long-term care industry is manipulating that number in order to increase the loss ratios.
Got it.
One thing that I did not mention is that under current statute, an insurance policy for long-term care has to have a minimum loss ratio of 60%. There was a rate increase that was approved, I believe last month, where the loss ratio is 0. They have paid no claims, although they've received significant premium. But because they believe that the future claims will be significant, the insurance department has given them a rate increase in anticipation of meeting that 60% loss ratio. My policy that I have, which I bought in 2004 for a premium of $1,170 a year, has gone through 7 or 8 rate increases. I'm in the middle of a 3-year rate increase, and in 2026, that $1,170 will be $5,200 a year. My wife and I each have the same policy, so we went from $2,200 a year to over $10,000 a year.
Yeah, that's what I'm hearing too.
I wrote to the insurance department a couple of months ago because they put in their disposition report for that 0% loss ratio that the policy is still required to meet the 60% requirement. And I wrote to them and asked, how will you know if that happens? Is the carrier required to present a final report when the last policy closes? And if they don't meet the 0% or the 60% requirement, what will happen? Will they claw back the rate increases? Will they refund money to the policyholders? What will be the remedy for the policyholders who have now paid premium increases on a policy that did not meet the minimum requirements. I have followed up with the insurance department twice since sending my original, I follow up every month, asking them to respond to my inquiry and have not received an answer to date.
Thank you. Very helpful. Sounds like this is going to get referred, but I'm very, very grateful for your detailed persistence on this, in this big problem for what could be saving the state a lot of money if people could afford to keep their long-term care insurance. So thank you.
Thank you.
Thank you. Representative Vale.
Thank you, Madam Chair. Good evening. So your rates went from between your wife and yourself, you said 2,200 in 2004.
Yes.
To over $10,000 now.
Yes.
And do you remember what your original benefit amount was? It's usually a per day or per month.
Yeah,
or per
well,
year.
the original daily benefit amount was $200 a day.
200 a day. Did you have the cost of living rider?
I
added to
did
it?
a 5% rider
Okay,
because it is a
5%.
partnership policy.
Did you have a waiting period, the deductible period of days before it kicked in?
As far as going on claim,
Like if you went in, if you were ever, God forbid, knock on wood, had to go in, that there's usually a elimination period.
yeah,
So like
there's a 100-day.
100 days for yours. Okay. And you paid that. And so again, this bothers me. If they had a problem with their numbers and it's their mistake, their actuarial work was not accurate and things changed. Now, if there was an increase once, twice, and it does say in the policy, they're not doing anything. It does say that they can increase rates. So that's
Yes.
not as if they're not abiding, but generally it's the same. Like I said, we'll say that in life insurance as well.
Yes.
But they have broader data with life, but it's, to me, to have 7 or 8 rate increases with a total of like a 500% increase in your premiums is absolutely ridiculous. And it's just unsustainable. And then the whole point is you could buy this insurance. How old were you when you purchased the policy?
49.
49. So you had the wherewithal to, not everybody is thinking about long-term care insurance when they're 49 years old, but you were, and you did your due diligence, and this is kind of how you get paid back for it. And it's frustrating, and how insurance works is you pay for that so that if that, God forbid, you never need to go in a nursing home, that your family's not going to have to, you're not going to lose everything. You'll be able to leave something to your family. But, you might not ever go into a nursing home. Right. And so that's how insurance works. Not everyone's necessarily going to use the policy either. That you have to be required. And I can tell you, of all the policies that ever sold, the most difficult one to get through underwriting to get approved is long-term care insurance. So I want to say, like, I didn't sell a slew of long-term care policies, but I didn't enjoy it because, half the time the person was getting turned down to even get the insurance in the first place because maybe they had high blood pressure or something else. So it was a very difficult policy to get through underwriting. So it has it's hard to get, and then they do this. It really bothers me. And I just can't understand the math of it. I don't know that they're being, and I certainly don't want to sound naive because I'm not. I don't know if they're being nefarious or just poor at their calculations, and maybe a little of both. But I want to say initially, I think it might have been miscalculations and just not good. But that's why we trust insurance companies to have the best people in the world when it comes to that stuff. So I'm sorry that, that you're going through that. It's not the way it was meant to be. Appreciate you coming up here and giving us your story and making us aware of what's going on. So
yeah,
thank you.
Representative, if I can address a couple of those points and just for your information, I have 40 years of experience in the insurance industry also. So, my wife and I were called upon to take care of her parents as they grew older. They were not people of means. They did not have pensions. They did not have savings. They had Social Security, and it fell upon us to take care of them and figure it out. They lived in Florida. We were here in Connecticut, and it was a chore. And on the plane ride home, after getting them settled, we decided that we did not want to put our children through that. And that's what caused us to buy long-term care insurance. I appreciated your comments to the industry representatives who were here. And it's clear you have a very good understanding of what's going on here. That said, I would ask you to consider that this is not the accident that the industry would have us believe. I believe that this was an intentionally designed plan by the industry. As you know, every policy, whether it be on the declaration page or a separate page, gives the premium for that policy. The policy that I purchased came with a premium page that said the annual premium should be $3,658. And yet they were going to charge me $1,170. Now, being in the business, I questioned, how is this possible? Because usually when companies give discounts, whether it be your home or your auto or anything else, they list in the policy the credits that you get. And what they said to me was, well, you and your wife are both buying policies. You're both young, you're both healthy. So, we're going to give you all these discounts. Now, to date, just for my policy, I have paid about $45,000 in premiums. Had they charged the $3,658 that the policy said they should charge, they would have collected about $80,000 in premium. But here's the rub. If they had told me that the policy was $3,600 a year and might go up, I probably wouldn't have purchased it. So they deliberately undercut these policies. They paid huge commissions to their distributors in order to push the policies, or at least I know that Genworth did. And they generated these policies, but only for a short period of time. My policy was sold, I purchased it in 2004. It was sold from 2002 to 2005. Now, having been in the business, there's no way that they could generate enough premium from policies that they sold for 5 years or 4 years in order to generate the revenue. I don't care what the interest rate or the investment income would be. There are not enough policies to create the revenue necessary to support the claims that would be coming 10, 15, 20 years down the road. And the fact that every company did this is not Genworth making a mistake or Travelers making a mistake. I truly believe that somewhere the industry got together and decided, if we all do this, we're going to make a lot of money. Because the more we raise the premiums, when our policyholders can least afford to pay it, the more they will drop out of the pool of policyholders. We get to keep all the premium and have no liability.
I hear what you're saying. So they offered you a return of premium?
They have not offered me a return of premium.
So, and that's a rider you can put on a policy too and pay extra money for.
I'm sorry?
Normally, but we're talking about, because of this situation, you can get a return of premium rider on some of those policies. You pay extra for it, and you can get your money back. It's like they have it on some life.
I do
insurance
not have
policies.
that on my policy.
No, but you don't. So,
and Genworth,
I think when we were talking about it earlier, that's because of this situation. Some companies are offering a return of premium or a buyout.
Right.
It's a buyout at least equal to or greater than their premiums paid.
Well, usually a policy buyout is a negotiated figure.
Okay.
The company says, we'll give you your premium back, the policyholders, and I come from the P&C world, so granted, it is a little bit different. But the company will say, we'll give you your money back, and the policyholder will say, well, that doesn't do me much good. I still have responsibilities, or I've lost an investment opportunity, so I want something more. And they ultimately come to some sort of an agreement. I would suggest, as part of the amendment to Bill 1420, that it not be limited to just the premium paid, but that perhaps the company be required to give some additional money.
I would say interest. Premium and
Simple
interest.
interest
Yeah.
or something
Mhm.
to compensate the policyholder for their lost opportunity of that money.
Okay. I apologize to the chair, like I did not expect this to be a topic in this committee. But it's something I'm certainly passionate about. It's a problem. I don't know what the exact solution is, but, so I want to apologize for all my questions, but, I don't know.
No apologies. You're very knowledgeable. It's been very interesting to
Let
listen
me
to.
just say, Representative Vale, I would love to have this conversation with you further. I'd be happy to meet with you at your convenience, and we can discuss it further.
You're gonna call me old?
Not at all.
Okay, all right. Okay, we can meet.
Senator Lesser.
Yeah, it's hard to follow Representative Vale. I just want to thank you, David, for your advocacy on this issue. I know you're passionate about it. I know there's a lot of work we can do to help turn things around. And I'm grateful for your thoughtful written testimony, which I have reviewed and we'll be talking further. So I just want to thank you for that.
Thank you very much.
Great. Next is Dominic Cotton, followed by Andrew Sellinger, followed by Liz Gustafson.
Good evening. My name is Dominic Cotton. I'm from Milford, Connecticut, and here to discuss the Katie Beckett waiver, as well as I think it's 7108, the autism and IDD waivers. And I guess I'm coming at this from a different perspective. I know my partner in crime, I said, Leslie Bennett, certainly clarified the issues as far as the rare disease community and our needs with respect to waivers. I wanted to talk about a couple of things. First of all, I'd like to thank the two of you for your work that you did on the Katie Beckett waiver. I think it brought to light some of the issues that we face as communities with wait lists and not knowing where we are on the wait lists. I know this is an experience that I dealt with some 11, 12 years ago when we had negotiations over the ABI waiver 1 and the ABI waiver 2, which I was heavily involved with. I've been involved with Medicaid waiver services for about the last 25 years as a person providing services under different levels of care, as well as somebody who's advocated for services. And I think when we think of like waiver programs, they're designed to meet the needs of specific communities. And that's how these programs come about. The one that I work on is for acquired brain injury, obviously autism spectrum waiver. If you look at the menu of services, they're slightly different. They're more skewed towards BCBA's services, which I did start a program on with that. So I do understand a lot of the behavioral concepts that go along with that. But I think when we try to change one of these programs to mold it to really fit the needs of one group over another, I think we're really doing a disservice. If you guys came around to the idea that you wanted to create a separate waiver for people who have IQs over 70, and from what I saw of it, like duly diagnosed. But when I read through the text of 7108. It just seemed like it was like trying to take the IDD community and co-opt some of their waivers over to the autism spectrum side. Now, Senator Lesser, I mean, I'm going to quote you on the number that you gave for getting out of 300 spaces on the Katie Beckett waiver. I think you said it was somewhere around $8 to $11 million, somewhere in that time frame. I think if we want to change things, then we have to appropriate
Your
to
time
those
is complete.
specific
Please summarize.
to those specific areas. So with Katie Beckett, you're talking about $8 million to go through their wait list. If you're talking about wanting to create more slots for autism spectrum disorder, I don't think that that's an issue. That's something that should come before you as a body to have a discussion on, not to take one group's waivers and kind of pass them over to the others, or, create a backup or a further backlog of waiting lists for other people. So, I mean, if this group wants to move ahead with a separate waiver to address those people who have, IQs over 70, and have, I don't know, behavioral needs. I'm not sure what the specifics that they were trying to get at with the creation of this. I've worked with a lot of different people over the years. I mean, I've run a residential treatment center for mentally ill. I've run programs for developmentally disabled. Every individual group has different needs. And, a lot of what we try to create is what we call person-centered planning. That's what all these programs are supposed to be designed on, because each different community has different needs. Brain injury has different needs than autism spectrum disorders. Same thing with IDD, and Katie Beckett. I mean, there might be some overlap where people are in both categories. And I know I'm working with somebody right now who started out on the autism waiver, unfortunately developed a seizure disorder. They went to do surgery for him, and they created a brain bleed, and now he has a brain injury. He's 17 years old. So I'm talking to the family about, okay, look, you're going to have 3 years to be able to get onto the brain injury waiver. It's not going to start until it's 18. You're already on Medicaid. So, you need to start this process along here. So
Thank
you
you.
got to
Bill.
be able to
Yeah.
figure those things out.
As we're moving forward, it certainly has now become crystal clear that we need to engage folks in the rare disease community so we can better understand. And you have such a wealth of knowledge. So we'll certainly follow up.
Thank you.
Thank you very much. Next, we'll hear from Andrew Sellinger, followed by Liz Gustafson.
Thank you, dedicated members of this committee. Thank you for hearing my testimony. My name is Andrew Sellinger. I'm from West Hartford, Connecticut. I waited 9 years to have this opportunity to speak on behalf of my son for his experience with abuse and neglect and our family's experience. So we normally would call the group home. We called in the evening to see how my son was. The staff reported his face was a little red. Oh, why was his face red? He had an issue at the day program. Oh, really? What happened? And they didn't have any information about that. So we proceeded to go to the residents to see what he looked like and what had happened. And when I will hold this up and I will show you guys a little closer if you like. We found Brian to have 2 black eyes and lots of abrasions all over his head. And with no explanation, there was no reporting by the agency when this happened, which, they're mandated reporters. And nothing was done. And then it was reported to us through this whole process that he did it to himself, that he went and punched himself in his eyes. And it happened more than once, twice. He had black eyes. So this is it happened in 2015. So this is not a new problem. You know, a lot of people are talking about staff shortages and pandemic and a lot of things. This is a systemic issue that has been going on a long time, too long, and needs to be addressed. So the conclusion, the doctor said that this was multiple trauma, soft tissues around the eyes and left ear, and strongly suspicious of an assault. And it was absolutely not substantiated as assault, only neglect from not giving a medical treatment when the incident happened. And that has, you know, left my son with a lot of anxiety and lasting, you know, issues from trust and from this issue. So, you know, supporting 7108, but I would like to also make a comment that we also would like 7108 to include numbers of people with autism, because we don't know those, and there's no way that we can plan or do anything without knowing what the population is. I have a folder at home with 255 reports in the 3-year period that my son was with this agency. And all those 255, most of them had been restraints. And in every one of those restraints, he had been hurt. And in all the reports, the commonality that I heard every time, he got out of the restraint. He got a hand loose and he started ripping clothes or trying to hit or whatever. If a restraint is done properly by people that know what they're doing, there is no reason that they should be able to get out of the restraint and hurt themselves or hurt anybody else. They're not properly trained. It's a go-to. This agency, it was a go-to. Rather than redirection or trying to avoid this situation, it just, you know, kept on going. He was always brought into the bathroom at the day program, the only place where there were no cameras. And we would always tell them the worst place you can take an escalated person is into the bathroom, where there's tiles and projectiles, slippery floors, and that was always their go-to to do. You know, and abuse comes in many forms. He was being treated for a pineal cyst and was on pain meds, and the side effect of pain meds are constipation. And we inquired about his—
Your time is complete. Please summarize.
BMs, and it had been reported to us that 2 weeks since he had a bowel movement, and there was distress and behaviors reported to go along with that. So in summation of this, I am in support of 7108 to revamp the abuse and neglect process, to eliminate the self-investigation and have independent investigations for these incidents. Thank you very much.
Thank you. Wait, we've got some, Andrew, oh, we have some questions. Thank you for being here. When you said you've waited 9 years, has the legislature never done legislation on the abuse neglect for this department?
No.
Oh.
I have a volunteer, according to an attorney who did disability rights. We had our, I think, our subcommittee a few years ago. He said that when he was at DDS, as their in-house attorney, he wrote the statute 22 years ago.
Wow.
And he said it's probably time to refresh it.
Thank you. That is really, really helpful.
I'll dig out the name.
Okay, wait, Rep Hughes has.
I've been advocating in Washington DC when I go to advocate for Fragile X and, you know, have made this part of my advocacy platform. But in state, you know, I haven't seen any real movement, and the issue is getting enough people together to make an impact and get attention. And I think we're finally coming to the point where we're starting to be heard, and that's why I have come as many times here to
Thank you.
testify on this important issue.
Greatly appreciated. Thank you. Representative Hughes.
I appreciate your testimony and your persistence. Again, you left this out, but I'm sure it's relevant for the committee members. Is your son nonverbal?
Yes, he is. He's nonverbal. He could not report any incidents. He can say a few words, just some basics of his wants and needs, but he could never report on an incident such as what's happened to him.
So terrifying. So both the agency and the DDS internal, review of the complaint didn't come up with the finding of assault ever?
No, they didn't. They didn't come up with that conclusion. They only substantiated neglect for not taking care of them. For what? If you substantiate not taking care of them for, and that's considered neglect, then there had to be some abuse or something that happened that you would, be looking at. So I don't understand how you could, come up with that conclusion. And when I asked the regional director of DDS to reconsider the evaluation that was made, I was given a flat out no. You cannot do that.
And it sounds like you have a binder full of 250 complaints. They're not all about one client, right?
This is all my son.
Oh, they
This
are.
is one agency and my son, not anybody else.
Okay. And you said it's over the course of how many years?
3 years
3
we were
years.
with the agency. And just to conclude, my son has been 7 years at another agency, and he has not had not one restraint, not one. How necessary were all those restraints? I would like to see much stricter controls on the use of restraints and who uses them and reporting of them.
Absolutely. I couldn't agree with you more. And finally, was a criminal complaint ever made to law enforcement?
So because the agency failed to report, it was after the fact that we found it, we contacted a West Hartford police officer who has a son with autism, and he said the first thing they're going to do is want to interview your son. And so, but the thing I don't understand is people can kick a dog and get jail time, or, kill a bird or do other things. And yet you can get away with doing this to a individual with disability, the most vulnerable people in this community, and nothing is done.
It's a failure on so many
Big time.
systems. And this would be a big step forward to creating some more strict accountability for these services that, really jeopardize the well-being and safety of people like your son. So I'm very, very sorry that happened. I'm so glad that you came before us to, so hopefully we can create some change systemically, because it's not just that age.
The trauma's lifetime. We drove by the incident the place where it happened recently, and his head whipped right around. He will never forget what happened at that location. Never. And
Thank
neither
you.
will we.
Thank you. Thank you so much. Liz Gustafson, followed by Richard Famaglet. I know your name and now I can't get it. Sorry. Famiglietti?
Good evening. Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Liz Gustafson, and I am the Connecticut State Director with Reproductive Equity Now. I will note that we have submitted testimony in support of both HB 7022 and HB 7102, but I actually tonight want to take the opportunity to do something a little bit different and share some of my own story. Planning for the future that we envision for ourselves includes family planning. This means an individual's or family's ability to decide if, when, or how they want to start or grow their families. A few years ago, for me, that meant having an abortion because I did not want or plan to be pregnant, nor was starting a family a part of my plan at that time because I was 3 months into my new career and doing this with all of you. And now for me, that means exploring more family planning options as I am currently a patient that is navigating and accessing family building healthcare via the fertility preservation process so that in the future, I can hopefully start or grow my own family. HB 7022 is a critical and meaningful step in the right direction towards increasing equitable access to family building healthcare, which is essential care for so many people in our state, whether we are enrolled in private insurance or in Husky Health. There have been incredible medical advancements in assisted reproductive technologies and fertility care and treatment. And for folks, including myself, along with many other individuals and their families, the ability to plan for and build families remains out of reach due to exorbitant out-of-pocket costs and lack of insurance coverage. I know firsthand what it feels like to try to plan for the future to the best of my ability, while also carrying the difficult knowledge that quite literally any day now, I am likely going to be denied coverage for my elective fertility preservation. At the same time, as a currently single 32-year-old with endometriosis looking ahead to the future, it is not out of the range of possibility I will also likely be denied coverage for that fertility care down the line. Cost and insurer should never be a barrier to starting or building a family, and passage of HB 7022 is a matter of economic and reproductive justice. We are proud that Husky currently covers prenatal and postpartum care, and it's essential that Connecticut takes this critical step to also ensure that folks on Husky Health can access the reproductive technologies and healthcare that many people need to get pregnant in the first place.
Your time is complete. Please summarize.
We must ensure that every individual and family has equitable access to the coverage and care needed to make decisions about whether or when to parent with necessary resources, support, and dignity. And thank you so much for the time.
Thank you so much for continuing to share your story, which is vitally important for our understanding. So thank you so much. Have a great evening.
You too. Thank you.
Next is Richard Famaglietti, followed by Chris Gallagher. Did I do it?
Good evening, Human Services, and yes, you got my name right, Representative Gilchrist. I'm here to speak in support of Bill 7106 for the wheelchair repair. It seems that since the law was passed last year, things have gotten worse, at least for me and New Motion. I hear that National Seated Mobility is doing better, so I may switch. Earlier, we saw that Wayne wasn't in favor of any consequences pertaining to if they don't meet the timelines for getting the repairs. Well, that's like saying, let's not have any fines for people who run a stop sign. In good faith, we got this bill passed last year. It was a good bill, but just weak because there's no consequences. And that was all on good faith. So now that good faith is ruined, we need those protections and those additions that my fellow advocates had spoken about. At a time where our governor seems to want to declare war on people with disabilities on Husky C, I know our legislatures are going to pass this bill to further protect us in order to get our wheelchairs repaired in a timely manner. Thank you.
Thank you, Richard, for your testimony and for being with us tonight and for bearing with us as we bounce a little bit around the agenda. We really appreciate your testimony and your persistent and thoughtful and forceful advocacy on behalf of people with disabilities. Are there questions or comments from members of the committee? Seeing none, I hope you have.
Oh, you know what? I'm sorry. I needed to add one more thing.
Okay, go right ahead.
And I forgot. Yeah, the long wait got me a little screwed up. So during my wait for my last parts, I'm speaking to a New Motion rep, and they said, "Gee, you're telling me my back cushion is out of stock, and the manufacturer can't get it to me. But I can order that part from Spin Life, which is an online wheelchair parts store." And that person told me, "Oh, well, that's our sister company. We own it." So I'm like, "Well, why can't you get what I need from the company that you're in partnership with?" "Oh, because they don't take the insurance." So I go on Spin Life's website tonight, and they advertise how they're in partnership with New Motion. And guess what? They do in-home repairs. Of course, it's all private pay. So every time there's a delay in terms of parts, maybe it's because all the parts that New Motion is saying they can't get is sitting in Spin Life stock. I don't know. Just doesn't make any sense to me. Thank you.
Thank you. Next, we have Chris Gallagher, followed by Kenton Hinkins, followed by Amy Romano, followed by Dr. Jan Ponce.
Thank you, Senator Lesser. I'm Chris Gallagher. I'm the public policy consultant for the Obesity Action Coalition, Obesity Medicine Association, the American Society for Metabolic and Bariatric Surgery, and the Obesity Society. We would like to, express our concern and confusion over the committee's consideration of Senate Bill 1421, which would only allow the state Medicaid program to cover generic lower-cost GLP-1 medications to treat obesity or diabetes. We find this legislation problematic, given that the Connecticut General Assembly has already approved and Governor Lamont signed into law Public Act number 2394, policy that already provides coverage for FDA-approved obesity medications for state Medicaid beneficiaries effective July 1st, 2023. However, DSS has not yet implemented coverage for these critical medications more than 20 months after this law has taken effect. We're also deeply troubled by Governor Lamont's budget proposal, which would eliminate coverage of certain weight loss drugs when prescribed for obesity only. We can only assume the governor is alluding to the newer GLP-1 medications. In addition, DSS is now proposing a Medicaid state plan amendment to CMS that would limit Medicaid coverage to generic medications such as phentermine and orlistat, drugs that were approved more than 25 years ago. The through line of SB 1421, the governor's budget, and DSS's proposed SPA seem to indicate that state policymakers are applying a double standard when providing Medicaid beneficiaries access to the latest and most effective obesity treatment avenues compared to those for patients with other chronic disease states such as diabetes, heart disease, or cancer. Think of limiting patients with type 2 diabetes to only metformin or limiting cancer treatment to only methotrexate. Such an approach would be met with outrage, yet policymakers seem fine with such a strategy for patients with obesity. As a nation, we must stop evaluating coverage of obesity care through a cost-only lens. This approach is biased and unethical. The goal of healthcare is not to save money, but improve the health and well-being of people. We urge the General Assembly and Government Lamont to require DSS to follow the 2023 law and open access to all FDA-approved obesity medications. And I have to say, we were the most proud of your intern, Sarah Makawicki. I think I'm butchering her name, but that is a lived experience. And she was so powerful in her comments before the committee. And I think you're going to see more people stepping up because people understand that they have a right to treatment. Thank you, Senator Lesser, for your leadership on the legislation in 2023. Thank you for Vice Chair Gilchrist for voting for this legislation, and we hope DSS will take action to implement the law as written.
Thank you, Chris, for testimony. And I do want to say, I believe there was a drafting error, and I don't think the intent of the legislature is to limit the bill to generic GLP-1s. Are there any comments or questions from members of the committee? If not, thank you for your testimony this evening and look forward to continuing to work with you. Next, we have Kenton Higgins, followed by Amy Romano.
We do not have Kenton Higgins.
We don't have Kenton Higgins. Do we have Amy Romano? Yes, we do.
Hi, I'm here. Thank you, Senator Lesser and Congresswoman Gilchrist and all of the distinguished members of the committee. I'm Amy Romano. I'm here in support of Bill 7102, an act concerning maternal and infant care. As a midwife and a national expert in maternal health systems improvement, I've dedicated my career to expanding access to high-value evidence-based models of care. I'm an active member and past president of the Connecticut affiliate of the American College of Nurse Midwives and a board member of Health Equity Solutions. I'm here speaking on behalf of myself and on behalf of my company, which I'm the CEO of Primary Maternity Care, which is a Connecticut-based consulting firm that works nationally across sectors to strengthen community-based maternity services such as doulas, birth centers, and midwifery-led models, and to better integrate them with the hospital systems. We were the primary consultants responsible for operationalizing the doula integration in the maternity bundle under Husky, and we've also just recently assisted Women's Health Connecticut with their first licensure of the first birth center in the state. So I'm excited to speak to you about those two components of this bill. First, with the birth center sustainability aspect, the bill directs the Office of Health Strategy in consultation with DSS and DPH to develop a strategic plan for expanding birth centers and hospital-based services in underserved areas. This is a step in the right direction, but Connecticut honestly needs a statewide birth center sustainability strategy that acknowledges that birth centers are not financially viable under the current Husky reimbursement structure, regardless of location. Hospital maternity services are funded through a diagnosis-related group system, while birth centers operate under a different rate structure and need a different, their financial viability requires different Medicaid payment solutions. So while the state undertakes an overarching strategy to explore regionalization of hospital services and coverage of rural and underserved areas, it should not delay in making immediate payment adjustments to begin to realize the intention of the recent licensure laws and the temporary waiver of the certificate of need requirements, which was to increase access to freestanding birth centers and spur development of new centers to unlock the well-established benefits of this model of care, better outcomes, higher satisfaction, and reduced cost of care. The rates set for maternal care do not cover the costs of that care, and there's no current rate structure for newborn care in birth centers. Raising the Medicaid rate and instituting direct payment for neonatal care provided in birth centers would help sustain and expand birth center access for Husky members. The state should also make permanent the con waiver. Birth centers play a crucial role in addressing persistent challenges in maternal health, including racial and economic disparities, lack of access to primary maternity care, and the rising cost of hospital-based obstetric services. My 2021 report, Getting Payment Right, How to Unlock High-Value Care Through Appropriate Birth Center Reimbursement, outlines the critical need for Medicaid payment reform. To support financial viability, I'm happy to work with DSS, DPH, and Office of Health Strategy to review the recommendations in this report and the opportunities to strengthen birth center infrastructure in Connecticut to bring our state in line with national momentum. Am I out of time? Oh, I heard a voice. I'll-
Apparently not. Go ahead.
Okay, I'll quickly speak to the doula piece. The bill proposes an increase in the doula payment rate within the maternity bundle. And while I fully support the ongoing efforts to ensure doulas earn a livable wage for critically important and highly valuable work, the payment rate is only one challenge to overcome to ensure Husky members have access to the doula benefit. Primary Maternity Care partnered with Health Equity Solutions, DSS, and CHNCT to survey the doula workforce in late 2022. Ease of getting paid was actually slightly more important to doulas around the state than the payment rate, and other factors were also critical to their interest and readiness to serve Husky members, including the availability of training and administrative support. The payment
Now your
method-
time is complete. Please. Thank you.
Can I just summarize by saying 2 years ago, we passed both of these bills. There's still exactly one birth center in the state, and there's still nobody in the state that has received Medicaid covered doula benefit. So we badly need to better operationalize these two efforts that are both critically important and highly, highly evidence-based. So thank you for your time.
Thank you for your testimony. Are there comments or questions? Well, we appreciate your thoughtful testimony and look forward to getting engaged.
I will send it through.
I'm sorry?
Yeah, I'm going to send it through. I have not yet sent my written testimony, but I will, including a link to the report that I referenced.
Got it. Well, we'll look forward to your written testimony, but we also appreciate your oral testimony just now. And we are very interested in what we can do to support birth centers and look at shortages in Connecticut. Other questions or comments from members of the committee? Seeing none, hope you have a wonderful evening. Thank you again. Next, we have Dr. Yan Ponson, followed by Sunindya Bala, followed by Jennifer Sparks. And if I am mangling anybody's name, I apologize.
Hello. Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and members of the Human Services Committee. On behalf of the Yale Child Study Center, thank you for the opportunity to support House Bill 7109, specifically provisions on intensive in-home child and psychiatric services, ICAPS. Sarah, and I'm Yan Ponson, a child psychiatrist involved in complex care and Vice Chair for Clinical Affairs. Sarah, name change, is a sweet child who has tried to die by suicide 3 times. She was in the intensive care unit, on the psychiatric inpatient care unit twice, and the emergency department 8 times. Her parents are working professionals, and she refuses to go to school and refuses to come to outpatient care. ICAPS, developed at the Yale Child Study Center, provides home-based psychiatric services for children with serious emotional disturbances at risk of hospitalization or who have been hospitalized or returning from residential care. This family-centered intervention aims to stabilize crises, reduce hospital admissions, and improve long-term outcomes. HB 7109's inclusion of DSS to review sustainable funding for ICAPS is essential for timely and effective community care. Recent increased Medicaid reimbursement and grants temporarily stabilized ICAPS network, pausing the wait list. But despite these improvements, demand remains high, with a wait list of close to 500 families, many of whom have been discharged from inpatient units or other high acuity settings. ICAPS is cost effective. A 6-month course costs about the same as a 12-day psychiatric inpatient stay. And without community-based services like ICAPS, children risk repeated hospitalizations. And service amelioration is still needed, particularly in areas that are underserved or not served, which are meant to be served. Areas like New London and Windham counties, which are care deserts for this service. Establishing a Medicaid billing code would address initial clinical staff training costs, as it takes quite some time to onboard clinicians with these highly complex families. And these are the most complex cases in the community, bar none, and clinical training and support is required. So in sum, we urge support for HB 7109 provisions related to ICAPS to address the mental health needs of vulnerable children and families. And I thank you for your leadership in strengthening and saving behavioral health services. We look forward to continuing to work together. Thank you so much tonight.
Thank you for your testimony, and we appreciated learning a lot more about ICAPS for the last couple of years. Representative Comey has a question.
Hello, Dr. Ponson. How are you?
Hello.
Thanks. I have seen you testify before. What was it in the Children's Committee, or what was the what else is this the same? Is this a different bill in a different committee? I'm just
This is a different this different bill. Yeah, in my role at the Child Studies Center for Clinical Affairs, I will testify for a couple of actions. So I'm also a co-chair for the services work group on the TCB. So I had testified in accordance with some recommendations coming out of the TCB.
Okay, yeah, I think I saw
Yeah,
you.
Medicaid reimbursement was a big one.
Okay. Well, thank you for your attention to all that we're doing up here and of course to our kids.
No, I appreciate all the work you're doing. Thank you.
Any other comments, questions? Seeing none, thank you for being with us this evening. Next, we have Sunindya Bala, followed by Jennifer Sparks.
Thank you. Dear Chair, hello, Chairs Lesser and Gilchrist and members of the Human Services Committee. My name is Sunindya Bala, and I'm here representing ROCA, an organization supporting over 100 young women and mothers ages 14 to 24 in Greater Hartford. These women face chronic trauma, violence, disengagement from education and employment, and lack stabilizing supports. Many are involved in the healthcare, child welfare, and criminal justice systems. ROCA works with young women to leave violence on the streets, break unhealthy relationships, and begin healing past trauma by changing behavior and building critical thinking and emotional regulation skills to help them achieve safety and stability for themselves and their children. I'm here to express support for House Bill 7104, an act concerning programs to mitigate the benefits cliff. This critical legislation encourages participation in job training programs that offer employment stipends by mitigating the effects of these programs on beneficiaries of public assistance. Most of our participants are eligible for public assistance, though few are accessing them when they're referred to us due to barriers such as lack of address or documentation. Following enrollment, 59% of our mothers not previously accessing childcare began utilization, and 29% of participants not previously on food stamps obtained this benefit. They need these stabilizing supports to stop relying on dangerous and sometimes illegal means of earning money to support themselves and their children, and to successfully engage in programming. ROCA's model includes a transitional employment program, offering participants real pay for real work, while teaching those who've never worked or successfully held a job what it means to work, practice soft skills, and navigate transportation and childcare, all in a supportive environment. However, they still need public assistance to financially stabilize and pursue employment placement and retention. The benefits cliff creates a significant barrier for participants because even with limited earnings, they exceed the income threshold for their public assistance, and this loss of benefits acts as a deterrent to participation, ultimately impacting their long-term stability. Take Moya. Referred to ROCA by probation at age 17, she was a victim of trafficking, homelessness, and young parenthood. Through her participation in transitional employment, she found a sense of purpose, stability, and hope. She completed her high school diploma, gained citizenship, and secured her own apartment. These were all milestones made possible by her involvement in the program. I'm also representing a newly formed collective of 7 youth-serving organizations across Connecticut who are working together to support over 1,500 disengaged and disconnected youth, and we have submitted written testimony collectively. We are requesting you to support passage of this bill to support our efforts in successfully fostering self-sufficiency among young people across the state. By allowing these young people to maintain benefits while simultaneously working towards workforce growth, we can alleviate economic hardships and support our communities. Thank you for your consideration of this important issue.
Thank you so much for your testimony. It's good to see you again. Just a quick question. Have you submitted written testimony to us?
We have. I have, and the other organizations have, along with the cover letter. So we have submitted that.
Okay, great. I didn't see it on the system, but I'm sure it'll be posted soon. Are there questions or comments from members of the committee? Seeing none, thank you for your testimony and thank you for ROCA's work.
Thank you.
Next, we have Jennifer Sparks. Is Jennifer on? No, Jennifer. And then after Jennifer, I believe the next one is Tanisha Signore. After Tanisha, we'll be hearing, I think.
Oh, no, I'm here. I'm sorry.
That's okay. I'm just making a quick announcement. After you, we're going to hear, I believe, from Leslie Wolfgang, followed by Gary Gilberti.
Apologize if you hear a baby screaming in the background. Thank you for letting me testify tonight. My name is Tanisha Signore. I'm the policy director at She Leads Justice, formerly known as QUELT. And I'm here today. My written testimony has a few different bills in it. I'm going to talk primarily about HB 7022 today, and Act promoting equity and coverage for fertility healthcare. We believe healthcare is a human right, and all people, regardless of their gender identity, sexual orientation, age, race, ethnicity, income, disability status, or relationship status, deserves access to quality and affordable healthcare. This includes reproductive care and, more specifically, fertility care. HB 7022 will improve access to fertility care for people who have Husky health insurance, a population which has been historically excluded from accessing fertility care due to the high costs. Importantly, this bill aligns with the medical standard of care, which clearly includes LGBTQIA+ and single people. This bill is a critical step in ensuring all Connecticut residents can access the care they need to build their families. Equitable access to fertility care is a serious health and economic justice issue. And as a leader in advocating for marginalized women and girls in our state, She Leads Justice fervently supports Planned Parenthood of Southern New England and Reproductive Equity Now in the important work of securing these basic rights. It is important for us to consider race when we examine our statutes' effect on the people who live in Connecticut. Our current state's law disproportionately impacts our Black and Latino residents who are enrolled in Husky at higher rates. This is especially significant within the topic of fertility because Black women are almost twice as likely to suffer from infertility as white women, but they are only half as likely to receive fertility care. This reality is due to a combination of factors, including coverage type, coverage rates, availability of services, hesitation due to a long history of discriminatory practices on women of color, and more. Connecticut considers itself a leader in reproductive rights and a champion for women, children, and families. To rightly assert that title, we need to pass policies which invest in equitable services for marginalized populations and break down barriers so all our residents can access these services and live the lives they desire and deserve. I'd also like to just quickly say that we are also in support of HB 7101, HB 7102, and HB 7104, but I imagine that I'm running low on time, so I won't get caught up reading my testimony for those other three.
You have 18 seconds.
Yeah, I don't have enough time. I got 3 full paragraphs, not enough time, but thank you.
You don't have to use all 3 minutes.
Instead of getting booted out mid-sentence.
Well, thank you for your testimony.
Thank you, guys.
We really appreciate it. Any questions or comments from members of the committee? Seeing none, thank you. Have a good evening. Next, we have Leslie. Actually, no. Next, we have. We don't have Leslie Wolfgang, so we're going to go to Gary Gilberti, followed by Corey Lee.
Good evening. Thank you, Senator Lesser. Thank you, Representative Gilchrist and members of the committee. My name is Gary Gilberti. I'm the Executive Vice President of the United States for New Motion. New Motion provides mobility devices to people with disabilities throughout the United States with one location in Rocky Hill, Connecticut. I appreciate the opportunity to speak tonight on behalf of our company regarding HB 7106. Since the inception of the Wheelchair Repair Task Force in 2023, New Motion has collaborated with consumers in hopes that we could find a common ground on how to improve service and repair for complex rehab wheelchairs. While we did not agree with the need for legislation, we have continued to work diligently to shorten timelines and ensure quality. As part of our effort to reduce wait times and increase efficiencies, we've made several investments and will continue to do so. Here are some examples. We use technician routing software that increases the number of stops that a technician can make in a day. And that helps us be more efficient, and that helps us serve more customers every day. That equals lower turnaround times. We've offered an in-shop service option, and as you've heard, some people have not been happy with that, but in general, most of our customers enjoy that option. It allows us to complete many repairs in one visit within our location, and it just offers convenience to some customers. It's not for everybody, and we don't demand everybody to do it. The next was remote service technicians. And this is a video technology where a customer can call in, and if we can access their phone or they can access a phone, we can, through virtual technology, assess the situation and try to resolve it. In some cases, we fix it while on the phone. In other cases, we dispatch a technician, but a lot of times it eliminates one visit. So that in itself also minimizes days. We've implemented a talk desk phone routing system, and that is a faster handling of incoming calls, routing customers to the correct team member, and also getting to the right team member who might be handling the order. We did this all recently, so there might be some issues in the past with our phone system and with our incoming calls, but we've addressed that. We've also implemented a new inventory system from Microsoft, and this allows visibility in parts across all of our locations and the ability to pull parts from within rather than from a manufacturer, saving days of shipping. Now, I know Mr. Fabrighetti mentioned that our sister company, SpinLife, had the same part on their website. They also have to order it. They do not stock it. So I just want to be clear that it wasn't an issue of them stocking and us not. So moving on, we have initiated in the last 60 days stocking the 75 top most used parts. That's about 80% of the parts that we use to repair wheelchairs. And that offers us the opportunity to fix chairs in a single day or a
Your
single
time
visit.
is complete. Please summarize.
Okay. In summary, I'd like to say that we support parts of HB 7106, but some of the ones that we do support, the state will not have the funds to make a reality. In its totality, HB 716 will create unrealistic requirements on providers, and provisions suggesting punitive measures for failure to comply do not sufficiently accommodate the complexities we face on a daily basis. So that said, we respectfully oppose the bill and would like to continue to work further with the committee to improve the process and get better every day. Thank you for your time.
Thank you for your testimony, and we look forward to continuing to engage with your company and the industry on improving the customer experience. Are there questions or comments from members of the committee? Seeing none, thank you for being with us tonight, and have a good evening.
Thank you.
Next, we have Corey Lee is on. After Corey, if Amy Lavoie is on, I don't see her. If she doesn't jump on, we'll go to Karen Buckley.
All right, good evening, and thank you for allowing me to testify on my experience with wheelchair repair. My name is Corey Lee, and I'm the peer mentor coordinator for More Than Walking. I work closely with Jonathan Sigworth, and last year I had the opportunity to perform at the Capitol in advocating for the passing of PA 2458. I'm also in the process of becoming a part of the Silk Board of Directors, and I also work with the Wheelchair Reform Coalition. I'm grateful that the law has come into effect. However, we're not done yet. As our motto we chanted last year, and we really want to see that people in wheelchairs and scooters have barrier-free access to the community because they need fully functional and operational wheelchairs. So I've been a wheelchair user for nearly 20 years. And as a naval veteran, my experience isn't that different from many of the other individuals who have testified. The only difference is I'm a service-connected vet with access to resources that many do not. But the need for swift repair is needed even within the confines of the VA. So I come here this evening in support of HB 7106. There are many reasons to perform repairs at home, and that's really what many of us are just advocating. Many shops close by the early evening or late afternoon. So for wheelchair users like me who have care being performed during the early morning hours, late afternoons might be their only option, which may give little time for the repair to be actually done or completed. And they may be subjected to changing that routine in order to make an earlier appointment, like skipping bowel care or bladder care, which that change could lead to issues which would further prevent them from reaching that appointment in a timely manner. Secondly, even if you don't have the ability to travel, maybe like with public transportation, but you have your own vehicle, in my experience, many caregivers don't have a license to drive. So how would a person like me, a high-level quadriplegic who isn't able to operate a vehicle, get to a shop to have these repairs completely? And lastly, and full transparency, while I don't currently use NSM or NuMotion, but maybe the VA will use them for wheelchair repair. Advocacy isn't limited by what you use. It's about supporting the greater needs of others. The current tech I work with through the VA is one person. He travels throughout the state and performs the repairs primarily in the vet's home. He's easily accessible in terms of communication when issues have arisen where a part was ordered that wasn't correct, which is not on him, but usually through the companies. Because the repair was done at my home, I didn't waste my time or my wife's time trying to travel. And this isn't about telling these companies how to run their businesses. This is about how they can improve the quality of their services because they're in an industry meant to serve the vulnerable population groups that I belong in. And with that being said, I'm appreciative of what is being done to try to mitigate the issues of timeliness repairs.
Thank you for your testimony. It's good to see you again. I know that you are an impassioned supporter of people with disabilities. I think I see a hand up from Representative Fortier. Oh, maybe not. Oh, okay, maybe not. Are there questions or comments from members of the committee? Seeing none, good to see you this evening, and you have a wonderful evening.
You as well. Thank you.
Next, we have, is Amy Lavoie with us? No. Karen Buckley, let's see.
Good evening, distinguished members of the Human Services Committee. My name is Karen Buckley. I'm the Vice President of Advocacy for the Connecticut Hospital Association. CHA appreciates the opportunity to testify tonight in support of Section 2 of House Bill 7108, an act concerning autism and intellectual disability. Section 2 would create a statewide coordinator to serve as a liaison with the hospitals that care for patients with autism spectrum disorder or with intellectual or developmental disabilities. The liaison will coordinate and consult with agencies that serve individuals with these conditions and diagnoses and help hospitals navigate the difficult course of ensuring patients are discharged to the appropriate setting of care as soon as practicable. CHA and Connecticut's hospitals have been working for several years now with various state agencies, including the Connecticut Department of Developmental Services. And we're working with the legislature to better address the needs of complex patients, including those with intellectual and developmental disabilities, as well as behavioral health patients. There's an urgent need to increase the availability of community-based beds and resources for these patients who otherwise often get stuck in hospitals when their needs would be better served in a different care setting. At the request of the leadership of this committee, in January, CHA surveyed our hospital members at the point in time to assess the number of stuck or difficult to place patients that were present in each hospital. At that moment in time, more than 200 patients who are clients of or accessing services from the state were stuck in hospitals. And in my testimony, I lay out the number per agency. Some patients have more than one agency involved in their care. In addition to those numbers, we also had an additional 100 patients who were stuck in hospitals due to complex medical needs that made placement in post-acute care settings difficult or nearly impossible. These conditions include the need for ventilator care, dialysis care, a combination of ventilator and dialysis care, behavioral health services, and other complex needs. The lack of appropriate care settings, too few community or specialty facility beds, and frequent delays due to the limited agency resources or probate court proceedings converge to create a domino effect that significantly reduces the timely throughput at hospitals. Many patients do not need hospital care, but are unable to return to their homes, which in turn backlogs emergency departments, reduces capacity at the hospital for other patients, and drains resources unnecessarily. Stuck or difficult to place patients often measure their time in hospitals in weeks, months, or even years, rather than what you and I would measure them in days and hours. So just want to say that one more time.
Please summarize.
So these patients sometimes get stuck in hospitals for weeks, months, or even years. And having a liaison is a welcome step that will hopefully have an immediate positive impact in assisting hospitals to place patients in the right setting of care as soon as possible. And we appreciate the committee's efforts to look at this as a part of a solution. Thank you.
Thank you, Karen, for your testimony and for being with us tonight. I do have a question about it. I would imagine that warehousing someone in an acute care hospital is just about the most expensive possible setting. Is that, who pays for that?
So it depends on the level of care, and if the patient is currently a citizen, but it is the state and the hospital or healthcare delivery system is what bears the cost. So when we're looking with the legislature to reduce the cost of overall healthcare, one of the key ways we want to look at doing that is to work with the legislature to ensure that a patient is receiving care in the most appropriate setting for them, and the best use of the resources we have. I think while there are cost implications, one of our main focus right now is the fact that patients are living in hospitals who do not need to be there. That is not the best place for patients to be living. They should be out in the community, in a place that can better meet all of their needs.
No, I understand that. And I
Mhm.
you know, obviously this is about patient care and quality of life, and people should not be in the hospital who don't need to be in the hospital. But when we go into our agencies, most of whom are our human services agencies, most of whom are Medicaid funded in Connecticut, we ask them to expand their capacity, they always point to budget constraints. And so that's why I was really interested in the,
correct,
presumably particularly if it's cheaper to care for somebody in a more appropriate setting outside of a acute care hospital, there should be some way to budget for that. So I'm just curious, in your test, I haven't had a chance, I apologize. We got a lot of testimony today. I've not read your, well, actually, I did read your, it's not true, but I didn't understand from it how the full breakdown, and maybe there's an appendix that I haven't seen, but just an understanding how we could break down the cost to sort of price out potential alternatives. I think that would be helpful. Maybe that's beyond the scope of this bill because we're just talking about coordinating, but I would love to figure out a way to understand, how much money we're spending and potentially redirect that to a better place.
Yeah, we'd be happy to work with you outside of this hearing to try and help quantify those numbers for you. I think a number of our hospitals can put that information together for you.
Great.
Happy to work with you on that. Thank you.
Sounds great. Good to see you. Have a wonderful evening, assuming
You
there
too.
are no questions from members of the committee, and it doesn't seem that there are.
Thank you.
Take care. Next, we have, I don't see Laura Devanzo on. I don't see Liz DuPont Deal on. So we're going to go to Cynthia Brahani. Good evening.
Hello, and thank you for having me today. I'm testifying to oppose HB 7022. These treatments are a terrible idea for children and teens with gender distress. Identity in youth is fluid. This is an empirical fact. No organization can define gender, as it is also fluid. Yet irreversible procedures are being pushed on minors who often desist by adulthood if medically untreated. Jamie Reed exposed cases of girls suffering painful ovulation drug effects and boys undergoing testicle relocation to prevent puberty and attempt to preserve fertility. If gender affirmation were removed, would you still consider these experimental procedures on mentally distressed yet otherwise healthy children humane? These procedures often fail, causing lifelong damage. Even Chase Strangio of the ACLU, a trans advocate, testified before SCOTUS that there's no evidence affirming procedures prevent suicide. New studies, including one from the Journal of Sexual Medicine, show these interventions increase suicide risk and mental health decline. This is futile healthcare and iatriogenic harm. I once believed I was meant to be the opposite sex. I was wrong. Many of my friends believed the same, and they were also wrong. The growing number of detransitioners exposes this as a medical scandal. How many more lives must be shattered before we acknowledge this? Meanwhile, real medical needs would go unmet. Can you justify diverting taxpayer funds from children with leukemia or chronic illnesses? My Cuban immigrant family relied on Medicaid to save my sister's life. If healthcare had treated subjective belief as medicine, she may not have survived. This bill is fiscally reckless because gender identity has no medical definition, meaning anything can be gender affirming and funded without limits. These procedures are experimental with no standardized coding, creating a financial black hole. Detransition care alone will become an expensive liability and open the door to wrongful death lawsuits. Should we fund liposuction for anorexia or chemotherapy for factitious disorder? These may sound absurd, but not long ago, so did state-funded medical transition for children. This bill will facilitate harm, sterilization, and wrongful deaths at taxpayer expense. Remove gender from this bill. No one is infertile because of gender dysphoria. They are infertile because they were sterilized in the name of gender-affirming care. That's my time.
Okay, thank you for your testimony. Are there comments or questions from the committee? Seeing none, have a good evening. Next, we have is Stacy de Moronville on?
The only person remaining is David Morgana, who has not
Okay.
accepted promotion to panelist.
David, can you please accept promotion to panelist?
He just did.
Can you hear me?
You can.
Okay. Hello, members of Human Service Committee. My name is David Morgana. I had a car accident 28 years ago, which resulted in a spinal cord injury. In the past 28 years, I've used power wheelchair, power assist manual wheelchair, and currently a manual wheelchair. I'm a longtime disability advocate. I've been involved with the wheelchair repair issue from the very beginning. I participated in the wheelchair work group, which then transitioned to the wheelchair repair task force, and currently serve on the wheelchair repair council that I was formed last year. I use New Motion for my wheelchair repair needs. There is also a second company currently known as National Seeing Mobility. So based on market share, a duopoly exists in our state in regards to wheelchair repair. Ever since the private equity controlled company New Motion has come into existence, customer service has dropped off a cliff and has not recovered. The discussions with the industry started around 2.5 years ago in the wheelchair work group. We told them then, and we continue to tell them now, they need to increase staffing levels. I don't know how many times this needs to be said, but I'll say it again. They need to increase staffing levels. They simply don't have enough technicians on the road doing in-home repairs. The industry has repeatedly given excuses that it's hard to find qualified candidates to hire or pass background checks. I believe the starting hourly rate being advertised is $21 per hour. People are getting paid equal or more to work at McDonald's. In my opinion, the industry is not being realistic in what they are offering for compensation. They are also having problems with turnover and losing existing staff to other companies offering better compensation. According to the data reported in the last Wheelchair Repair Council meeting, National Seeing Mobility's compliance numbers have improved to the 80% range, but still need work. However, New Motion's compliant numbers are terrible. They reported a 37% compliance rate, absolutely unacceptable. Also, according to the company's, National Seeing Mobility has around twice as many technicians as New Motion has, which partially explains the difference in compliance levels. As for a personal story, I've had repairs done in my home several times since the new law went into effect, and New Motion has been in non-compliance of the law every time. So for me, New Motion has a 0% compliance rate. I've also filed complaints with OHA. I can't help but feel New Motion has been manipulating wheelchair users by offering in-shop repairs in a much shorter time frame within a week versus a month for an in-home appointment. Recently, a newsletter was sent out by New Motion telling their customers it is quicker to come into the shop to get repairs done. This is not new. New Motion has been using this tactic for a while now to get consumers to come into the shop to get repairs done. Although accurate, it is an example of manipulation by the company to get consumers to come into the shop because it saves them money. Also, when you call the customer service line, the phone representatives ask you, when can you come into the shop to get repair done? They actively ask you first and do not mention in-home repairs in the beginning of the conversation. This, I believe, is a continuation of pressuring, manipulating, influencing the customer to come into the shop for repairs.
Your time
The-
is complete. Please summarize.
The industry has come out against Bill 7106 that legislation isn't necessary and say that things are improving. Give us more time. We will do better, we promise. I've heard this same thing said for a long time now. I just don't believe them. I don't believe they will improve and come into compliance with the enhancement of the law passed last year. HB 7106 will improve current law in several ways, including enforcement mechanisms, informing consumers of their rights, and holding the industry accountable. I urge everyone to support HB 7106 and continue what we started. The work is not done. Hopefully this bill will get us closer. Thank you.
Thank you, David. It's always good to see you or hear. We didn't see you, but it's always good to hear from you. And really
Thanks, Matt.
appreciate your participation on this. Are
Thank
there
you.
comments or questions from members of the committee? Seeing none, I think that concludes our public hearing today. We will be back for more, a lot more on Tuesday. And that will be our final public hearing of the year, at least the one that's scheduled. And then on Thursday, we will have a committee meeting. So with that, hope everyone has a wonderful night. Enjoy yourselves, and we will see you very soon.
Thank you, Mr. Chair.